Today we have just 1 minute. Dr. Madra is going to present how to cannulate, selectively cannulate. So Dr. Madra, please.
So a very good morning to all of you. So starting off with my presentation, thank you so much, Dr. Ramesh Ruprai and Dr. Sandeep Nijavan and the whole team for having me here. So first of all, I'd like to bow to all the masters of ERCP, right from Peter Cotton, Nib Sohindra, Meinhard Klassen, and also to my own guru, Dr. VGM. So this is a patient who was rolling in pain and amylase and lipase was elevated. And you can see here cannulation has finished the ERCP, just releasing the stone. Let's see what Professor Jeffrey Lee had to say about ERCP. He said it's like playing a musical instrument and to persist until the sound is just right. So it is not just a learning, it is also a feel. And the first step is reducing the scope. Coming to the shortest position is very important. And I know that it's not possible in every case, but coming to the short loop position will give ideal, passage of the accessories and best control. And so we need this hockey stick position, and the others are semi-long, long, and short routes, but we need only this position at 60 centimeters. The first thing that a candidate has to learn is to forget the forward scope, eye-hand coordinations, because it's an entirely different video game with different accessories, right? So this is what helped me in the initial phases to forget that I'm not doing a forward scopy. And so when the scope is at the D2, you should remember that it's in a J position and all the movements are different. Up, down moves up towards, and also the axes are going up into the CBD, and away, down is away. And right, left is not exactly right, left, but more of a torquing movement. And there are more things to do, like pushing the scope in, pulling the scope out, shoveling, dipping down, pushing the accessory in, moving your body, moving your shaft of the scope. There are so many moments, and the most important moment, the elevator. So coming from below upwards, this is the frenulum, papilla, hood, and infundibulum. Take your time to study the ampulla. These are the different types of ampulla. And can you guess which is the ampulla which is most difficult to cannulate according to studies? It is this one. The smallest one is the most difficult to cannulate. And this one is called a Sharpei appearance because it looks like this dog. You can see the folds on the dog. So, and this one has the most risk of post-ERCP pancreatitis. And NBI also can be used to identify orifice. Sometimes it's very difficult to identify the ampulla in a periampullary growth. But we should be really gentle because any trauma, you can cause a bleed and it'll become even more difficult to identify the ampulla. So ideal position of ampulla, once you've identified the ampulla, keep it in the left upper quadrant because that is the place where the accessories are going to come in. And one more, just a review, like sphincter of ampulla, this is sphincter choledocus and sphincter pancreaticus. But if you see, there is a long common channel in 85% of our patients and a V type and a U type. With U type doesn't have a common channel. That's in less percentage. If you see, this is like a steep hill if you want to go up the CBD, whereas the PD is more shallow and more direct. And also the CBD is in the 11 to 12 o'clock, and this pancreatic is 1 to 4 o'clock. But most important is to observe your guru doing it, observe and observe, because you need to memorize the 3D video of it rather than the 2D, because you're only looking at 2D, whereas inside there are multiple movements going on. And these are the CBDs which people practice in before they go into see the patient. So remember, the initial portion is like a steep hill. Keep the elevator up, big wheel towards you with a bowed sphincterotome. And these are the different sphincterotomes. long nose is the most commonly used one. There is also short nose, a no nose, noseless for all the experts to do noseless sphincterotomy, and there's a reverse cut for the biliary, which I'll be showing. And there are angled, straight, loop, and J-type guide wires, which are all hydrophilic, and hydrophilic has been proven to be the best to cannulate, vesiclite, pteromo, jaguar, whatever you want to call it. And in studies, angled tip won over the straight tip in this one study where they see it can help in maneuvering. Even if the tip hits against a place, it will fold and go inside. So that is very important for an intrarectal stricture. So yeah, we do not, in our unit, we are totally against contrast assisted, because if you fail, you are going to introduce pancreatitis and cholangitis. So we want a guide wire directed, which has been proven in all meta-analysis to reduce PEPs and increase the cannulation success. But which one to go first, guide wire first or sphincterotome first? We go for the sphincterotome first approach, where the sphincterotome is wedged 1 to 3 millimeters in the correct direction, and then the guide wire is advanced. So the whole thing is to kiss the ampulla. And inside, once the sphincterotome is wedged, you should remember that it's not a straight path. It's like is S bend, papilla up, duodenal wall straight, and CBD up. So initial part, a full bowed sphincterotome going steeply upwards, relaxing the bow, going to the horizontal direction, and then doing the shoe horn. So what is this shoe horn? So you have to pull up the scope slowly towards you with the up-down knob towards you, slowly as the sphincterotome slips inside. And once you're in this position, your nurse should start to try. They should not try before you get into this position. And they should do something called a door knock, where you have to just touch, and move, push, go in, go out, go in, go out, and not push. So when you're in place, you have to start making minor movements till you get a give way feel. So revising it, a shortest hockey stick position, ampulla in left upper quadrant, and point of contact, 11 o'clock trajectory, sphincterotome wedged, shoe horn, angle pteromo doing the door knock, and small movements with both knobs moving slowly. So let's see all this in action. So first, going into the complete reduced position. This is very important. I know that all cases you cannot do this, and of course you can cannulate in a long or semi-long position. And first thing to do is to study the ampulla. Not only this, and what I'm doing here is I'm pre-curving the sphincterotome and then introducing it inside. So that's important. It happens naturally when we do it. So here, this looked like a growth, and we have to study it with NBI, flushing it with water, studying it. And next is the positioning. Before positioning, one very important thing is to see the angle in which it's coming out. You can see it's directly this way, right? So you have to study it, go to the top. Take your time before you cannulate. This is the direction. Because once you start to cannulate, you will not be able to see which direction you have to go. So finished noting that and keep it in the right position and introduce it. End on, face on, perpendicular to it, and then change the direction slowly so that it goes into the 11 o'clock. Never push. We should never push, because if you push, you're only going to a wrong path and you're going to have a false tract. And now once you're in position, do the shoe horn, where you're pulling the scope slowly towards you and with the up-down knob towards you, and slowly you can slip into the angle, and there you know it's in the right angle. Then you ask them to pass. See, the wire is in without any difficulty. That's all it took. Actually, it's quite an unedited video. So this is the new CD technique for cannulating a very protuberant ampulla. So what do you do? This technique says that the CDs can be positioned along this imaginary, you can imagine these kind of CDs, and the wire goes through them, through the center. For example, this is the ampulla. So this is a wrong position because this is pointing this way, the sphincterotome, whereas this is the direction in which it has to point. So you bring it slowly to that direction, slowly change the axis. Now a little better, but not enough. Can you note that this is going this way? Now it's going end on. This is the good position, but not good enough. So even when somebody else is doing, you should be giving yourself this feedback. Now, still, if you pause here and see, this is the angle in which the wire is going to go, but whereas you want to go this way, right? So you have to change the trajectory again. So how do you do that? By slowly directing the sphincterotome to that angle. Now you can see it being done so beautifully. Yeah. Now you know you're in the right direction, you can start trying. So this is the same summary of the same thing, going into the right position, not kinking, because once you go into the wrong trajectory, you're only going to create more edema. And now, pregnant ampulla is the perfect time to practice a sphincterotomy with pregnant with stone and, practice a needle knife. If someone wants to try a needle knife for the first time, it'll be the best to do it when there is a pregnant ampulla because you are protected by the stone and you have to do it anyway for the stone to come out. You can see a very good delivery there. And so this is the position for a needle knife. So studying the ampulla is again important there. So here we've tried with a regular thing and then we went in for a noseless. After the pancreatic stent is there in place, it's not seen here, but after that we go in with the needle knife. You do little by little, gently, like paintbrush. You have to do it like painting the needle knife, very, very gentle and small depths. The depths should be very little, and then you should go layer by layer till you reach. And once you have reached some particular depth, you have to study, wash, and check if there's any bile flow. And you can see the duodenal flap being defined and a bulge here at 12 o'clock. And exactly when you identify the bulge, it's very easy to cannulate. Here again, in this case, you can see the white sheen, which is the CBD before puncture. You can note that over here. That is the CBD. So transpancreatic sphincterotomy is another technique where you can cut above the stent. And here this is window fistulotomy, which really protects. If you don't have a PD stent in place, this is the best fistulotomy to do. You avoid the ampulla. And of course, this is a patient where we tried twice and we couldn't cannulate distal CBD stricture due to pancreatitis. This is rendezvous where we are passing the wire inside. By this, we got into the PD and the wire, by the side of the wire, we cannulated and it was successful. Juxtadiverticular papilla. So papilla the ampulla can be inside the diverticulum, on the margin, or outside the diverticulum. General rules are when it's inside, it's generally the 4 or 8 o'clock position if you want to search. If it is on this, if there is a ridge between two diverticula, it will be at the end of the septum. And so that's how you identify. With juxtadiverticular papilla, it's difficult to identify, but not difficult to cannulate because the steep climb of the CBD is not there, and it's more of a gentle slope. So there are other techniques where you can do 2 devices in one channel, double endoscope, balloon dilatation of the narrow neck, endoclip assisted, cap assisted, or rendezvous techniques can be used. So this is a diverticulum at the margin. I will just show this case where it is helped with actually the cannulation was not possible because it was the angle was not good. So then we ended up clipping so that we could access it, and it changed the direction and we could cannulate them. And you can see the angle, it's not very steep. And so that's simple. We did get into the PD, but we could ultimately cannulate. So Post-GJ is another ball game where it's not very easy. The direction is different and you have to go in deep. So there, this rotatable sphincterotome and reverse cutting sphincterotome helps. So when things are tough, call a colleague. Please get a team with you. Teamwork brings success. And in a stable patient, try 24 to 48 hours. And it's been proven in studies that it really helps. And so to summarize, guide-wire cannulation with failed attempts 5 times. If you have a PD stent in place, try the transpancreatic sphincterotomy, but only for experts, and also needle knife only for experts. You can always do a rendezvous if it fails. So the art is long, but don't forget that you can always try after 48 hours. The art is long, life short, opportunity fleeting, experiment dangerous, and judgment difficult aptly applies to the art and science of ERCP. So thank you very much. Those are my references.
Elegant talk. Now I invite Dr. Itish to talk about the sphincterotomy. We can have questions in the end.
Very good morning, everyone. And I thank organizers for giving me this opportunity. The topic that has been assigned to me is sphincterotomy. So sphincterotomy is cutting a sphincter. So here we'll be discussing about sphincterotomy of the bile duct, pancreatic duct, and minor papilla sphincterotomy. So minor papilla sphincterotomy is a misnomer because there is no well-defined sphincter. So it is a papillotomy per se rather than a sphincterotomy. So there is a vast list of indication of biliary and pancreatic sphincterotomy. So that includes when we are planning a ARCP for CBD stone or pancreatic ductal stone removal, planning for intraductal biopsy, cholangioscopy, or planning to put multiple stents or large bore stent for stricture dilatation. While precut sphincterotomy is usually performed when there is a failure of standard method of cannulation. So contraindication to sphincterotomy is like uncorrectable coagulopathy, and we cannot orient the cutting wire along the axis of the bile duct or the pancreatic duct. So before proceeding further, so I would like to tell you that there is two terminology, that is major duodenal papilla and ampulla. So both are different. Ampulla is the dilated junction of the pancreatic duct and the bile duct, while the major duodenal papilla is the point where the ampulla water enters into the duodenum and beyond. So as you see, the papilla has multiple component. That is one horizontal fold that is called hood, and longitudinal fold that is called frenulum, and there is a suprapapillary protrusion. So usually the length of the papilla is 1 centimeter, and but it varies according to the individual. So why these folds are important? Because they help in identifying or locating the papilla during duodenoscopy. When the identification of the papilla becomes difficult, you should search for these folds. So major papilla has these three sphincters: sphincter of the bile duct, sphincter of the pancreatic duct, and sphincter of the ampulla. So during sphincterotomy, we cut and the intraduodenal portion of the sphincter beyond the muscularis propria. So before sphincterotomy, always your sphincterotome. That is the device we use for sphincterotomy. So now what sphincterotomy we are using is a triple lumen sphincterotome, and which has one port for the guide wire, one port injection, and it has a multiple marker, and one port for the cutting wire. It has multiple markers placed at an interval, which also tells about the depth of insertion of the sphincterotome. The part of the sphincterotome which is projecting beyond the end of the cutting wire is also called nose, which is maybe short nose or long nose sphincterotome. So normally what we are using is short nose sphincterotome. The length of the nose varies from 5 to 8 millimeter. The long nose sphincterotome is rarely used, especially they are useful when the papilla is located inside a diverticulum, and when you trying to pull out the papilla from the diverticulum, the long nose sphincterotome may be useful. So now these are different sphincterotome. You can see this is a sphincterotome on the right side, which belongs to the Olympus, the clever cut sphincterotome. It is called clever cut because the proximal part of the sphincterotome is insulated. It has multiple markers. You can see green markers at the two green markers at the both end of the cutting wire, while the blue marker in the center, which denotes the middle marker of the sphincterotome cutting wire during bowing. So there is another marker in this sphincterotome that is called V marker, which is located in the shaft of the sphincterotome. The V marker denotes that the point of exit of the sphincterotome from the elevator during insertion. So diameter of the sphincterotome also varies, and it varies from 3.9 to 5.5 millimeter. The narrow diameter sphincterotome 3.9 French, which accommodates 0.18 or to 0.25 guide wire, and this narrow diameter sphincterotome helps in cannulation of the minor papilla, especially. Actually, the engagement is easy, but the narrowed sphincterotome, they cause more trauma to the papilla and more submucosal injection. The tome can be either tapered tip or dome tip. The tapered tip helps in easier engagement, while the dome tip, they supposed to cause less chance of pancreatitis. So whatever the tome, the guide wire we're using is a monofilament steel wire normally used because it provides a sharp cutting of the major papilla. The braided wire is now no longer used because the wire is thick and it causes more coagulation than cutting. So coming to the length of the cutting wire, so we have a short cutting wire or long cutting wire. The cutting wire length varies from 20 millimeter to 30 millimeter. So normally most of the cases we using a short cutting wire because it has a lot of advantages. This wire can be precisely controlled and also reduces the risk of uncontrolled cut because the wire is not too deep inside the sphincter. And while cutting the proximal part of the wire, less likely to be in contact of the duodenal fold or inside the channel. But the problem is that this short length cutting wire, which is 20 millimeter, tends to orient the cutting direction towards the 2 o'clock direction while bowing. So coming to the preparation of the sphincterotomy, all sphincterotomy comes with a memory wire and which is located at the tip. So it maintains the curved design of the sphincterotomy and also protects the tip of the sphincterotomy. So before proceeding, we usually remove this memory wire by in slow stroke so that the curvature is maintained. And also prior to sphincterotomy, check the bow and unbow function and also flush the sphincterotomy before proceeding. So whenever we see a sphincterotomy, there are a lot of information provided by the manufacturer. In the left side, this is a clever cut sphincterotomy from the Olympus. It shows that the length of the catheter is 1700 millimeter. It requires 2.8 millimeter working channel. It supports O35 guide wire. It is tri-lumen. The shaft is 5.5 French. The tip is 4.5 French, and it is tapered. And the length of the nose is 7 millimeter, which comes into category of the short nose. And that the cutting wire length is 20 millimeter with the proximal insulation, and there are multiple markings as I have discussed earlier. So sphincterotomy, there are variations. They can be combined with the CRE balloon when we are planning for a sphincterotomy as well as sphincteroplasty. At the same time, this balloon can be used, though they are expensive. So in contrast to the normal CRE balloon, the length of the balloon is here shorter. So that is 40 millimeter. And it has a marker at the end, radiopaque marker at the proximal and distal end of the balloon. And there is also, you can see in the center of the balloon, there is a marker which is endoscopically visible during balloon dilatation. The dilatation, like a CRE balloon, the diameter of this balloon is variable, and so that is why it helps in sphincteroplasty. So coming to this rotatable sphincterotomy, which is also available, and the sphincterotomy can be rotated to the left and right, and also it helps in orienting the sphincterotomy or cutting wire along the direction of the bile duct. This rotatable sphincterotomy can be used for altered anatomy when in post-biliary type 2 procedure, so in which it can be rotated and can be made it inverse. So these are other sphincterotomy, that is wire-guided biliary type 2 papillotomy and no-nose sphincterotomy. No-nose sphincterotomy can be used as a needle knife and also for the sphincterotomy of the minor papilla. This is another needle knife sphincterotomy which has a knife and length varies from 1 to 5 millimeter. This is also trilumina. So electrosurgical setting, that is very important. Also, we should know what is the setting. Okay, the trial shows that endocut has the less chance of bleeding compared to the pure cut current, while is no risk in increase the risk of perforation and pancreatitis. For pancreatic sphincterotomy, pure cut may be preferred over blended current. Now, coming to the steps, know your indications and also pre-medication. Keep your accessory ready for sphincterotomy. Also, keep your accessories ready to manage complication arising from the sphincterotomy, like injector adrenaline or fully covered stems. Make sure the ground part is attached to the patient because these are monopolar devices and electrosurgical should be functioning. Sphincterotomy is performed only after deep cannulation because make sure the guide wire should not come out of the papilla during sphincterotomy. So normally the 5 mm or less cutting wire should be inside the papilla, which corresponds to the distal marker you can see. And sphincterotomy cutting direction for the bile duct is around 11 o'clock and the pancreatic duct around 1 o'clock direction. So the orientation of the cutting wire should be along the axis. Sometimes making orientation is difficult. So normally during sphincterotomy, we correct the orientation again and again by holding the shaft of the scope with a knife. Another method to correct the orientation is by rotating the left knob to the left and pushing the scope into long loop position, which helps in maintaining the direction of the cutting wire along the 11 o'clock position. So coming to the length of the sphincterotomy, it is again divided into minimal when we cut till the hood, and medium when we cut is made from the papillary orifice to the midpoint between the hood and the superior margin of the sphincter protrusion, and it is called full length sphincterotomy if the incision is made from the papillary orifice up to the superior margin of the sphincter protrusion. So what should be the length of the sphincterotomy? We do not require a full length sphincterotomy in all individuals. The The full-length sphincterotomy is only done when we are planning for a large stone removal or in sphincter OD dysfunction. We have to ensure that entire sphincter is cut. And in other case, for like stent placement, you do not need to do a full-length sphincterotomy. So the problem that the anatomical landmark may not be necessary consistent with the living bodies. Even if you do not do a full-length sphincterotomy, there is always a risk of perforation. So what should guide us that if you have a large bulging intramural segment, long cut can be made. And if your duct is not dilated and it is distant from the papilla wall on the fluoroscopy, then smaller incision can be made. So if you are not sure about the anatomy, then you can pull both the sphincterotomy, pull it out, or can inflate a balloon and pull it out from the bile duct to identify the landmarks. So this is the execution of the sphincterotomy. So a very small amount of guide wire is inside the papilla, like it is almost like 5 millimeter, and we cut is made in a stepwise manner along the 11 o'clock direction, so that, and then make sure that there is no excessive coagulations. So when do you say that the sphincterotomy is complete? And sphincterotomy, we say sphincterotomy is complete if the junction between the duodenal wall and the interduodenal portion of the papilla vater has been reached, or if the inner portion of the bile duct is visible, or if a fully bored sphincterotomy can be pulled up the papilla without any resistance. So during sphincterotomy, always maintain the contact with the roof of the papilla. There are 4 maneuvers how we maintain contact with the roof of the papilla: either lifting the sphincterotomy with an elevator, or by doing a big knob down, or slightly pulling back the duodenoscope, or counterclockwise rotation of the duodenoscope. So if you, during sphincterotomy, if you find that there is excessive coagulation, then obviously there are certain things you should remember. Either your guide wire is too deep and cutting the excessive tissue, or the contact with the roof is inadequate, which can be made by a maneuver I have told earlier. Always check the electrosurgical generator that you are not using the appropriate setting. Coming to the sphincterotomy in the altered anatomy, when the papilla is deep inside the diverticulum, in the center of the diverticulum, the anatomy is pretty clear. So sphincterotomy is easy along the direction of the bile duct, because the direction of the bile duct can be easily seen. But if your papillary opening is located at the margin of the papilla, then the anatomy is less clear. So in that case, you can use a long nose sphincterotomy to pull the papilla. Obviously, the sphincterotomy over a guide wire, because guide wire identifies the direction of the cut. You can bend the both the sphincterotomy, and any direction of the cutting wire to the base of the diverticulum should be avoided. Alternatively, needle knife sphincterotomy can be used. So now I have few slides, and this is about access papillotomy. I think previous speaker has already spoken. This is a standard technique. When this fails, this method we use. And before proceeding with the pre-cut, you should be well versed of the sphincterotomy, routine sphincterotomy. And before doing a needle knife, several practice movements should be made to make sure that it will move in the intended direction. Usually we cut in 5 to 10 mm incision upward towards the 11 o'clock and unroof the papilla layer by layer. So it has a 2 method, either needle knife sphincterotomy or fistulotomy. Sphincterotomy, when we start cutting from the papillary orifice. Fistulotomy, we start cutting away from the orifice. This is where you're doing fistulotomy. Fistulotomy trials have shown that fistulotomy has the less risk of pancreatitis, because we are not cutting the papillary opening. So again, the direction of the cutting can be made from above downwards and below upwards. So most of the center, they practice below upward cutting. So once you are opening the layer by layer and your biliary sphincter is identified, you can probe it and with a guide wire, and followed by which cannulation can be made. Another method of sphincterotomy is pancreatic septotomy, and where there is a guide wire enters into the pancreatic duct again and again. This is especially useful if the papilla is small. So we insert a sphincterotomy into the pancreatic duct and cut the septum along the 11 o'clock direction. So here, that after cutting, we always put a pancreatic ductal stent to prevent the pancreatic ductal stricture and pancreatitis. Here we are cutting. Here our sphincterotomy is in the pancreatic duct, and we are cutting along the direction of the bile duct. Once you see the bile, cannulation attempt can be made. Burdick's technique is another technique where the papilla comes out through a abnormal or fistulous tract to the roof of the papilla. We advance the sphincterotomy over the guide wire and cut the roof of the papilla, following which cannulation can be made. Coming to pancreatic sphincterotomy, there are 2 variants: pull type or needle knife. Pull type sphincterotomy is like same as the standard technique, freehand technique, the way we do a biliary sphincterotomy, but the direction is 1 or 2 o'clock directions. Pure cutting setting may be preferable. And the majority of the cutting out should be out of the papillary orifice, and pancreatic ductal stent is inserted after completions. Needle knife sphincterotomy, that is when is done after placing a pancreatic ductal stent, and stent function is a guide for the sphincterotomy. And it is not possible where stenting cannot be done and require more exchange, and maybe physicians they may be not familiar with this technique. Coming to pre-cut pancreatic sphincterotomy, it is usually indicated when there is a stone impacted at the pancreatic sphincter and the cannulation cannot be done. So, and pre-cut pancreatic sphincterotomy is done in the same way as the biliary sphincterotomy. Remember, difficult pancreatic ductal cannulation is encountered far less common than the difficult biliary cannulation. This is my last slide, minor papilla sphincterotomy. It is not a true sphincterotomy and can be done the same way as the major pancreatic ductal sphincterotomy by standard pull technique or needle limp technique. You can use a short no-nose sphincterotomy, but the direction is along the course of the dorsal duct, usually in the 11 o'clock direction. Thanks.
Nitish, for a wonderful talk, and it will really generate a lot of questions after the session. May I invite Dr. Samantha to talk about the complications of the ERCP?
Excuse me. Wow. See. A very good morning to everyone. Thank you, Professor Ruprai sir. And at the outset, I'd like to thank Professor Kalla, Dr. Sandeep Nijaman sir, and the whole team of AEW for giving me this opportunity to speak over here. So in the morning sessions, you have heard already my previous speakers have talked about how to do ERCP and how to cannulate, how to do a sphincterotomy, etc., etc. So I'm being given the task of talking about how do you manage ERCP complications. So we have moved a lot far ahead in our, the advancements of endoscopy. We have done a lot of things. We are now doing EUS-guided biliary drainages. We are doing third space endoscopy. There are a lot of technological advancements that have come. But having said that, ERCP, still after 7 decades or 5 decades of being first introduced, it still has the highest potential for complications. This is probably the most risky procedure in GI intervention that you can do is ERCP. What is ERCP is basically like you're an expert, you know everything about how to do it, but at the end of the day, you are an expert who is blinded while you're trying to attempt the bile duct or the pancreatic duct, because they obviously cannot see in your vision that this is the CBD or this is the PD. So it's like an expert trying to throw an arrow at a target, but the person is blindfolded. So the first study on ERCP complications was published like 6 years after the first ERCP was introduced. During that era, it was more of largely diagnostic. And what they found out was that the success rate was around 70% with complication rate of 3%. And they found that obviously experienced workers had a lower failure rate percentage and complications as compared to someone who was an inexperienced worker. Moving from that first study on complications, I'd like to highlight the first landmark study on ERCP complications from Martin Freeman's group, published in NEGM 1996. I think everyone is aware of this paper. More than 2,300 ERCPs. And what they found out was that, that there were certain risk factors which were there for the development of ERCP complications, such as sphincter dysfunction, young age, pre-cut sphincterotomy, difficulty of cannulation, number of pancreatic contrast injection, etc., etc. So that was the era where we started understanding that yes, ERCP does have its own course of complications, etc., which needs to be kept in mind. And there are multiple society guidelines which clearly talk about a separate paper, a manuscript on complications of ERCP. So whenever we talk about post-ERCP complications, what are the complications that we talk about? Majorly, we talk about pancreatitis, bleeding, perforation. So these are the 3 major complications which we are always concerned about. Obviously, there can be an aggravation of infection causing cholangitis, cholecystitis, or some anesthesia or cardiovascular related complications. Obviously, I'm going to concentrate more on the PEP, bleeding, and perforation. So if you look into the overall rates of post-ERCP complications, pancreatitis is, as of now, the highest. I mean, something which is of the three, that pancreatitis, bleeding, and perforation, pancreatitis is the highest incidence of 3.5 to 9.7%. And I would like to highlight the point here that if you look at all the other post-ERCP complications, PEP has the highest mortality rates. So when PEP develops in a patient with pancreatitis, the mortality is going to be higher. It's 0.1 to 0.7% as compared to all the other complications that has happened is 0.04 to 0.06%. I'll give you a typical case scenario. 35-year-old young female came to walking to the OPD, chronic abdominal pain, post-cholestatus. There are normal LFT, mildly dilated CBD, and you do a MRCP. Typically, there is possibly some sludge, something. You did an ERCP, twice the wire went into the PD. You did a biliary sphincterotomy, did not place a PD stent, gave adequate fluids, gave rectal NSAIDs. 48 hours later, she comes back with severe abdominal pain, acute necrotizing pancreatitis with organ failure. And this is what happened with multiple intervention and a hospital stay of 2 months for a procedure, which she came for an OPD basis. We all have faced these kind of complications, right? So what is the rates of post-ERCP complications when we talk about? So post-ERCP complications, this was the meta-analysis published of 145 randomized controlled trials, and they showed that the PEP incidence was to the tune of 10%, and in high-risk cases, it is to the tune of 14%. I'll not go into the details, and they have found that there was no overall, the trend for the incidence of PEP randomized to placebo no stone has remained unchanged since ages together from 1977 to 2022, meaning thereby we have not yet moved further ahead in our management of post-ERCP pancreatitis or preventing post-ERCP pancreatitis. Definition and grading, I think everybody is aware of that. Old one was the Cotton et al. New we use the revised Atlanta classification. I'll not go into the details of it. So what are the risk factors for post-ERCP pancreatitis? I think everybody is aware of that. The definite risk factors, patient-related, will be somebody who had a prior post-ERCP pancreatitis, female sex, previous recurrent pancreatitis, sphincterotomy dysfunction, and some procedure-related like difficult cannulation, repetitive pancreatic guide wire cannulation, or pancreatic injection. And there are obviously some likely risk factors for PEP like non-dilated bile duct, end-stage renal disease, etc., right? But I believe, and I think the persons present in the hall who have done ERCP will agree with me that probably the biggest risk factor is if you're doing a ERCP in an unindicated patient. Please do not do it. Do not wake up the sleeping dogs. So having said that, I will discuss about risk factors for post-ERCP pancreatitis. The only thing that we can do, because the management of post-ERCP pancreatitis is how you manage post-ERCP any pancreatitis for that matter, but how will you prevent post-ERCP pancreatitis? There are pharmacological treatment, IV hydration, endoscopic modalities, but prevention is probably the best strategy that you can adopt, because once PEP develops, you just have to wait for the cytokine storm to tide over, because you can't do much about once the pancreatitis is set in. So what are the burning questions that we always ask about when we talk about prevention of post-ERCP pancreatitis? That whether it is NSAIDs or PD stent or a combination of the two, which NSAID if you want to give it, which PD stent or what kind of PD stent you want to do it, and are there any endoscopic strategies to adopt in order to reduce the risk of post-ERCP pancreatitis? So I'll come to the first, probably one of the most talked about pharmacotherapy trials in prevention of post-ERCP pancreatitis. This is Joseph Elmanzer's group, published in NEJM 2013. They talked about rectal endomethacin, 600 patients, double-blind randomized controlled trial, and they found that rectal endomethacin decreased the post-ERCP pancreatitis to the tune of 17% versus 9%. So this was one of the first trials after which there was a lot of use of rectal endomethacin. This was a very elegant paper after that, a few years later, around 7 years down the line. Again, Joseph Elmanzer's group, they tried to find out the real-world practice. This was a US-based population registry, and they found that after 2013, after that paper came out and the evidence came out, they tried to find out what was the rate of post-ERCP pancreatitis and how was the real-world practice going on. So they found, strangely enough, that post-ERCP pancreatitis rate, it was similar. It was like 8 to 10% throughout. There was no change in the rate of post-ERCP pancreatitis. The only thing that happened because of the paper was that the percent of persons who were using ERCP and using indomethacin went from 6% to 46%. And people who are earlier used to put PD stent went down from 37% to 4%. So basically, you are just replacing endomethacin with PD stent. There is no change in the post-ERCP pancreatitis rates. What about the mortality after PEP? This was another elegant study where they again showed that after 2014, you can see clearly that the mortality related to post-ERCP pancreatitis has actually gone high. Is that related to lower use of PD stent? We still do not know. There was one more trial, the India trial, where PGI was also part of it, conducted by Venkat. They tried to do topical epinephrine to reduce the degree of post-ERCP pancreatitis. Again, it was not of any use. They could not show that it was better. After that, Venkat did this first NMA. This was published a few years back. A network meta-analysis for all the post-ERCP prevention strategy that can be done. And what they found out was very interestingly that rectal diclofenac was the best NSAID. Right? It's not indomethacin, but it was rectal diclofenac, which was the best NSAID. Combination of prophylaxis was probably more effective. And 5 to 7 French PD stents are more effective than rectal endomethacin. So this was the NMA that was there, the network meta-analysis that came out. So the question was still out as to whether NSAID or PD stent. The fight for the better PEP prevention was still there. So having said that, this paper was published just last year, late last year, a very elegant study from, again, Joseph Elmanza's group published in the main Lancet, where they tried to find out whether endomethacin alone or endomethacin with prophylactic PD stent, which one was superior. And this was a non-inferiority trial, and almost 2,000 ERCP cases were randomized. And you can clearly see that the post-ERCP pancreatitis was similar between indomethacin plus stent versus indomethacin alone. And they said that indomethacin alone was inferior to the combination, because it's a non-inferiority trial. They said that it was inferior to the combination of rectal NSAID and PD stent. Having said that, this means that PD stent, placing a PD stent, if you have an option, is always the winner if you try to prevent post-ERCP pancreatitis. So once you decide that PD stent needs to be placed, which PD stent have to be placed? Obviously, there was a comparison between 5 French versus 3 French, and there was a systemic review network meta-analysis which showed that yes, 5 French is superior to 3 French. Stent diameter was more important than the type of stent or the presence of flanges or not, right? Coming to some of the endoscopic strategies like ERCP salvage techniques for PEP prevention. This was a very elegant network meta-analysis just published a couple of years back by Antonio's group. And what they found out was that compared to standard cannulation, we have been talking about standard cannulation and whether it increased the risk of post-ERCP pancreatitis. They found in the network meta-analysis that probably an early needle knife can probably better decrease the risk of post-ERCP pancreatitis, because by that time, the edema does not set in when you're trying to gain access into the bile duct. And second, obviously, that compared to pancreatic guidewire assisted techniques, both early needle knife and transpancreatic sphincterotomy had lower post-ERCP pancreatitis rates. We even published this year one randomized control trial between rendezvous versus pre-cut. Obviously, this trial was not designed to detect whether there was a difference in the post-ERCP pancreatitis rate, but on a subgroup analysis, we found that pre-cut and US rendezvous was similar as far as prevention of post-ERCP pancreatitis is concerned. So probably we can say that standard CBD cannulation, keeping on attempting, probably is not a good strategy. Early pre-cut, rendezvous, and all these kinds of salvage strategies early on when you're trying to cannulate might help in preventing post-ERCP pancreatitis. What about the role of periprocedural IV fluids in PEP prevention? Yes, this was a multi-center trial. Dutch Pancreatic Study Group published this fluid trial, and they found that again the same findings which waterfall trial Enrique Madaria found out, that whether you give aggressive hydration or you give control group, the rate of post-ERCP pancreatitis was similar. So give standard hydration, no need for aggressive hydration, and that should be enough for PEP prevention if the patient has not to develop pancreatitis. Moving on from post-ERCP pancreatitis, it's all we talked about prevention. Now we'll go into management. What about post-ERCP or ERCP bleeding? So this is another catastrophic complication that can sometimes happen. Bleeding overall occurs in around 2% of all ERCPs, primarily related to sphincterotomy, and the chances of mortality is around 3 to 5%. What are the definite risk factors? Obviously, we know coagulopathy, anticoagulants within 3 days of EST, etc., cholangitis, bleeding during the initial, etc., etc. So these are the risks for bleeding. And I will not go into the details for shortage of time because of the classification of severity of bleeding, because earlier it was Cotton's definition. Now we use the ASG lexicon for defining the severity of bleeding. I'll just highlight on the latest data published just this year. This was from the SVI trial, the registry data that they came out, and they found that in a patient of more than 8,000 patients, they found that the clinically significant post-ERCP bleeding was seen in around 1.5%, out of which 2.3% of that required occurred after high-risk interventions. And obviously, these were the various kinds of repeat endoscopy and RBC transfusion that required during ERCP bleed. So how do you prevent ERCP bleed? Obviously, careful patient selection, correct the INR, see for the platelet. If not an emergency, correct everything and then go in. Obviously, these are the guidelines from ESG and BSG guidelines, where the high risk and the low risk cases should be kind of assessed and then go ahead. What are the technical strategies that you can do to reduce the bleed? Experienced endoscopies obviously has been shown to have less bleeding as compared to inexperienced. Do a proper sphincterotomy. I think Itish has clearly explained as to how to do the sphincterotomy in order to have less bleed, because there is an anatomically less blood supply in that 11 o'clock to 1 o'clock position. Avoid zipper cuts. Do use a proper electrocautery settings. Do not use pure current, that will lead to more amount of bleeding. And you can choose to use sphincteroplasty instead of sphincterotomy when there is coagulopathy. So let's say there is a, how do you manage ERCP bleeding? So this kind of a bleeding is happening. How do you manage? Please remember that majority of these bleeding will stop spontaneously. So do not panic. Just stay calm and try to assess what's happening. Once we understand how much of the bleed is there, from where the bleed is, usually in a sphincterotomy bleed, the bleed will be from the apex. So try to locate that, wash it, see it, and then try to address that bleed. So that bleeding can be addressed by a lot of things like injection, epinephrine injection therapy. The initial point, we can try to place clips at the apex in order to control the bleed. And obviously we can, if there is a lot of clot, we can remove the clot, cannulate the CBD again, and place a fully covered metal stent to stop the bleed. So these are the strategies that can be used in order to manage post-ERCP bleeding. But in all these things that you do, please make a point to know that you should avoid or protect the pancreatic orifice and do not block that. Coming to the algorithm, so any post-sphincterotomy bleed, complete the sphincterotomy. If you see a bleed, keep on doing the sphincterotomy and complete the sphincterotomy. If during the sphincterotomy you're having a bleed, you can use a balloon tamponade. You can use dilute epinephrine injection. After that, even if that post-ERCP, the bleed continues, you can use mechanical therapies. Followed by that, you can use a fully covered stems. If nothing works, obviously intervention radiology and surgery are there. If there is a massive bleed, etc., again, thermal probe like gold probe, etc., can be used. Even APC has been used. Coming from bleed, I'll come to the last complication. That's perforation. So whenever we have an ERCP-related perforation, let's talk about what to do. It's a typical case scenario, 45-year-old patient, OPD visit, you did a biliary sphincterotomy followed by an EPL-BD, stone extracted, rectal anesthetic given. 36 hours later, patient came with pain and fever, and this is what you see. There's a lot of perinephric air, pain, and the patient has a perforation. So whenever there is these kind of post-ERCP related perforation or ERCP related perforations can happen, in these situations, please make a note that the earlier you detect, the better it is for the patient and the better is the outcome. So here, time is the essence. Endoscopic and fluoroscopic examination for perforation should be actively looked into routinely after every ERCP, even if it has gone very, very nicely. Because at the end of the day, timely detection is key to prevent future complications when there is a perforation. Again, having said that, too much amount of reliance on radiology sometimes can be detrimental, because it has been shown that usually post-sphincterotomy retroperitoneal CO2 can be seen in as high as 30% of the patients, and the amount of air on CT and the size of perforation, there is a mismatch. So probably what you need to do is, for perforation, they should be analyzed on a clinical context basis as well, not just depending on the radiology. So this classification, step for classification for ERCP, everybody is aware of it. Type 1 is where you perforate with the scope. It is usually classically the medial or the lateral duodenal wall. This can be to the tune of around 18%. The most common is obviously sphincterotomy related perforation, around 58%. Type 3 will be the guide wire related, which is around 13%, where the bile duct perforation happens. And there is no proven perforation, but there is a lot of retroperitoneal. There is a type 4 where you just don't need to do anything. So how do you manage? Very simple. For type 1, where you have perforated with an endoscope, you use a closure device immediately if you can detect. Use a closure device, close it. For type 2 and type 3, you need to divert the bile. So obviously, you put a metal stent for a type 2 and maybe a metal or a plastic stent for a type 3. And for type 4, you don't need to do anything. So what you need to understand, this is a classical type 1 kind of a perforation, as you can see over here on the lateral wall. So if recognized, closure by an experienced endoscopist is now considered as the first line therapy for any kind of post-ERCP perforation. So please look actively into it. But obviously, surgical therapy should not be overlooked. So post-ERCP perforation management, as I've already highlighted, for a type 1, you close it. For type 2 and type 3, you divert. If there is a drain, if there is a fluid collection, you drain by PCD. Sometimes EUS-guided drainage can also be done. And reduce the load on the perforation side by keeping the patient NPO, place an NJ, etc., etc. If the patient starts deteriorating, sepsis happens, there is a signs of peritonitis, please do not hesitate to call in the surgeons. I'll briefly go through the infections. Obviously, there can be a lot of endoscopy-related infections can happen. There are certain risk factors for that. We are all aware of that because of combined percutaneous and endoscopy procedures, because stent placement happens in malignant strictures. Most important is if you are not getting a good, adequate biliary drainage, In those situations, obviously, the infection can go up. In a pre-procedure cholangitis, the cholangitis can get aggravated. There are other uncommon events of post-ERCP like sedation-related adverse events. Cholecystitis can happen, delayed post-ERCP strictures, and obviously people have now been talking about duodenoscopy-related transmission of infections. I'm not going to do the details of them because of shortage of time. So the take-home message from my side will be ERCP is not devoid of risks. Do only for the right indications. Post-ERCP pancreatitis is probably the most common and the most dreaded complication of all the three major complications that we talk about during doing an ERCP. PD stent is superior to NSAIDs for PEP prevention. So whenever you have a chance, please put a PD stent if you have gone accidentally into the PD. Bleeding can be controlled endoscopically most of the time, so do not panic. Perforation, you need to be very, very vigilant about it, and detection early will save the time, and most can be managed endoscopically. And as Peter Cotton has once said, that ERCP is most dangerous for people who need it the least. So please look for indication, indication, and indication. And finally, I'll conclude by saying a good mountaineer is one who knows how to come back safely. Thank you.
Wonderful talk by Samantha. As we have 10 minutes to go so any questions can be directed to our previous two speakers and Dr. Samantha. You may, or you can come down here and answer. The first thing which was told by you to prevention. So can a EUS with ERCP combination, can it be attempted in a goal, and we can achieve selective cannulation much better than anything else? Could it be planned some way? Yes, please.
There is, I believe that how ERCP can probably prevent is ERCP can prevent a lot of unindicated ERCP. Like MRCP, sometimes they say there is a stone, a small stone. It has clearly been shown in data suggests that whenever the stone size goes below 5 millimeters, EUS is much, much better modality than any of the other imaging modalities you're going to talk about to diagnose. So obviously, one, you are reducing the post-ERCP pancreatitis and any complication of ERCP by not doing the ERCP in the first place. So EUS is something which can actually prevent that. That's part one of the story. Part two, obviously, they can give you an insight into how difficult is the anatomy down, how difficult is the stricture, how tight is the stricture. Those things can be done. But having said that, probably selective cannulation is something which probably ERCP, I mean, EUS will not help unless you're doing a rendezvous procedure. So the only thing that can be there is if you feel that, obviously there is no data as of now, sir, to justify upfront EUS-guided rendezvous procedure. But yes, if you do an EUS-guided rendezvous procedure, no, I don't think so, sir. I don't think. As of now, we don't think that is that. No. Okay, sir.
What is your practical approach to manage a young female to prevent the pancreatitis, post-ERCP pancreatitis? A simple case, CVD stone. We got here 20 years. What is your practical approach to manage post-ERCP pancreatitis whenever young female between 20 and 25 years come with the CVD stone? So what you do will practically to prevent
You can
as of now?
Yeah. You're direct.
This is probably the most difficult question that you've asked, because you can try to prevent, but you can never be 100% sure that the person will not develop pancreatitis. So usual strategies that even if you look into all the data that they have said, that you are trying to use a combination of all those prophylactic measures that have been shown to be useful in preventing post-ERCP pancreatitis. So let's say you are doing a 25-year-old young female. Obviously, she's a young female. She already has one of the definitive risk factors for post-ERCP pancreatitis. And if usually these cases will have a small stone, so the diameter will also be normal. Let's say the bilirubin will also be normal. Do you understand my point? So these are the pre-procedure patient-related risk factors which are already very, very high for post-ERCP pancreatitis in this particular case. Then what I or anybody would be doing is use rectal endomethacin or diclofenac, whatever you can, give adequate fluids. And if accidentally you enter into the PD, please do not forget to put a PD stent and come out. So Venkat is a very close friend of mine. So he has been doing a lot of animal studies on what happens or what the mechanism happens once the wire goes into the PD. So one of the major mechanisms which we all understand is because of the onset of this edema that happens. So even I had discussed with him. So I tried to understand that why is it that people or the guidelines always talk about that more than one PD cannulation. More than one PD cannulation means that if the wire has gone more than once. So if once the wire goes in, are we supposed to put a PD stent? Guideline says no, do not put it. So I tried to understand, I asked, and then he said it is all a matter of statistics because the odds ratio is coming very nice when it is more than one, but that does not make it foolproof that if it has gone one, the pancreatitis is not going to happen because the insult has already happened. The inciting factor has already been there. That's my point. So if you are trying to very, very severely try to prevent a pancreatitis in such a young female, even if you go once into the PD, I would recommend you put a PD stent and then come out. Even if the person develops pancreatitis, that pancreatitis severity will be lower. Because this was one of the trials that people tried to do with biliary pancreatitis. So this was a failed trial, a negative trial. But having said that, the negativity was because what happened is already the cascade has happened. And secondly, a lot of the cohort of this patient, they could not cannulate the PD. But having said that, the concept still remains that if you can place a PD stent, if you can reduce the gradient inside the duct, the severity will obviously come down.
Dr. Sharma.
Samantha, do you do complete sphincterotomy in all the patients, or you decide the length of the sphincterotomy based on the size of the stone? Because most of the time the bleeding which happens at the end of the sphincterotomy, because at the apex.
Right,
so what I personally do is I do sphincterotomy up to the level and I see the size of the stone. If it is small, then I don't do complete sphincterotomy. So what do you?
I absolutely agree with you. I think we were just discussing this point with Itish and all.
Data suggests that the length of the sphincterotomy doesn't determine the risk of bleeding. So if you do a medium length, there is three length of sphincterotomy, that is a low, medium, or full length. So if you do a medium versus a full length sphincterotomy, the complication usually doesn't more if you're doing a full length sphincterotomy, especially bleeding. So obviously the length of the sphincterotomy is very customized. Like if you're planning for a put stent, then you do not need a full length sphincterotomy. Your small sphincterotomy is enough. If you have a large stone and you are planning for a plasty, then you obviously do not need. But that's why it is all customized. If you think that the stone will come out without doing a full length, then full. Then.
Thank
you. Yeah, nice talk, and well, it's always a humbling talk whenever you see Jayanta. That is one thing. And other thing is that when you talk of pancreatitis, it is always a humbling talk. Two questions. One is an asymptomatic patient, just chance detection of a CBD stone. So there is a 20% chance of pancreatitis in an asymptomatic patient, and there's a 20% chance of cholangitis over 5 years. What is your approach? That is one thing. That is the question number one. Second is that if I have understood ESG guidelines properly, they have talked about actively seeking PD and PD cannulation. And they're not talking about a chance inadvertent cannulation of PD and then trying to put a stent there. They've talked about actively seeking the PD and trying to cannulate it to prevent pancreatitis. I think there may be
I'll clarify both the points. So the first question that you asked is, if there is an asymptomatic CBD stone, what are you going to do? We have to remove it. There's no doubt on that aspect. Asymptomatic gallstone is different from asymptomatic CBD stone. Asymptomatic CBD stone, inevitably, this will land up with complications. And as a result of which, asymptomatic CBD stone, if there is a stone in the CBD, you have to remove it. There's no doubt on that. As far as the ESG guidelines is concerned, I'm pretty sure that they talk about, whenever they talk about difficult bile duct cannulation and all these things, they talk about inadvertent PD cannulation. What the SBI trial did in this particular paper that was published in Lancet, that was different. In that, they actively tried to enter into the PD to put a stent in order to see whether that PD stent was preventing the post-ERCP pancreatitis. So that thing is different from what the guidelines will say. The guidelines will never tell you that go actively inside the PD and put a PD stent. No. That's not the case. But what SBI trial tried to do is whether they try to find out whether an actively entering into the PD and putting a stent was adding or was better than compared to just giving indomethacin. You understand my point? And if you see the trial, you'll again realize that
a good number of patients, I think if I'm not wrong, I think 30 or 35% of the patients, they could not do a PD cannulation. And in spite of that, the intention to treat analysis showed, intention to treat means they consider the whole cohort, right? In spite of that, they showed that the PD stent arm was doing fairly much better as compared to the only indomethacin arm.
I think, do you want to answer? Because we want to start the live demonstration. We can discuss it little later on. There will be a lot of questions because this is the most burning thing. And as initially told, ERCP is like a Jwalamukhi. So touching it also is a big thing. So today we are going to, Mukesh, we are starting. So we are coming to the live session of cases, and we have a long list of cases to be presented today. May I now invite the moderator for the session, first session. Dr. Manish Patnagar Sahab, kindly come for the moderator as a moderator. We invite the chairpersons, Dr. Mukul Rastogi, Dr. Nitin Mahajan, Dr. Naveen Bhagat, Dr. Bhamar Sirsa, Dr. Patel Jaideep, Dr. Hemendra Bhardwaj. So, who sir is available? Dr. Bhatnagar, please go ahead.
Anurag, Manish Bhatnagar here. Good morning.
Morning,
Am I
sir.
audible to you?
Yes, I can hear you.
Yeah.
Can you hear me?
Yes, absolutely.
And are you seeing us also?
Yes, you are well seen, well heard. Please go ahead.
So this brings us to the third day of the conference. And I'm very excited to tell you that all the patients that were taken up yesterday for procedures are doing extremely well. There has been luckily no complication. And that probably is the biggest fruit that the performers can ever achieve. I'm sure you all understand that performing in front of the camera is not easy, and to be able to complete the procedure in the best possible way is what one aims for. So all of them are doing well. The one EPT bleed that we saw yesterday is also stable with a stable hemoglobin and will be taken up for the required procedure today. One follow-up of the patient which was taken up for peripancreatic node FNAC has shown granulomas likely to be tubercular on histopathology. Well, the list was very exciting yesterday, but I can assure you and promise you, we have an even bigger and a more exciting list of patients today, and we will go through them and hopefully complete them all by the afternoon. We shift now to the first patient in room number 1. This is the same patient, and I have, of course, to give you the details. We have.
Good morning. This is a 39-year-old male. Came with us with epigastric pain, abdomen, jaundice, and pruritus since 1 month. His CCT abdomen suggestive of hypo-enhancing mass lesion in head of pancreas with dilated PD and dilated CBD with ISBRD. ERCP was done outside 4 days back, and a 7 French GPT stent was placed. As we discussed, he was taken yesterday for EPT bleed, for hemostasis or EPT bleed. Today patient is stable, and we plan for we already planned for US staging and biopsy. So we proceed for that OT number 1.
Dr. Samir and
Yeah,
Dr.
good morning. So I am the
Harish.
opening batsman for the third day of this nice meeting. See, this case was shown yesterday, presented with upper GI bleed. The cause was post-EPT bleed, which was very well managed yesterday. And clips are in place, and there's no bleed, there's no drop in hemoglobin, and the biliary stent is working. So I've been asked to take a FNB from the pancreatic mass, which is the primary pathology. But we thought we'll first do a side wing endoscopy and see what is the status of the bleed side. So the bleed side looks okay. So we'll go ahead and do the FNB of the pancreatic mass. Remove the scoop?
Samir, do you still see a clot out there?
Yeah.
Would you like to remove that clot and do something, or you're happy with the hemostasis which is achieved by the?
See, if the patient has been hemodynamically stable,
yes,
clips are in place, there is no evidence of active bleed, I would wait for some time.
Yes.
And then see how his hemoglobin behaves and how his hemodynamics stay.
Yes,
if the hemodynamic status is okay, clips are in place, I'm very happy with whatever hemostasis has been
wide
achieved.
EPT is being done already. Yes. So we'll change the scope to EUS scope and look at the mass lesion. So first, whenever we see a mass lesion in the head of the pancreas, what is your approach, Samir?
See, whenever we see a pancreatic mass, a good cross-sectional imaging is very important. We generally do a MDCT to see whether what is the status of the mass, what is the size of the mass, location, what is the local regional spread, is there any evidence of distant mets. Then after the cross-sectional imaging, we talk to our surgeons and discuss with them whether they need a tissue diagnosis or not. Many times surgeons say that it's very clear, we want to operate, lesion is small, there is no local regional spread, there is no distant mets, so we don't do a FNB or FNA. But if the surgeon wants us to do a FNA or FNB to be sure that it's a mitotic lesion, then we go ahead and do a FNA or FNB.
So for the benefit of residents, in such cases, we go for a pancreatic protocol of CT abdomen where the radiologists take thinner cuts at the level of pancreas and look for the evidence of mass lesion, its location, and whether the duct is dilated, PD is dilated or not, whether CBD is dilated or not. And then you look for other ancillary signs like the duct penetration sign or duct cutoff, the ratio between the dilatation of the size of the duct diameter versus the parenchymal diameter, if there is any underlying chronic pancreatitis evidence or not. So cross-sectional imaging will tell you all these things. And imaging features, there are many imaging features which favors classical CA head of the pancreas, like a hypoechoic mass, which is avascular, and there is a PD cutoff, duct cutoff sign, positive, no duct penetration sign, no calcification displacement. So that way we can say it is a classical CA pancreas, and then you don't need any FNAC or biopsy. The person directly goes for resection. So Samir, you are at station 1 at the G junction.
I'm looking at the pancreatic body and tail, placing the splenic vessels towards the.
So can you apply Doppler to look for which one is PD? So if you can see the PD here, dilated, you can see the PD which is prominent here.
Yeah.
Okay, so can you measure the PD in the body area?
I guess.
Yeah,
this is the PD.
This is the PD.
I can show you.
Yeah.
Can you put up the air? Yeah. This is the PD. Yeah, this is the
freeze
PD.
करके एक बार ले लो. Check the
so
diameter.
PD is dilated in the body region. Yeah. Measure from the.
So a prominent PD in the body region indicates that the PD is dilated.
2.3.
Yes.
Yeah.
It is 2.3.
But we need to scan the whole pancreas.
Yes.
Leave it. That's fine. That's fine.
Okay. Remove. Yeah. So when you are here, you look for lymph nodes?
Yeah. First, I look at the pancreatic parenchyma to the tail.
Yeah. So any evidence of CP or not underlying? So there is no calcification, no parenchymal changes suggestive of chronic pancreatitis. Duct is dilated.
Duct is better seen here.
Yes, better seen. It's a
significantly dilated.
Yes.
So the pathology has to be downstream to the body of pancreas.
Hey,
now straight away we'll go for the SOL in the head and body, head and ancillary process.
So you'll go to duodenum, first part, and look for the head of the pancreas. For the people who are learning EUS, we do the station approach for endosonography. The first station is G junction, where you can see everything from G junction. You can see the liver, you can see the pancreas, you can see the left adrenal, kidney, the whole of the pancreas right from body and tail. And with alpha maneuver, you can see the head of the pancreas also. The second most commonly used approach is first part of the duodenum. You park your scope at the apex of the bulb and start scanning. Scan.
The portal vein, CBD with a stent in situ.
With a stent in situ. The Tram-Trek sign suggestive of stent in the CBD. The CBD is also prominent here, dilated.
Now I have to look at the mass where the CBD becomes narrowed. That is the most likely site of the mass. Can we have elasto? You have elasto? No. So you can see both the ducts. I mean, you can look at the CBD, which is closer to the transducer. Portal vein is below it. You try to go to the lower end, trace the CBD, and you see there the CBD is being narrowed. So this is the possible site of the lesion. And you can see a hypoechoic lesion, maybe around, we can measure it.
So in EUS, either you see a mass lesion clear cut or a sudden change in the diameter of duct tells you there is something there in the parenchyma.
So this is a rounded mass around 1.7, maybe 1.7 into 1.7 or 1.8. Are you happy, Sunil?
I think we have to show it very clearly because...
Yeah, this is the mass. Can you appreciate the hypoechoic lesion?
Dr. Bhatnagar, are you okay?
Yes, we can.
Samir, would you like to look at the luncinate first and then come back?
I can do that.
Yeah. So
because the
for luncinate, you have to go to the second part of the duodenum and then shorten your scope and then start scanning.
Can we have put on water? Possible?
You'll have to shorten the loop.
We straighten the scope.
Yeah. So the first thing you will see is slip down.
No, it's fine.
The imaging.
We need to put in water.
Hello. Sunil?
Yes, sir.
Is he the same patient?
Yes, sir. The same patient which was done yesterday by Dr. Nilay. The hemostasis was achieved. The patient had post-EPT bleed.
What I mean to say is, I mean, there are chances of actually, slippage of the clips when you...
Actually, we did side view endoscopy.
I'm being very careful. You can see I'm away from the clip side.
You have to be
that's why.
Yes.
Ear off. And you need to put in more water. So slowly with the anti-clockwise and clockwise, I'm trying to...
So with this station in the second part of the duodenum, you will see the mesenteric vessels first.
Yeah, put in water. Pancreas will come at 1 o'clock, but this is the duodenal lumen filled with water. It gives a better acoustic coupling. And now slowly with the clockwise, anti-clockwise, I'm trying to withdraw the scope. Very slow movement, maybe 10, 15 degrees, and try to find if you can see mass better from here. Very slow movement has to be there so that I don't slip out. Because we don't want to go again and again into the deep into T2 because clips are there. So I'm very slowly trying to withdraw, trying to see.
Some people prefer injecting
you can see the PD
water
coming from 5 o'clock.
Yes.
And if I do anti-clockwise movement, I can see the CBD with the stent.
Yes.
Can you see the stent?
Yes.
It is very close to the transducer. CBD is not dilated because it has been stented. Can you show?
I don't need. This is the stent.
This is the stent. Can you see the stent?
This is the stent. Yes. This is the stent.
Yes, we can.
Slowly I'm coming.
Mass dikhao, Samir.
I'm coming. Just coming. A very slow movement. It's a small mass, 1.6 into 1.7. Doppler. You have elasto? No, don't have elasto.
So this is the prominent PD here.
Doppler.
Arrow de do wapas.
You have to have a very narrow window of movement, 10 to 15 degrees, to see the uncinate process. Because if there is more movement, then we can slip out and the scope will come back into antrum. Slowly, I'm trying to withdraw and see where the mass is. So it's a slightly hypoechoic mass. Can I put up the arrow? Arrow. This is the mass.
in situations where you don't see a clear-cut mass lesion in the head of the pancreas, you take the indirect evidences in the form of sudden change in the diameter of the duct.
Where the CBD cutoff is there,
CBD cutoff.
that is the most likely site.
Okay.
Because sometimes the mass is not very hypoechoic, so has to be clearly differentiated. So the site of abrupt cutoff is the most likely site of obstruction.
Yes.
So I think we'll take from D1.
Yeah, we go back to D1 and then take biopsies.
So what I'll do is,
so if the pancreatic duct penetrates into the mass lesion, then it is not a malignancy. It is more in favor of a chronic pancreatitis with a mass lesion, mass forming CP.
Yeah.
So in classical PDAC,
so
you don't see a duct penetrating into
so
the
now if you see this, now the duct CBD is dilated in the upper part.
Yes.
You can see the stent inside. Even if there is no well-defined mass, but we have on cross-sectional imaging, the mass is there. And if you can see that there's an abrupt cutoff of CBD and the duct is not penetrating. So this is the site of bleed. If we had elasto, we could have put elasto and
elastography.
So can arrow. See, this is the area.
Samir, the PD.
Yeah, Samir, how will you differentiate it from lymph nodes?
So lymph nodes are more demarcated. See, you can see the planes are lost. Lymph nodes are more discrete. You can see discrete lymph nodes most of the time. And if you look at the PD,
is that always the case, or
sometimes there can be confusion, but most of the lymph nodes you can find discrete masses. Sometimes when the planes are lost with the surrounding adjoining organs, pancreatic mass is the most likely possibility. Generally, when you see pancreatic tuberculosis, sometimes it is very difficult to differentiate between a lymph nodal mass and a pancreatic head mass. Sometimes it's a problem. But here, if you can see.
Yeah, okay, thank you.
Sandeep, you're happy?
I'm not seeing a classical
hypoechoic mass.
Clear-cut mass in the head of the pancreas. The PD down is still dilated.
Yeah.
So there has to be mass beyond the.
Yeah. I'm rotating it.
There are prominent side branches also.
Yeah.
But there are no calcification.
No calcification, no evidence of chronic pancreatitis. What do you think, Sandeep? Puneet. This is the place of abrupt cutoff.
All you want to do something, then forget.
We have to go to the area where both CBD and PD are meeting.
Yes.
That's the area of interest. So if you look at it, CBD is here, PD is going to the right.
CBD is there, and this is the PD.
And PD is dilated, so we have to go where the PD is getting narrowed. So I'm pushing the scope, pushing the scope. Pushing the scope. This is the area where PD is becoming narrowed. Can you see this?
Yes.
This is the area. Can you Sunil appreciate it? We can take from down also, if you want. But there's no well-defined mass which we can say that this is a well-demarcated mass which is causing the obstruction.
Dr. Samir,
yeah,
I think you need to go a little bit more up to D2 in order to have the complete confluence there.
Yeah, I should go into D2. Actually, what Dr. Yaman said, I was trying to avoid D2 because clips are there. So I didn't want to displace the clips, but we'll do it again. We need to shorten the scope, get scope in the straight position, air off.
Air off.
Air off. थोड़ा मुझे water दे दीजिए, water. So again, I'm going towards the uncinate process, trying to see if I can see a better mass visualization. Water. We need to distend the duodenum to have a better acoustic coupling. And here we try to get where both the ducts are meeting. Very slow movement again. Yeah, that's fine. So before taking any tissue, we have to be clear from where are we taking the tissue. Very important to identify the mass and then try to take it.
Back in the first part.
First part now.
Yeah, back in the first part.
Yeah, we need to go. It's fine.
It's being to the polypectomy remarks again.
Water. Because the acoustic coupling है, air बंद कर दिया ना, CO2 बंद कर दो. There's no air needed. Yeah, put water. Understood. So why we are trying repeatedly taking time is because I want to be absolutely sure that I need to see the mass first before putting in a needle. Water.
Sunil, what is the CT finding of this patient?
Yeah, I'm just asking for CT, and myself has not yet seen the CT, so I'm just asking for CT scan.
I think CT was done and that has shown.
Done outside, sir. ERCP was also done outside.
Can you see both the ducts here? At 5 o'clock is the PD and CPD is here.
Yes.
Now
Still there is no clear.
I have to find a definite mass before I put in a needle. It has to be very clear that the mass has to be seen, well demarcated mass before I say that. Can you see the stent in?
Doctor.
A lot of it. Can you put
Hello?
it?
Hello, I am Dr. Pankaj. Am I audible?
Yeah.
So we'll be shifting to room number 2 for Dr. Rajesh Puri, sir. He is going to demonstrate a patient of carcinoma GB with type 1 block. So the plan is to go for a endoscopic ultrasound assessment and putting a biliary stent.
So good morning, everyone. Am I audible?
Yes, you are audible.
Yes,
you are audible.
So I have Dr. Dinesh with me, and we both are going to perform this procedure. I think you must have heard the history, and I have a technician, Ramveer Singh, and we have an anesthesia doctor, Dr. Alok. Now, few important things which I wanted to highlight. Before, like when this case was presented to me that this lady has a type 1 hilar block, and ERCP was tried, but it failed outside. So the plan was to do the hepaticogastrostomy or to do the bridging stent, meaning that from the right duct to the left duct and from left duct to the stomach. So Ramveer is a little new for the EUS-guided biliary drainage procedure. First, what I did, I discussed with him the entire case. I demonstrated him on the piece of paper what are the steps going to be. Second important thing which I want to tell you, like I choose a needle because these are the very small problems, but when you encounter, you'll end up into a trouble. Preferably try to use the 19G needle by the Olympus. I'm not propagating any company. The two important advantage of this, it has a metal sheath, and metal sheath, when you try to puncture the segment 3, you use a significant amount of elevator. If it is a plastic sheath, then this is going to bend and it is difficult to exchange the wire. So that's very important. Second, the needle which has a nitinol puncture needle, this has a nitinol puncture needle. Number third important thing, it has a very penetrating sharp end. If you come across with all the needles, the Mediglobe needle and the Olympus needle has a sharp puncturing because you require a sharp puncturing in these cases. So that's why I opted for the 19G Olympus. Now when I came, the needle I try myself, it was having a lot of resistance because it was used 2 to 3 times. So one of the very important things, you face the problem. You puncture the segment, you inject the contrast, you introduce the thermoguide wire. But when you exchange the thermoguide wire, when you exchange the needle over the thermoguide wire, because you are going deep, it is not possible to change the wire because thermo has a angle tip and it can goes. But if it is a straight wire, or it is an angle tip other wire, sometimes it is difficult. So exchange over the old needle is difficult. I myself has come across with the problem while using the other needle which has a plastic sheath. The exchange is a problem because this is a short wire. So please ensure that you should have a new wire, you should have a new needle. Because exchange, it will require a water pressure from the back, and if the needle core is not new, you are facing the problem. Number third, we planned that we are going to do the hepaticogastrostomy, but the geobar stent is not there. So that is another challenge which you should always look. You have gone in and you are asking for the geobar and your technician says he don't have geobar stent. Then you are in trouble. So these are the few important points which you should always remember. Number third, I was doing the endoscopic ultrasound in this case and there is a significant duodenal infiltration. So if I fail, either I will try with an ERCP, it might be difficult because there is a significant duodenal infiltration. Otherwise, a PTBD guy should be ready. That is another important thing. You may go in and if you are not able to do it, I have a one chance. EUS-guided procedure has one road. There is a no second. In ERCP, you fail. You are not able to cannulate, you are not able to reach, but in EUS, once you puncture, it is a one-side road. And EUS give the flexibility. You can do CDS, you can do hepaticogastrostomy, you can do rendezvous, you can do the antegrade stenting. But in this case, I'm only left with the one procedure, that is EUS antegrade. Because rendezvous is not possible, there's a duodenal infiltration. Hepaticogastrostomy, I don't have a geobar stent. Antegrade stenting is only possible. So I have a one chance. If this procedure fails, then this patient will go for the PTBD. Is that right? So I'm using the therapeutic linear echoendoscope. Patient is in the supine position. Patient is deeply sedated with the propofol and CO2 should be on, air should be closed.
Hello, I am Dr. Pankaj. Rajesh sir, we will be shifting to room number 1, where they are going to demonstrate FNAC of that patient.
So can I do one thing? Can I do one thing, Pankaj? I just demonstrate. Can you take the segment and can I puncture or I should wait? Okay. So should I go ahead with the case?
So we'll be shifting to room number 1 for FNAC. In the meantime, Dr. Rajesh is going to see the endoscopic ultrasound of this patient.
When we were evaluating the unsealing process, very interesting finding. There's some degree of calcification. Can you appreciate here? And it looks like intraductal calcification. Can you see this?
Yes, yes, it is seen.
And if you see, the only abnormality we could find was there's a hyperechoic area.
So Dr. Puri,
This is more of unsealing process and not head. So anyway, it can be differential, can be 2. It can be inflammatory mass with a background of chronic pancreatitis or a underlying CHOP. So because the history is short, we need to take tissue and make sure that we are not missing our mitotic lesion.
And it's vascular. So the Doppler.
And Doppler we'll put before putting in a needle.
So classical PDAC is hypoechoic and hypovascular.
This is hyperechoic.
This has got some vascularity also with some calcification, upstream PD dilatation. So look like a mass forming form type of CP or a group pancreatitis or maybe a mass forming IgG4 variety. He is a young person, 40 years, otherwise maintained, non-alcoholic and no weight loss and short history. So there is a doubtful indication of FNAC, and since there is a mass lesion, this is more in favor of a mass forming CP.
So really, this looks more of a CP than a real mass, you know.
Yes, yes, agree with you, sir. It doesn't look like a PDAC classical, which we see.
Yeah. Just hold on.
So whenever you are in doubt, you always look for ancillary findings, potential of calcification, displacement of calcification,
So-
duct penetration sign.
Sunil, can you recap the findings on the CT if you have seen it by now?
CT shows bulky pancreas throughout with a prominent duct and the more prominent head of the pancreas. It doesn't look like a classical mass lesion in the pancreas. So it's a bulky head of the pancreas But this is what we see in EUS also. So to me, the first differential would be a mass forming chronic pancreatitis by looking at the calcification in others.
So this is one of the areas when FNAC becomes a little tricky because in the background of chronic pancreatitis is difficult. Can you see my needle?
So you have a needle coming out.
Yeah, just hold on. Just hold on. So I have to position the needle in such a manner that it falls in the trajectory of my needle.
Yes. So the needle will come out from this side.
My needle. So I need to change the direction.
Change the trajectory. Yes.
Hold on like no. Just hold on like this. That's
I think the other area was okay. So, yes.
Can you see that needle?
Yes. This needle is now.
Yeah, the needle is well seen.
Just hold on like this. Just hold on like that because the position. It's a small lesion, a relatively difficult area to target.
So a quick jab and then you enter into the.
Just hold on. I have to take. Just hold on like this. Just like this. This is the hold it, boss. Otherwise, it will go into. I have to change the direction of my needle so that straight away I go into the mass. It's a very small mass. Just hold on like that. Arrow hटा दीजिए. Arrow हटा दीजिए. Just hold on. Hold on.
नहीं needle है.
Needle may not be very well seen because of the background chronic pancreatitis, but just hold on like this. But I have to be clear that my needle is inside the lesion. Can you see the needle coming out?
Yes.
Can you see the needle?
Yes, yes.
Yeah, but I have to be very careful that I'm the lesion. Just hold on like this. ऐसे पकड़ना है, otherwise the lesion will go. Can you see the needle?
Yes.
I'll make a quick jab. The problem is it's such a hyperechoic mass that it's difficult to see the needle inside the lesion. But then I know it's around 3 centimeters from my scope tape. So I put on the lock at 3 centimeters and trying to take the FNA. And the movement has to be very small because the lesion is only 1.7. Slowly I'm doing it. Can you withdraw the still?
Still
we have to withdraw.
Best. Okay.
Can you see the needle?
Yes.
I'm not trying to go deep because otherwise I'll cross the mass and go into the parenchyma. So very small movement in such a small lesion. Yeah. Tissue. Slide it. So uncinate process masses are always a little tricky for tissue diagnosis. Generally use a needle which is thinner. We avoid using 19G needles because it's very difficult to go through a scope which is kind of tortuous. So it's better to use a thinner needle. We generally use 22G needle. We prefer FNB needle. But in this case, we are doing FNA. Okay. See the tissue? Yeah. Tissue.
So Samir, for the benefit of the residents, what are your preferences for the needles in these cases?
Sir, for biopsy, we always prefer 19G needle. But in uncinate process masses or where the situation where the scope is not straight, it is always better to use a 22G needle. We generally prefer FNB, but sometimes it doesn't work. So we use FNA needle occasionally. But 22 is the size of choice. In such cases where the mass is small and the position is a little not straight for the scope. So 22G is a very good compromise for taking tissue in such masses. Otherwise, 19G needles.
Okay.
Because if we want to look at immunohistochemistry, we want to look at stroma.
Yeah.
Someone can focus it here. You got a good tissue also. Camera is there. Focus please. Is पे focus करना भैया.
Fine. Issues okay?
Sure.
Should I take one more?
Yeah, it's a good call.
So, what do you say? One more? No, can you hold the scopus?
Not needed. Beautiful amount of tissue.
Thank you.
Yeah.
Thank you.
Split कर दे. Split
कर. But I'm not sure. Tissue tissue.
No tissue was good.
So we move on to Dr. Puri now. Rajesh, we can see you.
Yes. So I was waiting for you people. So just to demonstrate the little bit of the anatomy, I will first show the problem at the D1. My scope is in the D1. Can you make the a little bit bigger endoscopic image? Yeah. Yeah. And EUS. Can you see the infiltration here? Can you appreciate the infiltration of the first part of the duodenum?
Yeah.
EUS image. I can't focus it. I can't go into the second part of the duodenum with the EUS scope at least. So now I'm in the first part of the duodenum. It is difficult to maneuver my scope into the D1, D2 junction as well as in the D2. So I can only give the limited examination of the view from the first part of the duodenum. You can look at the pancreatic parenchyma, gastroduodenal artery. There is a one lymph node, and this is most likely the portal vein. Is that right? You put the Doppler. So this is the portal vein, gastroduodenal artery, pancreatic parenchyma. To look at the hilum, what should you do? You make your big knob away. Can you appreciate the duodenal wall thickening? Dr. Dinesh, will you show? So this is the duodenal wall thickening. This is the mass here just below. Just below. Yes. This is the liver on the right side. This is the gallbladder with the large stone. And you can appreciate the thickening of the gallbladder wall. But as I said, there is a limited maneuverability of my scope. Sometimes it is difficult to demonstrate the mass. But definitely the gallbladder wall is thickened. You can appreciate here. And gallstones, and on the right side, there is a thickening which is extending, and the duodenal wall thickening. So this case, in my opinion, is an unoperable. You can see the trace amount of ascites also. You can appreciate the trace amount of ascites in this case also. So there's a trace amount of ascites, gallbladder stone with the thickening. Now our plan is to do the EUS-guided biliary drainage. As I said, EUS gave multiple option, but the duodenal route is out because it is a type 1 hilar block. You cannot do the choledochoduodenostomy. You cannot even reach from the first part of the duodenum. Now we are left with the hepaticogastrostomy, or we do the antegrade stenting. This is a small amount of ascites. Can you see here? Can you appreciate the ascites?
This one. Yes.
I think you can appreciate here a little bit amount of the ascites here.
So even the slightest amount of free fluid, it precludes any sort of surgery.
Yes, that precludes the surgery. Now, two important aspects when you are doing the EUS-guided biliary drainage. If you are planning to do the hepaticogastrostomy, can you give me the gauge piece? So then you should focus the segment 3. Can you show the fluoro, please? Now, two important things. This is the left lobe of the liver. You see where is my scope is directing fluoro? Yeah, my scope is going away. So I should direct towards the left lobe of the liver. Can you show the fluoro, please, again? Fluoro, fluoro. This should be the direction when you are doing from the segment 3. This radical needs to be punctured here on the right side. Dinesh is going to say, when you want to puncture fluoroscopy. So my scope is directing towards the left lobe of the liver. That is very important. When you are puncturing segment 3, you are deep down and you make the big knob towards you and you puncture the segment 3. But if you are planning to do the antegrade stenting, and if you look at the MRCP, the left duct goes and it goes up and then it goes down. So taking that big a route is not advisable. Taking the wire first down and then up and then down. What is the plan is, and as I said, here I have no option that I can convert to the hepaticogastrostomy because I don't have a stent. So it is better to opt for a better route. If I fail, then we'll do the PTBD. If I don't fail, we do the antegrade stenting because, as I said, EUS has only one direction, one street. Can you show the fluoro, please? So yeah, look at my scope. My scope is directing towards the left lobe of the liver. Can you show again, please, fluoro? Show the fluoro, please, again. Is that right?
Yes, perfect.
It's perfect?
Yes.
Now show. Just show me.
So
Is that right?
you will have
Can
to
you
check
show?
with fluoro
Can you show
and
the
EUS
fluoro?
image
Yes, that is
simultaneously.
important.
That is very important.
Fluoro? Yeah, this will also be okay. Can you put the Doppler, please? If I puncture this segment, if I puncture here, this will also be good. The only thing is, there is a above segment.
There
So
is
this
a
is the,
vessel which
there's
is
a
coming in
vessel.
trajectory.
Is that okay? If I puncture this,
think,
fluoroscopy,
that's okay.
please.
Yes.
Yeah.
Scope
Okay.
position is perfect.
Yeah, either this, or I will come little more higher. This segment is also possible to puncture. Is that right?
Yes.
We can puncture this segment also. Fluoroscopy, please. Yeah.
I think this is perfect.
This is good?
Yeah, we should go.
Now give me the 19G needle.
Needle.
So the needle which has been flushed with the contrast already. Another important thing is always discuss with your colleague, technical staff, that he should prime the needle. Can you lock it? Lock it.
Rajesh, Dr. Nijawan here.
Yes, sir.
Which segment is preferred, segment 2 or 3?
Sir, when you are planning to do the antegrade stenting, it is always better to use the segment 2. But if you think that the procedure might be unsuccessful antegrade, then it is better to go segment 3. Then you can do the hepaticogastrostomy. Number 2, if you just take care, I will show you. This is the segment 2. And if I show my scope, I am in the stomach. So before puncturing, you just ensure that, can you see I am in the stomach? Can you see the endoscopic image?
It's always better to see on endoscopy that you are beyond the G junction.
Yes, that is important. You can choose any segment, but ensure that you are distal to the EUS image. So you are distal to the G junction. Otherwise, segment 3 is okay. If planning to do an antegrade, segment 2 is also okay. Doppler, please. EUS scope.
So
EUS,
what are you
please.
planning to do here, Rajesh? I mean, which segment are you targeting now?
So I'm targeting segment 2. And as I said, I have only option of antegrade stenting.
Correct.
So that's why I have targeted segment 2, not the segment 3.
Okay.
Yes. Yeah, that's why I'm doing antegrade. Yeah, that's why I'm doing. That's why we are doing antegrade. Now we are not doing antegrade. We are doing. Yeah, that is okay. Now we can leave the. So Dr. Dadish has a question: when the duodenum is infiltrated, why you are doing antegrade? So the few important point: when the duodenum is infiltrated, then definitely you can only do the antegrade stenting. Even if the D2 is infiltrated, you might require to put a longer stent, but D1 infiltration is not the contraindication for doing the EUS-guided. Yes. Can you show the fluoro, please? Fluoro? Yeah, is that okay?
Perfect, sir.
So this is my needle.
So here it is coming. This is.
So another important thing, I will give a jab. Now, just wait. I am in. Now I request to inject a little bit contrast, very slow. Fluoro. Yeah. Show the fluoro, please. Yeah, fluoro. Good. 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 Now you see. Can we enlarge the fluoro? That's okay. Yeah. Now your wire should go down. That is important. Okay. You can inject a little bit of more contrast. Yeah, that is okay. Now you understand how to go? Now flush with the water first. A little bit of the water. Slowly. Flushed. Now put the guide wire. What? Yeah, you can see the common hepatic duct is seen. Yeah,
We have seen in the MRCP, sir. It's a
No,
Taiwan.
we can see the common hepatic duct, na? Yeah, there is a below, there is a duct. See, we can see. Yeah, no, later, after dilatation. Very gentle when you come. Can you make the fluoro little bigger? Can you make the fluoro little bigger, please? Little more bigger? Yeah, now you show. ये वायर हटा लो अपना हाथ उससे हटा लो उससे Can you make the fluoro bigger, please? Just wait. Yeah, put the wire slowly. Slowly. Just see where the wire is going. Yeah, just wait. Yeah, just show the fluoro, please. Yeah, put the slowly, because wire is going in that direction. Yeah, show. No, this is, you remove your this. It is okay. If I face the problem, I have other options. Can you show the fluoro, please? Yeah, put the wire little bit. Fluoro. Now you see what has happened, but it is okay. Have you noticed what has happened?
Yeah, the wire had coiled. Now you straighten.
Yeah, wire is coiled and gone towards the periphery. So I discussed with my technician that before doing that, this is the very important thing. This fluoro has an intermittent, it should be continuous, but we will able to manage. I will take cystotome, then I will manipulate my wire. At this juncture, never remove the wire now, because the shearing of the wire will be, chances will be very high. So what I'm going to do is, just wait. Let me take my needle in. Needle in. Wait. Fluoro on रखना होगा. Yeah, just wait. Just. Now what we do is always keep on checking in the EUS image about your wire. Yeah, show the fluoro, please. Slowly. Fluoro, please.
Gone.
Yeah, very slow.
Gone.
No, your wire introduction is faster, please. We should have 1-to-1. Why I'm telling you? Because I don't want there should be a buckling in the stomach. Slowly, 1-to-1. Fluoro, please. Fluoro, keep on. Keep the fluoro on. Keep the fluoro on. Just wait. The another important thing, always keep the wire in the EUS image. Can you see the? Yeah, keep on changing. Always keep on seeing the wire in the EUS image. That is important. Fluoro, please. Fluoro. Yeah, fluoro. Fluoro, please. Yeah. Put the wire in. Fluoro. Fluoro. Yeah, you have to. Now the wire is finished and he is going to. You can take, please, and number 1. Very important thing.
This is a very important
If there
step.
is no labeling, and I'm very sure my technician is confused. Is it a contrast or is it a saline? So he throw it. So there is a labeling is very important, because if there is a contrast and you exchange, the wire is going to stuck. Yeah, put the saline. Yeah, forcefully. Yeah, fluoro, please. Fluoro.
Intermittent.
Fluoro. Yes, I have come out. Yes.
This is a very important learning step for the beginners and this thing, how to exchange a short wire. They have to have some water.
Now, please put the cap also. Give me the cap. Always do the cap, because sometimes you forget and the air keep on leaking. So please take this. Yeah. Good. Cautery setting, आप endo cut की जो करते हो, EPT की जो करते हो, कौन सी करते हो? 3, 3 and 2.
What is the choice of guide, Rajesh? You leave the point.
So Rajesh, can you walk us through what's happening?
Can you ask me?
What's your choice of wire?
What's the
025 or
choice of-
035?
025.
So avoid sharing. I mean,
Yeah.
035 has got more sharing chances. That's why.
7 French cystotome. Yeah, now I'm using the 6 French cystotome. So I will use the Olympus guide wire 0.025. Now, my cystotome is there. Can you see on the EUS image also cystotome? What are the setting we have done it? Okay. Yeah, endocardi. Okay. So can you show the fluoro, please? Fluoro, please.
Yes.
Fluoro.
You're already in, sir.
Yeah, I want to see the fluoro, please. Show the fluoro, please. Keep a traction on the wire. Show the fluoro. Show the fluoro, please. Fluoro. Yeah, now what I can do, remove the wire. Remove means now, can we shift your patient in the center? Can we do it in the center? यहाँ से आपको हिलाना होगा इसको हल्का सा बहुत स्लोली फ्लोरो नो अपोजिट
आ गया
या और थोड़ा लेके जाओ अपनी तरफ खींचो अपनी तरफ या यस इज ओके या इज ओके now you have to can you show the fluoro please yeah now you have to take the wire in yeah yes good slowly yeah just wait can you show the fluoro yeah put the guide wire now
Dr. Puri,
yeah
we are shifting to the next room. You beautifully placed the wire.
Put the guide.
And we'll be back with you in about 5 minutes. Can you hear me, Dr. Puri?
What was the question?
Dr. Puri, we're shifting to another room for 5 minutes.
Okay.
Right?
Fluoro?
So we'll be back with you in 5 minutes.
Yeah. No.
We're shifting to another case. Here is a patient who has had a hemicolectomy done for CA colon, and she is now being taken up for a screening colonoscopy.
Hello.
Pankaj.
So I am Dr. Pankaj. Am I audible?
It is a surveillance colonoscopy.
Anurag, could you repeat that? We didn't get the details.
All right. So here is a patient who's already had a hemicolectomy for CA colon. This is a surveillance colonoscopy and is being taken up by Dr. Pankaj. Dr. Pankaj.
Good morning. Am I audible?
Yeah.
Yes,
Okay.
Pankaj, you are.
So as rightly said by Dr. Govil that this patient underwent low anterior resection 5 months back, and we are going to do a surveillance colonoscopy to see any more polyps in this patient. Right now I am in the cecum. I have seen the terminal ileum which looks normal, and now the plan is to gradually withdraw the scope and find out the polyps. The scope which I am having is Olympus EZ-1500 scope, and it has zoom functions, and we can see up to 1.5 mm close to the mucosa. So right now I'm in the cecum, and I'm going to gradually withdraw the scope and look for any polyps. The bowel preparation is very good. So we are going to have a very good colonoscopy.
And we are using a X1 series of processor.
Sometimes you see these spastic contractions, and you have to just wait for these contractions to go to see the lumen. We have a functional water jet here. We can do insufflation. It's got very beautiful images.
What are the additional things, Pankaj, we can do to make our imaging better, especially in surveillance when we don't want to miss early cancers, early lesions?
So what we do is we do visualization for the polyps while withdrawal of the scope, first in white light endoscopy. And if we see any suspicious lesion is there, and then we can turn on image enhanced endoscopy, this narrowband imaging, and then we can analyze any polyps. So I will just show you how the NBI looks. So
third generation NBI from Olympus.
Yes. So this is the brightest of these NBI scopes since the Olympus has produced. We have got very bright images of narrowband imaging, and shows in detail the vascular pattern, the differentiation between the superficial and deep vessels. So I'm going again to this is RDI image which has been used to detect bleeding while doing POEM procedures, third space procedures like ESD. And then with the switch of a button, I'm again back to white light endoscopy. So I'm gradually withdrawing the scope. So far, it looks clean. So far, it looks clean. Yes.
We can.
Pankaj,
Sir?
like Fuji, these Olympus people have not introduced AI in this.
AI in this, yes. So the Fuji
No,
people.
sir, actually, they are coming up now in ISG-Con. They'll be launching a endo-brain, sir. So, which will characterize the polyp also and tell us which type of polyp. So, very soon they are coming with endo-brains, sir. In ISG-Con December, they'll
So
be
we have found
launching.
a polyp. So we have found a polyp here. So on white light endoscopy, we can see this. And if we do underwater colonoscopy, we can actually magnify the image. So I'm going to fill up the colon with the water. And then first we are going to do first.
Shall we do the near focus?
Just lost. Where is that polyp? I'm searching that polyp. I think it was a polyp or just a mucosal fold. Turn on the NBI image. It looked like a polyp. Looked like a polyp, but I think it was a fold, I think. No? It was
Dr. Rajesh has very nicely negotiated the guidewire across the stricture.
Can we show the near focus? And
yes.
And now he has opacified that duodenum to make sure that he is inside the duodenum. And now he is opacifying the biliary tree.
The normal pattern. This is the
this is the
NBI.
normal image of NBI.
This is the normal image of the NBI. And you can see the pit pattern.
Now we are getting sounds from the other room also. Kindly switch off the sound that side.
This is the pit pattern. This shows air water is not functioning.
Near focus, I would have.
Yes, now.
This is the near focus function which we have now just see to inspect the area. And then we can do zoom function also.
Yes.
So we are just do near function.
Yes.
So this is the zoom function which we are 1.6x times the thing. So we can.
Dr. Gaurav, the zoom which you are showing, have you put in the hood?
Dr. Rajesh
over the
Puri,
scope?
the guidelines.
That's what is a polyp. There is a polyp.
As rightly pointed out, we have
gone into
we have not put the cap. Ideally, we should have put the cap.
Yes.
But we have not.
So now on the left side of the screen, we can see a small sessile polyp. Let the contractions go, and then we can characterize this polyp.
Hold on, hold on. We'll just let him characterize the polyp and then shift to Dr. Rajesh in a while.
Okay.
In
Thank
30
you.
seconds, we'll shift.
Thank you.
Please.
10 by 8 is fine? 10 by 8. 8.
So actually there is a lot.
हाँ ठीक है. But ये बता दो.
Yeah, Rajesh, you are back.
8 centimeter.
Length is short. हो जाएगा, आठ हो जाएगा. So Dr. Rajesh has very nicely negotiated through the. Can you show the fluoro? The guidewire across the stricture. He has gone deep into D2. What explain you?
No, you are able to hear the voice of Dr. Samir.
Yes, we can.
And he has opacified the duodenum to make sure that he is inside the duodenum. Then he's withdrawn the cystotome. He has opacified the stricture. And now he is planning to, because he has used 6 French cystotome. Now without dilatation, he'll place the stent. What choice of stent will be the Rajesh?
Yeah, it's very important because if you are using the 10 French assembly, sometimes it is difficult and you may face, and I always feel a quick and the easy procedure, especially at the new place, is very important.
Absolutely.
Don't try to do venture. So what we have opted is 10 centimeter, 10 millimeter by 8 centimeter, 7.5 French assembly.
Yeah.
7 French assembly. So that is not going to create any problem in negotiating across the stomach wall and across the liver. So this is a 7 French assembly, 10 millimeter by 8 centimeter.
Yeah. And Dr. Rajesh has opacified the stricture very nicely so as to make the choice of the length of the stent.
Pardon?
Can you show the flow?
Can you show the scope, please?
Yeah, actually.
Scope? Yes.
So he's making sure that his guide wire is
wire.
straight. There is no looping so that his stent goes
Keep
smoothly.
a traction on the wire.
So steps with the technician is very important. I always feel by introducing now, I have reached up to the elevator. Just show the fluoro. Just keep a traction on the wire. Just keep a traction. Now, I have to introduce the stent. I will use both fluoro as well as EUS image. Can you show the fluoro, please? Show the fluoro, please.
Now the stent is coming out of the scope. Yeah.
Show the fluoro. Fluoro, please. Continuous fluoro, please. Fluoro. Fluoro. Scope should also be seen. No, just near the scope. Because the bending can happen there.
Yeah.
That I will going to take care in the last. Yeah. Now my stent is in. Is that right?
Yeah, absolutely.
Can you notice?
Yeah.
So I'm in the left duct. Can you show? And now, first what I'm going to do, I'm going to tell Ramveer to release the stent. What I'm going to see that in the duodenum is the stent has completely open up or not. So will you slowly release?
So if it doesn't open up, then it means we have not crossed the stricture.
Yes.
That's what you mean?
Yes.
Yeah.
Yeah. Fluoro. Open the fluoro, please. Yeah. Open. Slowly. Slowly open. Yes.
Yeah.
Open. Open. Open.
Can you
Yeah.
see-
Can
see
you
the
see the stent has opened up? Very nicely. Just wait now. Can you show the above marking? Yeah. So what I'm going to do, please just wait. Don't open. Show the fluoro,
I'll
please.
keep both ends. Yeah.
Yes. Just wait. Yes.
Yeah.
Now you see this is okay?
Yeah.
Yeah. Show the fluoro. Yeah. Keep on opening. Keep on opening slowly. Slowly. Lower end is open. Fluoro, please. Fluoro. Fluoro. Yeah. Open. Open. Open, please. Open. 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 Open, please. Open. Open. Open.
You can appreciate
Open,
the
please.
structure is long and tight.
Yeah. Open.
So
Open, please. Open. Open. Fluoro. Open. Yes. Have you
Yeah.
noticed completely
it's
is
a
done?
Yeah, long structure.
Now you can see the upper end is expanded, the lower end is expanded, and there is a long stricture. Is that right?
Yeah, absolutely. Very nicely done, Dr. Rajesh. So it basically shows the close coordination between the endoscopist and the assistant.
And if I would have a geobar stent, I will just tell you what is more important. Now this lady has a poor performance status. I agree we can do it. But a young middle-aged man who may go for a chemotherapy, and because of the advancement in the chemoradiotherapy, especially in the CA gallbladder, the overall prognosis is bad. But if it is a cholangiocarcinoma or CA head of the pancreas, the patient life expectancy is longer. So generally what happened is tumor clip and it produce now type 1 goes to type 2 or 3 MB. It is always better you do a bridging as the radiologist does, from right to the left and from left to the geobar, which I commonly do in my practice. Whenever a type 2 block, yes, for few days to few weeks, you may be okay with the one stent, but within 4 to 6 weeks, patient come with the blockage of the other side of the stent. So if you take care in the beginning, you avoid the two procedures. One stent is there, but it is going to prevent the recurrent cholangitis and help the patient for getting the
Plus,
chemotherapy.
you are not traversing the diseased area.
Yes,
Doing it in a
that is it.
non-diseased
Can you
area.
show the fluoro, please? So now I will withdraw the wire above. That is important. Slowly, slowly. Fluoro.
Sometimes the stent may take some time to expand.
Yeah, sometime
So-
it fluoro. Sometime it happens that you see I'm getting
Resistance.
yeah, wire withdraw karo. Withdraw the wire.
So before removing the catheter, you may need
Yes.
to wait for some time for the stent to expand.
Yeah, remove. Is that clear? Yes,
Yeah, nice.
yes.
Very nice.
Fluoro. Fluoro.
Okay.
Fluoro.
There is a small announcement.
So
We
now
will be
I have
having
done
a
it.
panel
And
discussion
I'm
at
going to
11
see
a.m.
the any
There is a
local
slight delay,
complication
but
at
we'll
the
start
site
at
of
11 a.m. with
entry
our
or
panel
so.
discussion.
You see there is a no hematoma, no collection, no evidence of the bile leak at this moment. And we have already drained it. And I'm very sure you will start seeing. You see the IHBR had decompressed immediately. Have you noticed? Now we don't see that much of the IHBR, which was, and the pneumobilia can be seen. Can you appreciate the pneumobilia on the EUS? So that indicate that your stent placement is in the right right place, and that job is over.
Very nice.
Rajesh, wonderful exposition and difficult
Thank
case,
you,
but
Dr.
you handled
Rajesh.
very well.
We will shift to Dr. Pankaj again. He is still doing the screening surveillance colonoscopy.
So welcome back.
Yeah, Pankaj,
Actually,
you're on.
I am gradually withdrawing the scope. Small polyp which we found actually is very small, and lot of peristaltic spastic contractions are there, and just trying to find any other polyp which we can see. But in the meantime, we just show the normal colonic mucosa. So this is the white light endoscope we can see. And
Can
if
we
I
do near focus now?
Huh.
So now we are doing near focus.
And if I turn on the NBI, we can clearly see the superficial versus deep vessels. You can see the large bluish vessels which are in the submucosa.
Now small vessels also.
And these are the small vessels, and this is the
Now-
normal pattern on colon. So you can see very fine vessels are there, which you can see is the normal pattern, normal caliber is there, and in between the whitish mucosa which suggests the crypt and epithelial lining, which is also absolutely normal. So this is a normal colonic mucosa on NBI magnification.
Yeah, absolutely.
Just turn on again white light
Can we
and turn off the zoom, and again I'm going to gradually withdraw the scope and search for any polyp if at all there. I've just come in the sigmoid colon. So here seems there is a small polyp on the right upper quadrant of the screen.
No, it's a mucosa.
It's a mucosa.
Mucus.
It's a mucus. So we have reached the anastomotic site. You can see post LAR, and it appears side to side anastomosis, where we can see one limb is going towards the ileum and one is the blind limb. There is end to side. This end to side anastomosis. So these are the surgical clips. You can see the anastomotic site looks healthy. We'll just turn on the NBI image here, and can do underwater colonoscopy. So if you do underwater colon, it actually magnifies the mucosa without any optical function, and if you do underwater colonoscopy, it's comfortable also for the patient. Studies have shown if you do underwater colonoscopy, the patient has less post-procedural pain and discomfort, and it also magnifies the image.
So in your day-to-day practice, do you follow underwater or only in specific situations?
If we do the procedure without sedation, most of the times we do colonoscopy under sedation only. But some patients where the patient has refused for sedation or we are not giving sedation, then I would like to do a underwater colonoscopy. But very important, the patient should have a very good preparation to do underwater colon, like this patient. If you have a very poor preparation or the preparation is not adequate, then obviously you can't do underwater colon these patients.
And
so it sometimes
underwater EMR also, if we can see small polyps,
yes,
it will be
we can do underwater. It's a safer alternative because of the buoyancy of the water. The polyp lifts up naturally. It lifts up, and very easy to do a underwater EMR. So we have reached the rectum actually, and looks normal. So the patient is safe. She looks okay post surgery.
So I think we can shift to other room.
We can shift to other room.
Javan, can you hear me there? Is Dr. Nijawan there in the hall?
Yeah, we can hear you.
Yeah, Anurag, what's the next case now? So now if we have done with this, we propose to end session 1 live session for today. May we shift to the panel discussion there in the hall now. So we will have the panel discussion, and very soon after the panel discussion, we will be back with you for the next live demo session. Thank you.
एक बार यार इसको देख
Signing off from here.
Off screen देख ले.
I would thank all the moderators of this session. And we would now move to a very interesting panel discussion on cystic tumors of the pancreas. And I would invite the speaker, Dr. Samanta. Are you here? And the panelists, Dr. Kapil Jamal, Dr. Vivek Bhargav, Dr. Itish Patnaik, and Dr. Sandeep Jain.
Good morning, everyone. As the panelists take their seats, I'd like to once again thank Sandeep sir, Sandeep Nijawan sir, Rakesh Kalla sir, and Mukesh Kalla sir, and all the team of AE4 for giving me this opportunity. It's an amazing conference, and we'll start with the panel discussion. So the panel discussion is on cystic tumors of the pancreas. Cystic tumors of the pancreas is something probably we do not encounter as often as as the West reports. Probably that must be because of lack of surveillance interventions that have in the West, and obviously because of maybe some of the reasons of the health reasons and all that. So I'll start with a very common case scenario. There's a 56-year-old female, known diabetic, was being evaluated for dyspepsia and found to have this suspicious lesion, as you can see, on the pancreas and ultrasound, and then underwent a pancreatic protocol CT, which revealed this cystic lesion. Patient had no pain abdomen, no past history of pancreatitis, etc. Referred for US. You find this kind of a lesion. So what to do next? So basically, how do you approach a pancreatic cystic lesion? Let's say asymptomatically diagnosed or incidentally diagnosed, or diagnosed with very, very oligosymptomatic, because majority of these will present with this only. So I'll go to my panelists and start with Dr. Kapil first. So Dr. Kapil, what are the, these kind of lesions must be coming very commonly in your clinical practice. So what are the differentials that you majorly think of? And what is the concern? Why do we need to even bother about these kind of cystic lesions, which are incidentally detected because the patient doesn't have any symptom?
So as Jayanta pointed out, so most common cystic lesion which we see as gastroenterologists are pseudocysts, which is incidental, and patient, but only thing is patient complains of a history of pain, and there's a retrospective history is there. But other lesions which are there, like we have benign and malignant. Benign are like which is uncommon, like hydrated cyst of the pancreas.
Right.
And malignant are like the cystic lesions, which are like IPMN,
Right.
which can be a branch duct or a main duct, or can be a SCN or a mucinous cystic neoplasm. So these are the commonest lesions which we see. And why it is a concern? Because if this converts into a pancreatic cancer has a very high mortality. And if we see, we don't have a large data from our country, but if we see the US data,
right.
So it is one of the deadliest cancer, and the incidence is increasing. Maybe the diet and the metabolic factors, or the and the detection is increasing, and the malignancy has a very worse outcome. That's why it's a concern for all of us.
Absolutely. So, so that's as Dr. Kapil has mentioned about that. We're going to, for the panelists, we're going to concentrate now only on the pancreatic cystic neoplasm part. We're going to not discuss now pseudocyst. We're going to concentrate on the pancreatic cystic neoplasm. So, as Dr. Kapil has pointed out, that it has been growing in incidence. The detection prevalence has gone on increasing. And this is one of the data which shows that more than 8 years, almost close to 40% of the patients have some kind of a pancreatic cystic lesion. And obviously this has become or gone on to increase probably because of because of the more and more imaging that are being done nowadays, which incidentally detects. I think I'll come to that to Dr. Vivek. And the classification as Dr. Pankaj was, Dr. Kapil was mentioning that there are epithelial cysts, non-epithelial cysts. We're going to concentrate primarily on the neoplastic lesions and non-epithelial cysts, primarily which we commonly encounter are the pseudocyst and the parasitic cyst, as hydatid cyst, as Dr. Kapil was mentioning. But we're going to now concentrate primarily on the neoplastic epithelial cystic lesions. There is IPMN and mucinous, and the serous cystic neoplasm, etc. And as Dr. Kapil aptly mentioned, that there is a higher risk of pancreatic cancer because these cystic lesions, they themselves not only go on to develop pancreatic cancer, they create a field defect, right? Dr. Kapil, what do you think? They create a field defect because of which the pancreatic cancer can develop in any other side of the pancreas and not necessarily in the de novo cyst itself, right? So this is the cystic, the risk of malignancy in the main duct IPMN is as high as 68%, and mixed is around 38 to 65%. And why do we need to basically improve the diagnostic modalities? Because there's a huge amount of risk of inappropriate resection. I'll come to my surgical colleague soon. But then probably a lot of these cystic lesions, because of the fear of, later on malignancy, these cystic lesions gets resected, and eventually they found out that these are non-neoplastic, which probably has a very, very, very low chance of going into development of neoplastic lesions. So I'll come to Dr. Itish. So these cystic lesions, what we are talking about now is the pancreatic cystic neoplasms we are talking about. We'll start, because for the sake of the audience, we'll start from the clinico-demographic profile, which helps us to kind of corner or, come to a diagnosis as to what this kind is likely to be. So what do you think? What are the common, let's discuss about the common clinico-demographic profile that we talk about in these kind of pancreatic cystic lesions.
So definitely clinico-demographic profile is very important because it narrows down our differential. And in one line, if you say all of the cystic neoplasm are common in females, except two, that is one is IPMN, which is distributed equally between male and female, and cystic neuroendocrine tumor in the pancreas also, which has equal male and female distribution.
Absolutely.
And if you see that regarding age of presentation, the serous cystic adenoma also shown in the picture, it is called grandmother cyst, right, because it presents in the 7th decade, and mucinous is 4th to 5th decade. Right. And solid pseudopapillary neoplasm, it presents usually 2nd to 3rd decade. So it is a daughter
population. Yes. So
then
please carry on. Yeah.
Yes. So regarding this is the age of presentation. Now coming what is the clinical character? So usually most of the cystic neoplasm, they are asymptomatic usually. So except IPMN, which will have more symptoms. So that is one. Serous cystic adenoma, usually asymptomatic, incidentally detected. Only thing it can produce is like compressive symptoms whenever it goes very large, and you usually not common to find such lesions. So mucinous, again, it is exclusively in females, almost exclusively in females, and located in the body of the pancreas mostly. And so they are also asymptomatic. Maybe few patients, like up to 20%, may have pain abdomen and may present as a lump, but again, that is one. So regarding the pseudopapillary variant, and usually they come on with present in young female with a vague abdominal pain. Yes. And there is no specific symptoms for that. And incidentally, you found an imaging that is a lesion in the pancreas which has solid and cystic component. Right. Regarding side branch IPMN, again, it is two types: side branch IPMN, main branch duct IPMN. Side branch IPMN, it is the most common variant of cystic neoplasm, which is almost like asymptomatic and doesn't have much malignant potential, while the mucinous main branch IPMN will have recurrent pain or recurrent pancreatitis.
Right. So we are basically more concerned about mucinous variant, be it mucinous cystic neoplasm or IPMN and side branch IPMN that you're talking about. Right. Absolutely right. So, and obviously there are various classifications of IPMN as we talk about, and Dr. Itish pointed out there can be main duct IPMN, branch duct IPMN, and a combined type. And obviously we are concerned about mucinous and IPMN variants because they have a very, very high risk of developing malignancies. SPEN already Dr. Itish talked about. So I'll just summarize whatever Dr. Itish told us, that what are the characteristics of the different pancreatic cystic neoplasm that we talk about? So if you look into the age criteria, majorly will present in the 5th to the 7th decade, except for SPEN, as you rightly pointed out, that will be around in the 2nd to the 3rd decade. Again, gender predilection, Dr. Atish has already pointed out that majority are female predominance, except for the IPMN and the cystic neuroendocrine tumors. As far as symptomology is concerned, most will be incidental. They all will be asymptomatic, except for the SPEN variant, because SPEN are symptomatic, and that is probably one of the reasons why they present early on, because they'll present with the symptoms and obviously will be early presentation. Imaging wise, we'll shortly come to later on. And obviously, some of them will be communicating with the MPD, some will not. Like IPMN variants will be communicating with the MPD, the others will be not. And the number of sins majorly will be solitary, except for the IPMN, which may be multiple. And again, the most important thing probably Dr. Atish was pointing out is that the malignant potential is important, right? So when we talk about serous cystic neoplasm, these gets detected in the elderly, most like incidental, because they don't do anything. They have a very, very negligible neoplastic potential. On the other hand, the branch duct IPMN has a potential of almost as high as 1/3. SPEN and CNET will be around 10%. Mucinous cystic neoplasm will be close to around 40% at the highest level, but the most malignant potential probably is 36 to 100% will be the main duct IPMN or the main duct IPMN that we talk about. Now I'll come to Dr. Vivek. Sir, once the patient gets referred to you, let's say, some outside ultrasound done, just as we were talking about the clinical scenario, and we find that there is a cystic lesion. So what will be your approach as to what should be the choice of the imaging modality, one? And then once you have done that imaging, how do you kind of come to the diagnosis based on the imaging characteristics as which kind of lesion this is?
So I think when the patient comes with already an ultrasound done on that patient,
Right,
I think
sir.
MRI and MRCP will be the best choice.
Right, sir.
So we want to actually see on MRI. Can you hear?
The sound is low actually. Can the mic be changed or something?
So we want to see the communication of the lesion with the pancreatic duct or its side branches. That's very important.
Right, sir.
So that's why I think MRI is the only modality which can clearly show the communication between the cystic lesion and the pancreatic main branch or with the side branches.
Right, sir.
And we can take very thin sections.
So as per you are saying, sir, that MR with MRCP will be the best modality of choice. Is there any situation under which you want to do and maybe an additional CT or any other imaging modality you want to?
No, if suppose
resort to.
If suppose we want to do an aspiration or we want to biopsy certain thing, then EUS is the best modality in which you can, especially for the solid lesions, we can take biopsy from that lesion. And if there is a liquid component, then we can aspirate it and do a CEA test or a, there is also a vascular epidermal growth factor, which is very high in the serous cyst adenoma, almost greater than 16,000. So that's also diagnostic for serous cyst adenoma. So we can, if suppose we are suspecting pseudocyst, then amylase will be very high.
Very high, sir.
So we can actually do the tissue diagnosis as well as do the chemical diagnosis so that we can come to some conclusion by taking biopsies or aspiration by EUS.
Absolutely, sir. So can you run us through the imaging characteristics that will tell you or maybe make a guesswork as to what this kind of the nature of the lesion as per the MR? Let's say you have got an MRCP or MRI done.
Suppose it's a pseudocyst.
Right, sir.
Then we take a history whether the patient is having pancreatitis or he is having a regular alcohol intake.
Yes, sir.
So that then again, if we want to do a MR scan, we do with the contrast study.
Right,
There
sir.
will be no nodular enhancement in that cystic mass lesion.
Right.
There may be some hemorrhagic area or cellular debris, but there will be no enhancement of the wall or any nodular component in the cyst.
This is an important point to note. Yes, sir.
Then we come to next serous cyst
Serous cyst.
adenoma.
Yes, sir.
So it has got a characteristic honeycomb appearance and like a sponge, where there will be multiple microcysts which are more than 6 in number.
Okay.
And sometimes in the center of the lesion there is fibrous stroma, which can also calcify later on.
Right, sir.
So this can also be
So
seen.
primarily it will be a multicystic kind of a honeycombing
Multicystic
pattern with some
honeycombing.
kind of,
Yeah.
central fibrotic calcification,
Yeah.
something like that.
It does not obstruct biliary tree or
Right.
pancreatic duct.
Yes, sir.
When it's small, but when it's very large, then it might
It
obstruct.
might cause symptoms,
Yeah.
and then you can come.
Yeah.
So next will be IPMN, sir.
Now, if we take IPN, we see a pancreatic duct dilatation upstream.
Right, sir.
We have to exclude any calculus within the duct so that we can at least rule out chronic pancreatitis. If that is excluded, then we can say there's something is there in the duct that is obstructing the pancreatic duct, and there is upstream dilatation of the
Right, sir.
pancreatic duct as well as the side branches.
Okay. So the side branch will not be causing a dilatation primarily of the main duct.
Yeah.
But obviously a main duct IPMN will cause a distal dilatation, and then we can kind of,
Yeah.
get an idea of it. And what about SPEN, sir?
In SPAN, actually, we see a young patient, and there will be a solid component initially, which later on necrotize into cystic components. And when we do a contrast scan, then this nodular components enhance.
Right, sir.
These nodular components enhance while the necrotic portion do not enhance. So we come to a conclusion. We can also see metastasis in the liver. Often we can, in these patients, the
Right.
SPAN patients, we can also look for those metastases also in the liver.
Exactly. So as Dr. Vivek has pointed out, that the choice of imaging will be MRI and with or without MRCP. And obviously, I think PET scan is something which we should not be doing. This does not probably give us any additional benefit or any additional information over and above what you're going to get from MR and MRCP. What do you think, sir?
I don't have any information about PET, but I think MR is good enough to
Get the diagnosis. Yeah. So even the guidelines, if you talk about all the guidelines that I've talked about, they always talk about MR and MRCP. So once we have got this cystic lesion, we have understood what is there. So I'll come to my surgical colleague, Dr. Sandeep. It is always an honor to have a surgeon amongst us in the gastroenterology forum. So, sir, I'll ask you that you are the person who's going to decide what to do of the cyst. We all are just going to do the diagnosis. Rest is up to you, sir. So how will you risk stratify based on whatever the imaging findings that we have as to how to go about further? What is your to-go kind of thing?
So basically, when we say risk stratification of cystic tumors, we mean actually whether there is any potential of them being malignant or not.
Right, sir.
And so we have to, in that case, would consider a surgical resection for those tumors. And risk stratification actually in this particular field starts when you have everything. You have clinical findings, presentation, examination findings, and imaging.
Right.
It is always, in this particular field, it is retrospective risk assessment with all the three things combined.
Right.
So when you have a patient who has presented with pain abdomen, jaundice, suppose, for example.
So symptoms is one thing.
Yeah,
Symptomatic pancreatic cystic lesion, right?
Basically, there are three things in totality for
Right,
risk
sir.
assessment broadly categorized wise: symptoms or presentation, which includes physical examination,
Right, sir.
and imaging, and then biomarkers or chemical analysis if we have already done that or we are planning to do that.
Right.
So in presentation, pain, then jaundice,
Right.
then if there is history of recurrent pancreatitis, of course it is not seen very commonly, but if it is, then it is a pointer. And then imaging, if you have a clear-cut case of serous cyst adenoma, then it's a closed chapter for that particular moment. But if you have MCN or IPMN, then it becomes important to see the size of the tumor, its communication with the main pancreatic duct, its anatomy with respect to the rest of the pancreas,
And ductal
its
dilatation and all.
intracystic radiological findings, be them septae or neural nodules, absence or presence of vascularity. Then you may have to consider the peripancreatic lymphadenopathy, involvement of the retropancreatic splenic vessels. So all these things, if during this stage also there is a confusion, then endoscopic ultrasound guided cyst aspiration and
Would be
analysis. like for example, CEA levels
Right.
and CA 19.9. CA is very important. We may not have all the kinds of tumor markers available.
Right, sir.
But
We'll come to
CA
that discussion shortly, sir.
Yeah.
Yeah.
So
and
these,
and what about the worrisome features that you talk about, right? Like one is that you go directly send for surgery, right? You directly decide that you're going to take the patient for surgery, and then obviously there'll be a sub cohort where I would like to do a surveillance kind of a thing, right?
can I just make one point
Yes, sir.
regarding your risk assessment thing? So when we consider the MRCP versus CT scan,
yes, sir.
Actually, it is practically impossible to rely on one imaging to do the risk assessment and the treatment. So our message should be that you may select MRCP as the first line of investigation.
Right,
but until you do both contrast enhanced CT scan and MRCP, then only you would be able to do the proper risk assessment and the definition, I mean, the decision about the future line of course.
Right, sir. So the question now lies is that what additional information are you looking for in the CT, which you won't get, you think you won't get from MR or MRCP, sir?
Like for example, many of the intracystic characteristics may not be visible on MRCP.
Okay, sir.
Then its relationship with the pancreatic vessels surrounding lymphadenopathy,
So for your resection
associated
purpose
pancreatic anomalies. So all these things, and as we have discussed right now, the risk assessment part, it includes many features which are more better seen in CT scan than MRCP.
Right, sir. Okay. So as Dr. Sandeep had kind of pointed out, the how do we risk stratify? So for the benefit of the audience, I'm just going to kind of summarize what he told us, that you can clearly think that this is not, I mean, the cyst is safe, and you can just let it go is if the size is less than 3 centimeter, no nodule, solid component, no ductal dilatation. Obviously, any patient, as Dr. Sandeep aptly pointed out, if there is an obstructive jaundice with cystic lesion enhancing mural nodule more than 5 millimeter or a ductal dilatation more than 10 millimeter, then obviously this is a cohort of patient where we will upfront do a surgery. And then obviously there will be a cohort of patients where there is a worrisome feature as we talk about. So whenever there is a worrisome feature, like let's say the patient had a history of pancreatitis, cyst size was more than 3 centimeter, mural nodule is less than 5 millimeter, enhancing cyst wall, or the ductal dilatation is between the to go and not, that is 5 to 9 millimeter, abrupt change in caliber, or there is a rising CA99, etc., etc. So these are certain worrisome features where we probably, as you had aptly pointed out, then you go ahead with cyst fluid analysis and try to find out what more to be done on this aspect, right? That's what we discussed, right?
Yeah, absolutely.
Okay. So from here, then probably, so once is we know if the cyst is safe, or we know that the cyst has to be resected. In between the two, obviously, if there is a worrisome feature, we move ahead. So I'll go ahead to Dr. Kapil. So Dr. Kapil, when the surgeon will send you, so when do you think you're going to do an EUS? And what about contrast enhanced EUS?
So as Jayanta, you have pointed out in the last, so normally if the patient is in between dilemma, so normally if the patient has upfront malignancy, looking on features on radiology, so we don't do EUS. And if size is less than 3 centimeter, all as per Fukuoka and the AGA guidelines, we don't do anything. So size more than 3 centimeter, there's upstream MPD dilatation.
Right.
And there's cystic nodule or there's increased vascularity. So these are the main criteria which, if the patient is not fulfilling in the diagnostic
In
modality,
absolute surgical criteria, right? So the surgeons wants more information from us, something like that.
Like if the patient has a lesion in the tail of the pancreas, surgeon may not ask us because lesion is easy. But suppose lesion is in the proximal body or is in the head,
Absolutely.
where he will require more radical surgery like a Whipple's
Right.
So in those scenarios, we may by these criteria which you are showing. So one is size more than 3 centimeter, presence
Right.
of mural nodules.
Mhm.
Then there's upfront dilatation of the
Dilatation,
duct.
ductal
These are the
dilatation.
major criteria which we consider for considering for this one.
EUS for assessment, characterization, as well as analysis of the fluid, right? So
And you said about contrast enhance EUS.
Mhm.
So it's basically for the nodularity part of the wall. Suppose we are not able clearly to find out what is happening.
Right, sir.
So in those cases, the contrast enhancement will tell whether it's a vascular nodules or not. So if vascularity is present, that means it is a malignancy,
Right.
and patient should be offered surgery or a curative therapy and should not be kept for surveillance only.
Right. So that is what I'll just summarize what Dr. Kapil just pointed out is that US are we going to do when the surgeon sent to you because we do not know whether we're going to operate on the case. There are some worrisome features, but we want to more characterize the lesion, whether it's mucinous or not, and whether we're dealing with anything else or not, and then kind of try to find out. So these can be the kind of features that we can have in mucinous cystic neoplasm, SPEN. These are the US features that we can have. And the data on the safety and efficacy of pancreatic cyst is very, very nice. This was one of the analysis which had shown that the accuracy for specific diagnosis is US is as good as, US is definitely better than CT, but obviously not as good as MR as Dr. Vivek had pointed out. And obviously, as Dr. Kapil pointed out, that the need for contrast enhanced US will be to characterize the mural nodule because it can as well be just a sludge ball or some mucin can be there. We need to kind of differentiate it from the mural nodule to have established the character of the mural nodule and obviously the vascularity pattern and then kind of comment on it. So from there, once we have done, we have characterized on US, the cyst, what is there. Then I'll come to Dr. Itish. So then would you like to now go ahead with doing a cyst fluid analysis? So my question will be very specific that let's say you have gone to do the EUS. What are the situations why you will think that even if the surgeon has sent it, let's not do the cyst fluid analysis? And what are the conditions where you actually go ahead with doing the cyst fluid analysis? And what are the tests that you're going to order after the fluid you have aspirated?
So majority of the cyst, they do not require EUS or fluid aspiration.
Right.
Like in serous cystoadenoma, the morphology itself says that it is serous, so you do not need to do any further analysis. Regarding mucinous also, if there is no worrisome features, like cyst is small, without solid component, no non-dilated duct, you do not require, patient can be followed up. So aspiration comes when the patient is, most of the cases, the surgeon demands that we require aspiration. That is one scenario. Otherwise, there is indication like...
Very good question. I'll just interrupt you. I'm going to ask Dr. Sandeep, why do you surgeons many times we think that it is okay. I don't think there is a reason for you to aspirate. Why don't you go straight away, do the surgery because this patient is, let's say, have a 5 centimeter lesion. Something is there. Why do you want an aspiration? Many of my surgeons, everybody has faced this problem. I mean, the gastroenterology have faced the problem. Why do you need a cyst aspiration?
Cyst aspiration is indicated if there is, as you said, the gray area, borderline, the middle segment,
right,
where you are not sure the malignant potential of that cyst. It's a part of the so it was part of the risk assessment thing. So the cyst aspiration is also actually the part of risk assessment thing. So if during the risk assessment you are not sure what you are dealing with and whether it needs a surgical consideration, then you have to probably go for cyst aspiration.
Right. So I'll get back to Dr. Itish that what are the tests that you're going to kind of order now?
So, apart from that, I will just add one thing that whenever the cyst morphology is also not clear. Right. Let's say patient has a multicystic lesion presenting with a fever or some alarming features, then also that becomes an indication for aspirations and also rapidly enlarging cyst size more than 3 millimeter per year, but it varies according to the guidelines. Regarding the sending for the test, obviously the first you identify the morphology and identify after aspiration, tend to aspirate the entire content if possible. And if it is a multicystic lesion, you target one component and aspirate the entire content within that component. That is what to prevent infections.
So this is a very, very important point that Dr. Itish is making, that whenever we aspirate, we make sure that we aspirate the whole amount of fluid because always there is a risk of secondary infection of the cyst and then we land up in problem. And even the surgeons will going to then face a lot of problem during the dissection. Yeah, please carry on.
Then it may not be possible always to aspirate the entire content. That is also a thing. And based on the morphology, if you think this is a clear content on the US, there is no echogenic content, then 22G suffice. But if it is thick mucinous, then you might end up doing 19G may be required. So regarding cyst fluid, first thing is like morphology, clear, usually mucinous cystic neoplasm, they are clear contents. And during aspiration, maybe you get some blood due to hemorrhage. Regarding analysis, obviously there are, you should know that whenever I'm sending for cyst analysis, it will tell you whether it is a mucinous or IPMN versus other cysts. It will not
Right,
give you a
right.
diagnosis.
We differentiate between mucinous and non-mucinous.
Mucinous
right.
and non-mucinous. It will not give a diagnosis. So that is the aim. So one thing is like cyst with amylase, and if it is like less than 250, it is unlikely to be pseudocyst.
Right.
Normally, you will see very high in thousands that
Mhm.
cyst with amylase content. The second thing is string sign, which is very important, has to be done in all cases.
Mhm.
So we put a drop of the fluid over the slide and take another slide and touch it and lift it.
Right.
A string sign is positive, especially the string is more than 1 centimeter in length and it is lasts for 1 centimeter, more than 1 second. It is highly specific for diagnosis of the mucinous,
Of the mucinous
lesions.
Mucinous character of that
Yes.
fluid. Right.
So cytology is very confusing. Means clinical
not very good.
practice, yes, rarely it is helpful. But if we suggest suspicious, even the cytology is suspicious, that is good enough.
So the specificity is higher, but obviously the
Yes,
sensitivity must be low.
sensitivity is low.
Right.
Regarding, there is two other markers, CA and glucose.
Yes.
And glucose has come up recently. CA obviously, as you have mentioned, less than 5, it is non-mucinous, and more than 1 entity is likely mucinous. Again,
Right.
the sensitivity is not very high. Glucose supposed to be better than CEA, but again, the cutoff of the glucose is still taken as a
We
50,
still do
but
not
it's-
know, but probably certain data is coming up with meta-analysis showing that probably glucose can better predict mucinous as compared to right. And obviously beyond this, obviously we can do a lot of molecular markers are nowadays coming up. Obviously these are all experimental, not in day-to-day clinical practice, but we can do all these molecular markers in order to understand what is there. So we have taken the fluid, we have taken the cyst fluid. Dr. Kapil, I'll come to you. Do we need to do anything more beyond the cyst fluid analysis? Or do you think that there is a need for, let's say, a confocal laser endomicroscopy or a through the needle biopsy? So these are newer things that are coming up, people are doing. So what is your take on that?
So if you see the data and then patient can undergo a CLE, that is confocal laser endomicroscopy. Only problem is it will enhance the cost. And the problem is what we find is that it is expertise is less and device is not available everywhere. So you have to refer it to patient to higher centers. If you see the data shows it's superior to very high sensitivity, specificity with very high predictive value. So it can diagnose. Only thing is, can a patient benefit? Suppose what surgeon told that there's a 3 centimeter in the tail of the pancreas. So would you consider doing a CLE?
Right.
Suppose a patient has a in the head of the pancreas where patient will earn a Whipple. So in those conditions, you may require test, and if affordable, then we can do.
So probably we still need to find a place for doing a confocal laser endomicroscopy. Quickly, I would like to ask you, what is your take on through the needle biopsy? The More forceps, I think this conference has also shown through the needle biopsy.
So it was,
what is your take on that?
It came as a fashion initially in 2010, very high data showed, or it can go through the same US scope only, FNA needle, and can take biopsy forceps. My concern is that what data shows, it has a very high complication rate, around 10%. Patients can develop complications.
I guess the bleeding rates are high.
Bleeding rates are high, pancreatitis rate is high.
Yes.
And if we are just doing for diagnosis and the surgeon is not very keen to operate and we land up patient developing a complication, so it's better than to avoid it.
Better to avoid. Okay. So if probably there is some suspicion or probably we do not get adequate information from cyst fluid analysis, probably we might think of doing a through the needle biopsy.
If you have available devices, you can do. Only thing is, it will add up on cost of basis to the patient. And if we consider a biopsy forceps, so we have to explain to the patient that he may land up into complication like bleeding and pancreatitis in up to 10% of patients.
So I'll just quickly ask both of you. People sometimes do pancreatoscopy in cases of IPMN. What do you think about that? This is just the data that I'm showing, but I just wanted to know your opinion on this. This is a meta-analysis that shows this.
So I don't do in my clinical practice.
I
don't consider pancreatoscopy changing the diagnosis of a patient who has developed suspecting
IPMN.
cystic lesion.
Dr. Sandeep, do you want to know the extent of the pancreatic duct involvement via pancreatoscopy before doing your surgery?
Actually, it is not of much use. Suppose I think you are asking for a patient where surgery is already contemplated.
Yes.
And so in that case, actually frozen and intraoperative finding. Yeah, because in any case, you have to do a frozen of the resected margin. So pancreatoscopy, I don't think make much of a difference.
Right.
So pancreatoscopy is something which we probably do not do it. So I'll come to Dr. Sandeep once again. I think when to do surgery, we have already discussed, right? That the symptoms are there. So I'll not go into the details again. There are some data which shows that probably size is not the only thing. Mural nodule and other things are obviously there, pancreatic duct dilatation, etc., etc. I'll just skip these slides for want of time. And obviously across the guidelines, people have talked about these major things. So if the cyst size is more than 3, duct is dilated more than 5, jaundice, solid component, mural nodule, cytology with high-grade dysplasia, etc. Once you've done a cyst fluid analysis, obviously it makes a ground for sending the patient towards the surgeons. So what are the surgical options that you want to go ahead with, Dr. Sandeep? What is your usual clinical practice?
Yeah, it's pretty straightforward depending on the location on the pancreas. If it is head of the pancreas, then Whipple's is the only option we have got. If it is in the body and the tumor is small, then central pancreatectomy or median pancreatectomy is one of the options, but we find a very limited number of cases suitable for that procedure. And body and tail is distal pancreatectomy. With splenectomy, most of the times, if we are either doubtful of malignancy or sure of malignancy. Suppose there is a tumor which is anteriorly, more often anteriorly placed, and we are sure either by frozen or by preoperative radiology that it's not malignant, then we may consider in rare cases distal pancreatectomy, which is spleen preserving.
Okay. But otherwise, you sacrifice the spleen as well.
And the approach is also important to know that most of these procedures, in fact, all of these procedures can be done laparoscopically.
Right.
And then robotic also.
Do you ever consider prophylactic total pancreatectomy versus segmental dissection? What is your clinical practice? Do you do segmental dissection or total pancreatectomy?
Total pancreatectomy as a prophylaxis only in one condition. In my own experience, we had a patient of VHL with multiple cystic lesions of the pancreas, but the indication of surgery was not that. It was multiple neuroendocrine tumors in the pancreas.
Okay.
So for that reason, we had to do total pancreatectomy.
But otherwise, it is segmental dissection to go with.
Exactly. Even in IPMN, even if there is evidence of radiological evidence of disease in rest of the pancreas, if frozen is negative, even then there is no indication of total pancreatectomy.
Okay. So obviously you do a frozen section, decide on what the level of your involvement is. So that is the reason why pancreatoscopy becomes obsolete, right? Because they are already doing the frozen section out there. Right. Absolutely. And what about pancreatic enucleation for side branch IPMN? Just a few.
See, it's not about the whether the tumor is side branch or main branch. Its relationship with the main pancreatic duct. Because enucleation is a risky procedure, because even if it is a side branch IPMN, the risk of injuring the main pancreatic duct while enucleating the tumor is very high, and that is a very deadly complication. So either we do, it's a very, very superficially placed tumor, which is a it's a theoretical option, possibility. And if we navigate the surgery doing intraoperative ultrasound and see that while enucleating, we are pretty sure that MPD is not, damaged.
Right.
Then it may be possible. But for IPMN,
for all practical purposes, we do not.
For other tumors, it is like for insulinoma and all.
Right.
But for IPMN,
we do not go ahead with
it should
any
not
kind
be
of
considered.
enucleation. Correct. And a brief question to both Dr. Yatish and Dr. Kapil. People are nowadays doing this RFA for pancreatic cystic lesions. Your thoughts on that?
I do not have experience of RFA or alcohol injections.
What's your? I understand. Not many of us have the experience, but what do you think of the idea, the concept of doing this RFA for pancreatic cystic lesions?
One thing, if patient is not fit for surgery, then I think further treatment is rarely helpful. So in this RFA regarding this cystic neoplasm, I don't think it's robust to do that as a routine practice for a patient.
So I think
only if you are surgically, those who do not deny surgery and unfit patients, and there is risk of metastasis or high risk features, then you may consider, but again, that is matter of
so once we have done with this, we decided not to go ahead with surgery. I'll come back to Dr. Vivek. How will you, sir, we're going to carry out the surveillance?
So basically, it depends upon the size of the lesion. If the lesion is larger, we have to do a quicker surveillance, say 3 months, 6 months.
Right,
If
sir.
it's smaller than 1 centimeter, then we might do after every 2 years or 1 year interval.
So the size of the lesion will obviously kind of decide on how frequently we want to kind of do the surveillance.
Yeah.
Like less than 1 centimeter every 2 years is good enough, 1 to 2 slightly closer, and maybe even more than 3 centimeters is there. The patient doesn't want a surgery to be done. Then if we want to do a surveillance, probably it has to be done every 6 months, or a close-up surveillance needs to be required, something like that. Right, sir. So that is how we do it. And once we have done a surgical resection, probably mucinous, Dr. Sandeep, for mucinous, once you have done a surgery, I don't think you further require any surveillance, probably. Or you do?
No, it depends actually. If suppose biopsy shows adenocarcinoma, then
right.
the surveillance, as for any other cancer, you have to do that.
Right.
But if you are sure on histopathology that it's a benign mucinous carcinoma, mucinous lesion, then you need not have any kind of.
So the message is very clear that if there is an invasive cancer on that surgical specimen, obviously we will...
Cancer or even some kind of dysplasia, high-grade dysplasia, for example.
High-grade dysplasia and all that. And obviously for IPMN, patients will, even if there is a segmental resection, they'll require lifelong surveillance because...
Of course, because
it's a field defect.
Because the difference between MC and IPMN is that in IPMN, you are just removing the tumorous part of the disease.
Yes.
The rest of the pancreas, you are not
basically
sure.
a minefield.
Yeah.
Anywhere an explosion
So
can happen.
it can happen in another part of the pancreas.
Right. Absolutely. So that is how you do the surveillance if you're not resecting versus if you're resecting. There are certain caveats I just to mention that all these guidelines grade the evidence to low to very low quality because basically we don't have enough data because the disease in itself is so scanty and sparse. It is difficult to interpret what is worrisome or high risk. And obviously the pancreatic cystic lesions subtype specific recommendations have not come up because some subtypes have high malignancy risk as compared to the other subtypes. And we still probably need better advanced imaging and diagnostic tool. This is a very, very interesting study that is coming up, an international collaboration study, Pacific study, where they are kind of going to follow up patients for over more than 10 to 20 years and then kind of try to come out with the data. So I'll briefly come to the algorithm. So any patient of unsuspected pancreatic cystic lesions on CT or MR, if there is an acute pancreatitis history, we evaluate for pseudocyst. If it is symptomatic with a high-risk feature, we send the patient for resection. If not, and we find that there are certain worrisome features, we can kind of do further investigations. If it turns out to be mucinous cyst with high-risk features, obviously the patient goes for a surgical resection. And if there is a communication between the cyst and the MPD, obviously this is a branch duct IPMN. In those situations, probably we can observe. But if not, then probably this is a diagnostic. The diagnosis become mucinous cystic neoplasm. We can consider for resection. Sometimes branch duct IPMN with we can consider in young patients who prefer surgery over extended surveillance. Any last comments from any of the panelists before we conclude this session?
Just a word on what Sandeep had said, CT is better in demonstrating the morphology. But I feel that MR is much more better in demonstrating the finer septas and the nodularity of the lesion as compared to CT. And CT is only important, I think, for the calcification part and the peripheral calcification, central or peripheral calcification part. And then if we want to see actually the vascularity around
the vasculature, tumor, once you plan for a surgery, probably
we can do a
staging CT kind of thing would be required.
We can do an angio also by CT that will give a finer branches around the lesion.
Right. Okay. Yes, sir.
Dr. Nijaman?
Sir, so the question is that, do you think that if there is an IPMN, do you need a tissue diagnosis? That's the question.
No, for IPMN, I don't think there is a need for any aspiration. If we are sure on imaging that it or whatever investigative modalities, so IPMN is not for aspiration.
When there's a clear-cut diagnosis of IPMN, we do not do it. Whatever we are talking about is whenever there is a doubtful situation, only then probably we'll go ahead with any kind of additional modality, starting from EUS to cyst aspirations.
Dr. Nijaman, we are ready here for the cases.
Yes, sir.
Actually, it's not about which is better between MRCP and CT scan.
Right.
So there is one part which is the theoretical discussion part, and one is practical management. So when we are considering a surgical management,
Right.
I would never operate any patient of this disease based on MRCP or MRI only. We have to have a CT scan because for surgical decision making, otherwise definitely MRCP, and it is true other way around also. No surgery without only based on CT scan.
Yeah, absolutely.
We have to have both of them.
So that's the message is very clear that characteristics of the cystic lesion is very, very well delineated with the MRCP. But obviously, once you have decided to take the patient for surgery, a staging CT to look for the vasculature, etc., is required because the surgeon needs to have a plan ahead before taking him for surgery. I thank the panelists once again for an amazing discussion, and I end this over here. Thank you.
Yes. Thank you, Jayanta, for a nice discussion and overall presentation, making the things very clear of such a rare disease. And I would like to thank all the panelists for active participation. Thank you so much.
I think Dr. Samantha deserves a big round of applause because it was such an excellent, comprehensive review of the entire subject. We move back to the live sessions, and I would invite the moderators for this session to kindly come on the stage. Dr. Rajiv Mansal, are you here? Yeah. Dr. Paras Shah. Hold on. Dr. Nitin Pai, Dr. Paras Shah, Dr. Pankaj Gupta, and Dr. Sahil Parmar. Dr. Govil?
Yeah, Dr. Amit, are you listening to me?
Yeah.
Yeah, welcome back to the second part of live session today. So we had performed EUS-FNAC from a pancreatic mass lesion in a young person today in the morning. The person who bled yesterday post-EPT, and we did EPT, we did a clipping for them. And then today we took the FNAC from the head of the pancreatic lesion. So Dr. Kalla is ready with the biopsy report. So we are shifting to room number 1 to Dr. Komal for seeing what we took out in the morning from EUS-GJ. So Dr. Komal, please.
Yes, so I just want to show you the findings which we have got in this FNAC. So what you can see on the screen are these multiple clusters of pancreatic cells. There is no inflammation. These blue things which you see are the clusters of pancreatic cells, and the pink things are the RBCs. There are no inflammatory cells in this. So an inflammatory lesion is ruled out. It's a cellular slide, a cellular FNAC. So we are dealing with a pancreatic lesion. So there are two things which we are seeing in this. One is this mass of pancreatic cells which are overlapping each other. I have focused it in high power. So this is a mass of pancreatic cells. You can see it's a jumbled up mass. You can see all these nuclei, how they are overlapping each other. Somewhere here you can see an attempt to a gland formation. You can see the pleomorphism, the hyperchromatism. Here is a mitotic figure. So this is a cluster of malignant ductal cells. Now, along with this, the second thing which we are seeing here is clusters of pancreatic cells which are enmeshed in fibrous tissue. So they are big clusters and they have got enmeshed into a lot of fibrous tissue. In contrast, I want to show you a cluster of benign pancreatic cells to differentiate. So this is a cluster of benign pancreatic cells. This is also present in the background. You can see that this is a very uniform monolayered sheet of cells. These are benign pancreatic cells. Now, along with this, there are clusters of these pancreatic cells which have got enmeshed into fibrous tissue. So the fibrous tissue cells become spindled. These spindle cells which you see, this is a big cluster of pancreatic cells which has become enmeshed in a lot of fibrous tissue. Now when we scan into the low power, here is a cluster again of cells where a lot of spindle cells, fibrous tissue is enmeshed into it. There is an absolute lack of any kind of inflammatory activity. All these blue things which you see is the cellular malignant cells. So what we are dealing with is probably a case of CA pancreas which has developed in chronic pancreatitis.
Ma'am, can I ask you a question?
Yes, please.
Yeah, so how many clusters you want to make a definitive or a presumptive diagnosis on rows?
See, rows has no criteria for saying how many clusters. If you are seeing even one cluster which is showing you all the features of malignancy and the sample is sufficiently interpretative of the lesion which you are suspecting, it is sufficient. But if you are suspecting a malignant lesion and what you are seeing is only normal cells, multiple clusters of normal cells, or only inflammatory cells, then even that sample will be inadequate. You may have to repeat the pass.
Thank you.
Thank you, Dr. Komal. So we have the answer now. So this patient has got a CA pancreas with a background chronic pancreatitis, and he goes for surgery.
I'm interrupting you once more.
Yes, yes.
I just want to show you one big cluster of these malignant cells which has got completely enmeshed in the fibrous tissue of chronic pancreatitis. So all these cells which you can see are the spindle cells, the fibrous tissue.
Yes.
And here are the malignant cells which have got enmeshed and where they are growing surrounded by this.
Yes, ma'am. It's very well seen now. Thank you very much.
Thank you.
Sunil, this,
So we are
this
shifting
patient
to
on EUS, did you see for vascular invasion?
There was no vascular invasion, sir, and it was a mass forming. We thought it's a mass forming chronic pancreatitis, but now we have the clear answer. There is underlying
So he's a young
malignancy
patient.
in this also.
I think he is 30, 35 years of age.
Yes, sir.
So he goes for
He directly goes
surgical-
for surgery. Yes,
Okay.
Peoples. So we are moving to the room number 2, and Dr. Shreyans will present the case.
This is the case of a 50-year-old male. He's a diagnosed case
No,
of
it's
chronic
other room,
acute
no?
pancreatitis, ethanol-related
Hamara hai na?
fevers. He presented to us with complaints of epigastric pain abdomen, which was intermittent, and a jaundice, which is from the past 15 days. CCT abdomen was done, which was suggestive of a chronic calcified pancreatitis with a dilated proximal
Sorry, the
CBD.
voice is not clear here in the hall.
Time out. Post nahi karna.
Sorry, is it clear now?
People can judge you very quickly.
There's
For no
a
reason.
background noise actually, so
Okay.
that's not helping matters.
Acha.
CCT abdomen was suggestive of a chronic calcified pancreatitis with a dilated proximal CBD and IHBRD. There was a likely lower CBD stricture in the intrapancreatic part. There was also a small pancreatic pseudocyst or a possible ectatic pancreatic duct due to pancreatic head stricture in the head of pancreas. Patient had a history of cholecystectomy 1 year back. The patient is planned for EUS EUS followed by ERCP and multiple plastic stenting. This is the CT image which I'm showing. And we'll proceed towards the case now.
Hi.
You're on. Yeah.
Yeah. Hi. Good morning, everyone. Hi, Rajiv. Hi,
Dr.
Nitin. Yes. Hi. All right. So, yeah. Sorry. Did you say something?
Yeah, please carry on.
Yeah. So we have the scope in here inside the stomach. So today we are discussing the EUS findings of chronic pancreatitis and what we find in this case. Yogesh is here with me. So, so step one, we'll look at what can we do with the EUS in terms of chronic pancreatitis. So you see, this is a transgastric view, and I guess there is really no doubt about the fact that this is an obvious chronic pancreatitis case. And when it comes to assessment on EUS, there are several things you can do. One is the Rosemont criteria, really applies to more sort of
certain cases where you have a doubt and a possibility of chronic pancreatitis. And this case obviously fills all the Rosemont criteria. And if you think about Rosemont criteria, you think about the major criteria, which includes hyperechoic foci with shadowing. So if you see on the screen for all the young learners, so what you're looking at the screen are basically what we term as calcifications, but on the EUS, these are hyperechoic foci and there is shadowing, which means there's calcification, and this is parenchymal, right? So that's what we are seeing here. The other major criteria is intraductal stones. So when you look at the pancreatic duct, and as I'm moving the scope here, and you can see there's a lot of calcification, including inside the pancreatic duct. So that's another major criteria confirming that this is chronic pancreatitis. And then you can also, the third criteria is lobularity with honeycombing, which in this case with extensive calcifications, we can't really visualize that. And this is a transgastric view. You can see sometimes you can't really see the duct very well because of the calcifications and the shadowing. The other ductal criteria include dilated duct, dilated side branches with hyperechoic walls. And if you see, this is the duct with a lot of calcification around across the stomach, right? So this is a transgastric view. And as I'm moving my scope, this is the neck of pancreas. I'm just going to use a Doppler for a moment. Now you see here, this is your dilated pancreatic duct in the neck, and it's pretty impressively dilated, and we can measure it. And here we are looking at about 8.5 millimeters. So it's a very diffusely dilated pancreatic duct in the neck here.
Dr. Saurav, isn't it easy to miss an intraductal stone in such a massive stone burden in the parenchyma?
No, certainly, because once you have shadowing, then you can't see the duct distal to it, and therefore you cannot comment on the presence of intraductal stones in such situations. Now here it's very obvious that you can see the stone inside the duct. Like for instance, right here.
For diagnosis, we usually rely on CT or MRI or even with such a load of calcification, USG also will give a diagnosis of chronic pancreatitis.
Correct, yes. Sir.
So in which cases you would prefer EUS for diagnosis of chronic pancreatitis?
Well, I mean, I think that's really a debatable question, whether EUS can pick up early chronic pancreatitis. And if those changes that we label as early chronic pancreatitis truly in the natural history go on to have progressive chronic pancreatitis, because age-related patients, old patients with diabetes can have subtle changes on the EUS in the pancreas, which may be labeled as early chronic pancreatitis. So that really is a debatable question. In instances where the duct is dilated, you're not certain on the CT. Therefore, in those instances, I certainly advocate doing EUS, but purely for diagnosing cases, we don't know what will happen with these patients.
Even for associated masses with such load, that will be helpful.
Yeah, no, certainly. Those are the instances where we definitely do it, because of obstructive jaundice in chronic pancreatitis, we must do EUS. And I'll show you something new with the newer endoscopes with Olympus, and also Pentax, I'm sure also has it, including Fuji's, the elastography. And I've started doing this a little more in my patients. And you can look at the screen here. You can see these blue-green colors. So I'm just going to pause for a moment. Let's see if I can find a good location, right?
Before that.
Yeah, so I just pointed out to all of you. So these are the different colors you see. Red indicates a very soft area, and blue indicates a very hard area. So the more blue means it's more hard. Now you look at this pancreas. I mean, of course, this is a ductal area. Yeah.
Dr. Saurav?
Yes, yeah.
In the setting of chronic pancreatitis, you may have an inflammatory head mass.
Yes.
Or you may have malignancy.
Sure.
So what are the features on EUS which goes in favor of what? And is it always necessary to do the FNA at this stage?
Well, I think the features on EUS which would say predict a more malignant lesion would be something more hypoechoic, diffusely. Again, these are not great telltale signs that it's definitely malignant or not, but something that's diffusely hypoechoic, devoid of calcifications in the mass. So if you have a mass with inside which calcifications are there, that can be more in favor of an inflammatory mass, but something more diffusely hypoechoic, especially having a jaundice in these instances, goes in favor of malignancy.
Also,
Yeah.
also, I think the type of vasculature, if more
Sure.
abnormal vasculature within the mass, then it will be more of malignant.
Right. So but unfortunately, we still, I mean, if you look at elastography, yes, the higher values go in favor of malignancy, means very hard lesions, but they are not extremely useful in differentiating. So at the end of the day, we still rely on biopsies to sort of help us with that. But again, in the yield of biopsies is also lower because standard FNB, your say sensitivity is like 95%. With pancreatic masses, it goes down to like 60 to 70%.
So,
So
Saurabh,
it's another challenge that we face on a day-to-day basis.
Saurabh, any role of contrast EUS in such cases to differentiate inflammatory versus malignant in
Yeah,
chronic
so I
pancreatitis?
think contrast EUS is a great modality, which I have not been using much of it personally, but yeah, contrast EUS is another modality which can help you differentiate between a malignant versus inflammatory lesion. So there are several things that you can do: EUS elastography, contrast EUS, add to it the biopsy, examine the mass properly. In this instance, however, we are dealing with something else, and we'll show you in a moment. Let me get the scope in D2.
Saurabh, in clinical practice, our surgeons are extremely iffy for operable lesions. They just don't want you to touch it.
Really?
No matter what happens, they don't like you putting needles here and there. So do you still, is there any place where you'll say, no, I would prefer or I would insist on a biopsy here? Because our surgeons say if it's
Yeah.
operable, we don't need you at all. For nothing is required. Every
Agreed.
CT answers more or less everything that they need.
Yeah, but I think the practice varies, and you can debate whether a biopsy in a patient undergoing Whipples, actually scheduled to undergo Whipples, is required or not at all.
So it may be inflammatory mass also. So in case of chronic pancreatitis, if mass is there, we really need to differentiate either it is inflammatory or
The
malignant.
only unfortunate thing is your biopsy yield is very low. So
Yeah.
many a times you're going to do a biopsy saying, no, I want it. And you'll still not be wiser. And then he will say that it was operable, you tracked everything.
No, you're right. I think that the fact is we do, our tools still are not absolutely fantastic in differentiating malignancy. But if you do find a malignant lesion, that at least convince the family or the surgeon to go ahead and operate when they are, debating whether they need to operate or not. Because
New
if it's
adjuvant, do you have any experience? Because nowadays the real issue comes for new adjuvant. Because there's a lot of data where says that head pancreas are doing better or worse with new adjuvant. And that's where you require really the tissue diagnosis.
Yes, agreed. I mean, if you're looking at a borderline case, you want a tissue diagnosis, oncologists will definitely want it. So that would be another instance where you would certainly do it. But really, in the settings of chronic pancreatitis, we come down to whether you're planning to operate or not, whether you're debating whether you want to manage conservatively or operate. In that instance, I think we would consider. But
That's
inflammatory or malignant, either way, doesn't matter, right?
Yeah. Can we quickly step to row number 3 and
Yeah.
the interesting finding on colonoscopy?
Sure.
We'll come back to
You
you
want to
quickly.
see us
Yes.
do the FNA of the cyst before the ERCP or fine?
You just position your needle and we'll come back to you.
Sure.
quickly.
Okay.
Yes.
So this is the next case. It is about a 59-year-old male. He presented with EHBO jaundice. On sonography, the patient had an intraluminal echogenic sludge in the upper mid and lower CBD. The ERCP finding, ERCP was done on 7th of November. They found some polypoidal lesion and the biopsy was taken. However, it was inconclusive. So we are planning colonoscopy in this patient and we'll be proceeding towards the case.
Dr. Virul, we are on.
We have this patient who is, I believe you already have the history, is that right?
Yeah, we know the history.
Okay.
So what is your plan now here?
Yeah, so we did the ERCP, removed the prior stent, and introduced the Microtech cholangioscope or IMAX. Very important to make sure that you have an adequate sphincterotomy or dilated ampullary opening to get the IMAX or cholangioscope through. So this is the image quality. We are now at the cystic duct. And we are seeing this, what looks like mass or a blood clot within the cystic duct itself. Let's do a fluorocarbon.
Post-stenting inflammation and a mass or a lesion, is there any way you can tell on colonoscopy?
So that is the.
Viral, actually, I did the ERCP of this patient. Actually, this is post-cholecystectomy. I
Yeah.
think cholecystectomy was done around 3 weeks ago. And after that, he came with jaundice. And when we did ERCP, we found a filling defect, which looked like a stone at the level of porta. And then we were actually, doing balloon retrieval, and some mass-like lesion came out at the papilla.
I see.
And then we took the biopsy. It was a big piece. I think we need to know what was the biopsy report of that.
I agree.
And then we left out, there was some lesion left out in the CBD. We thought he's a perfect patient for doing the colonoscopy.
So you did spy biopsy that time? Or
No, it was ERCP. When we were actually retrieving that, a mass came out at the papilla.
That you sent for.
Yeah.
So this is the lesion that we are visualizing. It's within the junction of cystic duct and common hepatic. We actually went past this into the common hepatic and then the right and left intrahepatics as well. There was no lesions there. Everything looked normal. But I can go past this into the hilum to demonstrate that. So here we are.
So, Dr.
Look, all looks completely normal here.
Yes, yes.
Nice view also. The
biopsy
colonoscopy is very
material
nice.
Yeah, Dr.
Yes, yes.
So the biopsy which was taken by you shows
That's what I wanted to ask actually.
a necrotic material. So one of the very important things which I wanted to discuss, whenever filling defect come and there's a suspicion of stone, and on repeated ballooning, if it is not coming out, that indicate it is a polypoidal, either a polyp in the bile duct or a polypoidal nature of the cholangiocarcinoma. They may present as a bleed, that is a hemophilia, or they may present with the obstruction. So I will just, Viral, can we show the cholangiogram you have taken at that time?
Yes.
I think that will going to give a picture. Can we show that cholangiogram?
Yeah, actually, I think.
So that is very important, and this is a necrotic tumor. Viral is going to demonstrate just now.
Yeah, but is it benign? Because it was highly mobile actually.
Yeah, so this should be a recurrence of malignancy. Viral, can we go to the cystic duct deep? Can we go to the cystic duct deep? So few important points which I think, Dr. Viral, can you tell what is the difference between the SpyMax versus SpyDS? IMAX, is that right?
Yeah, IMAX.
Yeah.
Yeah, so one key difference is the cholangoscope from Microtech that we're using right now is a 9 French scope. The Boston Scientific cholangoscope is a 10.6, 10.8 French, 10.8 French device. There is a larger IMAX cholangoscope also available in the market, which can be used to obtain larger biopsies if.
Am I audible?
Can you hear me?
Hello?
Can you hear me?
So
we'll be
basically
shifting
the
quickly
11 IMAX has a 2
where
millimeter
Dr.
working.
Saurav is ready to see the
And this has
control
1.2
chronic
millimeter
pancreatitis
working
patient.
channel, which is equivalent to the SpyDS, and this is a 9 French.
That is correct.
So 1 French assembly difference is there. And few point, if you can tell while taking the cholangoscope in, what are the precautions to prevent the fallback? How you will going to go in? What is your practice? Do you do the good EPT or you do the balloon sphincteroplasty?
Yeah.
So what is your
My usual practice, so there's a couple of differences between practice in the US versus here that I've noticed so far that we discussed earlier. One difference is it's a single operator cholangoscope. So generally speaking, I am the one operating the cholangoscope as well. So outside of that, getting inside the bile duct, you need to have a good sphincterotomy. So you can get in very easily. If you don't have a good sphincterotomy, then it's also important to maybe have sphincteroplasty in some cases, especially if there's no length.
Dr. Viral, can we quickly move to Dr. Saurav? He's ready for something. We'll come back to you in a minute. Yeah.
Okay.
Dr. Saurav.
Go to cystic duct.
Room number.
Can we live? Yeah. Hi. So a quick note. So we found a cyst in the head of pancreas, which is actually the reason. Looks like he had jaundice and obstruction of the bile duct. So we ended up putting the needle to aspirate the cyst because we feel that this is probably the reason, at least contributing, if not primary reason to the of the patient having jaundice and biliary obstruction. The bile duct is actually 2.5 centimeters. And this is not a very large cyst. It's about 2.7 by 2.7 centimeters. So
Is it making your reaching the papilla difficult, or you anyway going to plan just to
we'll
aspirate?
anyways plan the ERCP. I think PD stenting would be advocated as well as an ERCP biliary stenting.
Okay.
Now, when it comes to cystic lesions, by and large, they're all pseudocysts, but we have seen in my prior research experience, up to 5 to 10% can have IPMNs as well. So something, a food for thought, because if you're looking at a lesion and there is some suspicion for IPMN, so perhaps it's worth aspirating and confirming. This way, anyways, this is therapeutic and we'll aspirate and send it for analysis. So we'll just turn this on right now with the
So
suction.
obviously, this is not a pseudocyst drainage. This is a complete aspiration of the cyst at one time.
Yeah. This is a basic complete aspiration what I'm doing. I'm not doing a transduodenal stenting because it's a very small cyst, you see.
Saurabh, but
If it was larger-
are you worried about the infection part or?
Yeah.
You see, after draining this, if this is your primary reason for obstruction of the CBD, do you want to place a stent in CBD or this is enough?
Well,
And what
I think
about the
we
infection
have
part?
an option of observing and seeing what happens to the patient, if the jaundice reduces or not. At this point, I feel there could be another reason beyond just the cyst for the reason of obstruction. So I think I'll still go ahead with the RCP. Let's show everyone what we.
Can we see the fluid here?
Let's look at the fluid here. We have a white background. It's a little hemorrhagic towards the end. It's a little turbid, but it was more yellow.
Okay.
Okay, there you go. So pull it out. Yeah, definitely would I give antibiotics, a small risk of infection, which is about 1%. If you are not reusing the needles. So let me see this. Yeah. So yeah, I mean, I think we've managed to successfully decompress the entire cyst. And let's look at this now. Well, this is the bile duct. Can you see on the screen? Yeah.
This guy hasn't had a recent attack of acute pancreatitis.
We'll have to see the
Acute
story.
on chronic, yeah. See?
Yeah, but this duct is very dilated. You see, this is the bile duct and it's branching off. And it's about 2 to 2.5 centimeters in diameter. So what we'll do is we'll nevertheless go ahead with ERCP in this case. Yeah, I mean, this is the duct coming from here, going down towards the ampulla.
Yeah. Are you seeing a mass here because you had a?
No, actually, it was primarily the cyst, you know.
Yeah.
There's a little hemorrhage in there, but that's the cyst. That's it. There's no mass here in this case. At least I can't see anything yet. Post aspiration, worthwhile to see, but I don't see a mass here. This is the duct now. Better visualize. Before we could not see the duct over here. All we could see was the proximal dilated duct. But post aspiration, I'm able to see the distal duct a little bit. Not very dilated here, but much more dilation.
So
in the proximal part
usually,
here.
usually in malignant cases, benign cases, we don't see so much of dilatation.
No, I agree.
Right?
I agree.
So could this be something abnormal pancreaticobiliary anomaly, which is leading to chronic pancreatitis as well as choledochal cyst, something like that? Because he is not an alcoholic, probably.
I mean, it's a classic chronic panc, and I think, I'm not convinced about that. The reason I'm really wondering is why does he have so much dilation of the duct?
But while you are changing your scope to ERCP scope,
Yeah.
we'll move quickly to the room with the colonoscopy.
Sure. Okay.
Yeah. Room 3 for colonoscopy. Yes.
Thank you.
So you are on. Dr. Viral.
Let's look at the ampulla hub.
We can see Dr. Nikhil.
Nikhil, you are online.
Oh, Dr. Nikhil, you are online.
Right and ready to go for the procedure.
Can you?
Dr. Viral, you are on.
Oh,
Yeah.
thank you.
Show the
Yeah, so
endoscope.
we are seeing
endoscopic
this.
image.
We visualize the cystic duct, which is actually right there at 1 o'clock. We're trying to go inside cystic duct. What we thought previously was cystic duct was actually not the cystic duct. This, look down. There. So this is cystic duct, and this is looks very normal. Little inflammatory, but nothing, not significant. And this is, yeah, so you can.
So this is a polypoidal lesion and most likely this is mitotic.
Yeah, this is the problem area.
So I think Dr. Rajesh was telling the difference. We just heard 9 millimeters and 10 point odd. Is the diameter of the channel the same, the working channel for the IMAX?
So when we compare where the 9 French assembly of this has 1.2 millimeter, where the SpyDS of 10 French has 1.2 millimeter working channel. And when it comes to 10.5 of the SpyMax, then it is a 2 millimeter channel. So better maneuverability of biopsy as well as better maneuverability of.
Does it have NBI or any other features in the scope?
So they don't have an NBI, they don't have an AI.
But
both are not there.
You can freeze the image, which is what. So if I freeze it, you can freeze the image on the IMAX, which you cannot do on the DS, Boston Scientific DS.
Yeah. Okay.
So you see, this is bleed on touch. Have you noticed?
Yeah.
Very
So
friable.
this is a tumor, no doubt about it. And there is a blood over it, and that's why you are getting this picture. The repeated attempt to clean the duct in view of suspected CBD stone, and that's why you are getting a clot over it. But this is a polypoidal variety. It could be a polyp or could be a malignancy. But this patient definitely fit and require a surgical intervention.
So will you all stent this at the end because of the interventions or?
So stenting is not stenting to be done to prevent the cholangitis.
Yes.
So what was the question?
Yes. Post biopsy, post number of manipulations which are going.
Yeah.
Are you all going to be stenting him right now?
So we are going to do the stenting in this case, and the hilum is maintained. And can you see here?
Yeah.
It's pretty extensive. There's, you can also see some small neoangiogenesis type vessels along the side of the bile duct wall, which also suggests a malignancy.
So this patient require a CT angio or a dynamic CT followed by a resection. And I think if I'm not wrong, right posterior duct is involved. Is that right?
Yes.
Rajesh, what is the previous biopsy report? Because it was a very big
Is
chunk.
a necrotic material, sir. Necrotic material.
Dr. Virul, while you are taking a repeat biopsy,
take the biopsy again.
So the fluoro.
Yeah, we'll take the biopsy again.
Yeah. So while you are taking, Dr. Rajesh, repeat biopsy, we'll switch to another room, room number 1, for a large polyp in the sigmoid colon.
Okay.
Room number 1, please.
So anterior. Cystic रक्त बाजू में ना? Contrast. फ्लोरो चालू है? कुछ नहीं जा रहा। ये वायर को निकालना पड़ेगा।
Hello, Dr. Gaurav.
Hi. Good morning, everyone. Can you hear me? Am I audible?
Yeah. We can't see you now, but we can see the polyp now.
Yes.
Yeah, we can see you also.
Okay. So this history was presented to you. This elderly male who's got a sigmoid or a left colonic polyp. I was just inspecting this polyp of the of the recording, and I found it is more of a polyp with a very thick stalk. It has a large sessile component, and it is a thick peduncle. So ideally, in such scenarios, in routine conventional practice, in your routine setup, we normally snare these polyps and do a simple hot snare polypectomy and get it out. Now today, we are going to demonstrate something new, which is using a track motion device. This is purely for academic purpose, and what we are going to do today is we are going to use this special traction device, and it's a sort of a robotic arm. It's sort of an extra arm. The arm that we always, in endoscopy, there's always an element that we don't have enough traction, we don't have enough triangulation. So Fujifilm actually made this arm a few years back, which was in the R&D last year, and in DDW they actually launched this. So in the past few months, we've been using this arm in ESTs, which are difficult to lift, in polyps, or in LSTs, which are having good adherence to the muscle, so that you can dissect the tumor away from the muscularis and cause enough submucosal, tunneling, or submucosal dissection can be performed. So, so to introduce you to this device, first of all, what you require is a double channel scope, preferably by Fuji, because the way this arm comes out from the scope, the angle at which it approaches the tumor is more preferred with a Fuji double channel scope rather than any other Olympus or others. Second, this goes through the working channel, that is a 3.7 working channel, which is on the right side of the scope. And it comes with a few adjustments inside. So I'll just explain you how this device is made. So as you see, can you focus on the yeah? So as I introduce this arm into the channel of the scope, you can see this large arm. So this is the extending arm. So I can change how much of this I want outside, how much of this robotic arm I want outside. I can rotate it. Can you see it rotating?
Yeah.
I can withdraw it, and now I can open it, can hold the tumor, I can close it, and even another special function is that I can twist this arm. So slowly I can, increase the tension on the tumor so that I can perform good dissection in the plane. Ideally, as I said, we perform this, use this arm in ESTs which are difficult to treat or difficult to manage by routine conventional endoscopic methods. So in this case, what we are going to use is, we are going to first perform okay, 1 second. So you need to have this entire thing straight, as straight as possible, so that you can get it into the scope.
Does it work like a better version of a band or clip assisted ESD?
Sorry?
Does it work like a better version of band or a clip assisted ESD?
Yes, it is. So the advantage of this is you can even use it in retroflexion. You can use it in different, locations where, performing a band is not so easy. So can I have some injection? So my idea in today's case is I want to hold the polyp downstairs, pull it more down, give me an injection needle. And with the help of the device, I'm going to perform some extra traction on the base of the polyp. Now I'm going to apply some fluid so that you know that the gravity is working on the 6 o'clock position, which makes my life much more easier. And before I start my incision, I'm going to use this. There are two good aspects of the arm, which I'm going to demonstrate today. Needle out. Okay. Push the scope. Inject. 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 Keep injecting. Keep injecting. Keep injecting. Okay. That's it. That's it. Okay. So now I've caused the stalk of the polyp to have some submucosal cushion. Once I have that, I'm going to use this arm to my give me a knife. Now, while I'm performing dissection, the importance is that I want to maintain my plane of dissection away from the tumor. Today, for demonstration purpose, I'm going to use this extra device that we have. Now I'm going to open it. Rotate 1 second. Rotate it. I'm going to push it inside. Catch it. And then I'm going to draw it back. Okay. So there are two things which I can do with this. I can cause some traction, and at the same time, I can also use this for hemostasis. So if there's severe torrential bleeding, this device can also be useful to achieve some good hemostasis.
Dr. Gaurav, have you done the NBI inspection of the polyp?
I was told the NBI was done. We were using a Fuji system over here. So this was more of a polyp which was having a JNet 2B, 2A features.
Yeah.
And because there's a stock, we are going ahead. And so this is a tricky part. You need to align. Okay, now give me a knife out. So this is a Fuji knife. This is a Fuji flush. 1 second. Okay. So I'm using the endo cut mode over here. Now I'm again going to rotate and give some extra traction. You can see, knife out. Knife in. Okay, now inject. Inject to that. So there are two advantages. I can inject. Oh no, not air. Saline. Inject saline. So you have to have good coordination with your team. You need to know when and what to. Yes, inject. That's it. Okay, knife out. Okay. So you see, I'm using that arm. Okay, now see what I'm going to do. I'm going to twist it a bit. I'm just going to push it away. I'm going to see how it works in this scenario. Push the
Dr. Gaurav, while you are doing the dissection,
yeah.
We quickly shift to room number 3 for colonoscopy. Interesting finding is seen.
Knife out.
So Dr. Nijavan,
Room 3 for colonoscopy.
रहेगा
Yeah.
उसको।
Dr. Nijavan.
ऊपर dilated था, फिर narrow area।
Yes.
Now look at the image and now the things will be very
नीचे का
clear.
portion दिख नहीं रहा था।
Yeah, please show.
Yeah, so here you can see we've frozen the image
अच्छे से
on
डाल
this.
देते हैं।
So you can see the polypoid mass in the right.
टिप से कर लेते हैं। मैं पीछे आ रहा हूँ आप।
Yeah, we can see that. The only issue which I want to discuss is that it was a mass which could be could be retrieved by the balloon. So it's a mobile mass.
Yeah. Pottery.
So
Cut भी करना है दोस्त।
could it be a
Pottery
benign
नहीं।
lesion? That was my concern.
Cut. Yeah, stricture.
Neoangiogenesis changes and very fibrotic and friable.
अब डाल रहे हो?
So this has to be a malignancy. We can try to remove it. The problem will be that it will bleed.
See, can you visualize now? The left ductal system or the and this is a mass which is blocking. Is very clearly seen. And this should not be benign.
Yeah, but it's a malignant mass which is actually unusually mobile. Normally in biliary ductal system, you get a infiltrative type.
I think the mobile component is actually just a blood clot because of chronic bleeding and friability from the cholangio, which we can see sometimes. And we were just discussing that we can. What I'd normally do in the US is we would actually go past this with a little small stone extraction balloon. And like you just said, we just take the whole thing out, exactly what you did.
Yeah.
And then send that off, and you'll usually get necrotic. If you're really lucky, you might get some cholangio diagnosis from that as well. But generally, when you see something like this is almost always malignant.
Yeah, I know.
And cholangiocarcinoma is sometimes very difficult to diagnose, even after brushings and spy bites and other techniques. So this patient will most likely require surgery.
So you can see the cystic duct on the right side. So cholangiocarcinoma is 3 variety. A sclerosing variety, sclerotic variety, which run beneath the mucosa is difficult to diagnose. But when it is a proliferating variety or polypoidal, then it is easy to diagnose on the biopsy. I'm very sure if we take the biopsy from here, it's going to be positive. There is a blood clot associated with it, but we can show the cystic duct on the right side.
Yeah.
On the above and the left side, there's another system.
Dr. Puri, the cystic duct.
Yes.
Yeah, so this is a very circumscribed mass. There is no inflammation seen around it. Is it? Am I right?
No.
Yeah, please go ahead. What is your question?
What I'm saying is that it's a very circumscribed mass. There is no inflammation seen around it.
Yes. So what is the message by that?
That's just I'm trying to ask whether that could point towards a benign etiology.
So it is blocking the ductal system. If you see on the fluoroscopy, right anterior ductal system is blocked.
Okay.
And when you go in and this patient has the bleeding also. And what is the nature of the benign lesion? A polypoidal lesion in the bile duct, unless proved otherwise, should be malignant.
Okay. Any role of EUS at some point of time in the past or now?
Actually, before going that, if it is a submucosal bulge and the mucosa would have been normal, I would have done the EUS. In this case, I will say don't do the EUS. The reason is, if the CT scan shows there is no outside mass, and if you do an EUS and take the biopsy from here, the risk of the bile duct leakage is very high. And there is a lesion like a polypoidal lesion, it is better to do a targeted biopsy rather than doing the EUS and taking the FNB or FNA. If you find an extraluminal mass, definitely EUS would have been help. But in this case, I don't recommend to do a EUS and take, because risk of bile leakage will be very high.
So till now, it's a completely intraductal mass.
Yes.
So here you can actually see portion of the bile duct is normal.
He has gone inside the ductal system, and can you see here?
Yes.
I've gone through it. And this is basically the end where
Now can you see the neovascularization?
Yeah, so you can appreciate slightly blurred, but yes, we can appreciate somewhat.
Yeah. Can you put the water? Don't freeze it. Yeah.
Dr. Rajesh, can we shift to room number 1? Dr. Saurav is showing something interesting.
Yes, Dr. Sunil, definitely. And you see, we are deep into the ductal system. So what we are looking is a tip of iceberg. There's a rest of the mass is also there.
So Dr. Gaurav, you are on.
Okay. So we have changed now our instruments to a clutch cutter, and the reason why it just washed it because there's some bleeding. Yeah, but that's it. So we fought a vessel with the clutch cutter. The advantage of the clutch cutter is that you can perform coagulation and dissection with the same instrument. And whenever you have stalks or you have a thick fibrous septum, I think it works very well in open. Catch. Wash. So you can see there's a vessel which is slightly more towards the left. Wash. Open. You make it this way.
Can we call this a device-assisted ESD?
Yeah, so it is a one of hold.
Gaurav, is there a lock system on it? So when you do twist it, does it stay there, or the minute you move the scope, it's also
Yeah, so
coming back?
the disadvantage is it's still the lock is not yet defined.
Yeah.
So,
that's-
you know, while I'm using this,
Because every time you're moving the
Yes.
scope, the traction is also falling.
even the X-Tack is, you know, the device itself, the track motion also moves. So unfortunately, there's a vessel which is not responding to standard coag. Maybe give me a standard Olympus coag. So the device, the lesion is almost out, but we need to handle this bleeding before we do the, get it out. So in such situation, the best method is you go close to the lesion, give your tamponade with your scope, coag rasper. So this is what we do. You press your scope onto the vessel. You make sure there's a mechanical pressure on the vessel so that you can wait too much pooling of blood. You can buy time. Meanwhile, it's not. So unfortunately, the coag rasper is not in this room, but nonetheless,
Your device is not hampering vision, no? The
it
vision
can.
wise-
It's, currently, it's not. So you can see my device is at 4
And
o'clock.
no cap here. You're
No,
using
you
free
can't use a cap with this because it comes through the same accessory channel. So very difficult to use a cap. So sometimes the problem with this device is you can't go close to the lesion, and most of the experts who do ESTs, you want to stay close to the lesion, you want to stay close to your dissection plane. So in ideal scenarios, I think this is a device to be used as a rescue attempt rather than a primary attempt at EST.
Hope the cost is not prohibitive about the device.
I think cost is something you'll have to discuss with the company. But yes, if you are doing good volumes, I think this can be a good armamentarium. You know, I can actually use the device to even cause tamponade. But currently, just withdraw the scope. Withdraw the scope. Open. Catch. Open. Wash.
Dr. Gaurav, while you are achieving hemostasis, we switch to Dr. Saurav Mukhewar, and he's ready with a, I think, papillotome inside the papilla.
Okay.
Room 2, please.
Not will switch.
Dr. Saurav, we are on.
Yeah, okay. Hi. So we ended up getting our ERCP started. We cannulated the bile duct. Interestingly, he has a really large, you see on the top of the screen, he has a very prominent minor papilla, so probably pancreas divisum as well. So we've gone inside the bile duct. Can we show the fluoroscopy so that contrast, please? Yeah, contrast. Yeah, fluoro life, yeah.
Still a lot of bulge seen on your endoscope, huh?
Yeah, that's the top right is the minor. And if you can see on the fluoro, is it visible to you guys?
Yeah.
The fluoro, right? Yeah.
Yeah.
So it's a stricture about 1.5 centimeters. So the way we estimate the stricture length, I see the diameter of the scope. And in this instance, about 1.1 centimeters would be your diameter. Another, say, 0.5 centimeter. So about 1.5 centimeter stricture in the mid CBD. So, which is in line with what we would expect on the EUS, where we could see that area getting a slightly narrow. But we're going to do a sphincterotomy first, and then we'll plan to put a stent in.
So,
Saurabh, which metal or plastic, multiple plastic stents?
You think it's extrinsic, the entire compression?
Yes, it is. It should be extrinsic.
Because if it's mid and lower is okay, then I guess.
Yeah, the mid and lower is okay. So it is all secondary to chronic panc, and it's probably fibrotic, presumably, but we should do I'd say maybe a brushing would be good to do.
That was my second question, that would you do brushing in all? And which kind of stent would you prefer in this, metal or multiple plastics?
Yeah, I'm just going ahead with the sphincterotomy. It's a nice long intraduodenal segment. This should be sufficient, I think. Yeah, so depending on the affordability, the risk of migration is there with metal. But it's just one-stop shop. 1 year you keep it, you'll treat it. Other option is multiple plastic, cheaper. But I think you'll still need to do it every 3 months ERCP. So 4 ERCPs versus, 2 ERCPs and a metal or 4 ERCPs in plastic.
And studies have shown neither metal or plastic are superior to each other. They have equal results.
They're pretty equal. So Costa Magna protocol, try to put as many plastic as possible. But yeah, I think this is good, right? Okay, so exchange now. Yeah, so we did the sphincterotomy exchange. So we'll go ahead with brushing and then plan for plastic stenting in this scenario, unless we have a fully covered SEMS to put. I personally like fully covered SEMS in chronic panc patients, but if I think it's not unreasonable to go plastic stent first, because if we are dealing with a malignancy, then I guess patient is heading towards surgery, then maybe a metal stent would be unnecessarily expensive for him.
You had a massively dilated pancreatic duct also, and are you planning any intervention in the same session, or?
We were considering. I think Pankaj mentioned he's not having much of a pain, so
and his stone load is also quite heavy. And would you have first tackled that with an ESWL probably before you have touched the pancreatic duct?
Yeah, but I think I could not. We'll do the ERCP to see if there are intraductal stones. Then probably ESWL will help. But if it's purely stricture,
right now, as per the history, sir, patient is admitted for obstructive jaundice. So better is that we treat this symptom first, this clinical scenario first, and later on follow-up, we may decide what to do for the pancreatic duct.
Yeah. Now, what do you guys think about changing the natural history of the patient by PD stenting? There's some data to say that it will help.
Dr. Saurav, thank you very much for a very nice demonstration
Thank you.
on EUS and on ERCP. So we are moving to room number 4. Dr. Nikhil is ready with a colonic polyp.
Okay.
Room 4, Dr. Nikhil, please.
Hello, done.
You're on, Dr. Nikhil.
Good afternoon, everyone. Thank you, Mukesh sir and the team for this opportunity. So we have an interesting case of a old gentleman with multiple colonic polyp, and this one is a bigger polyp. So whenever see a colonic polyp, the standard teaching approach is SSMA: site, size, morphology, and approach. So this is a polyp on the splenic flexure along the fold. Size is around 1.5 to 2 centimeter. Morphology, I will recommend you should do both on white light and on NBI. The white light morphology is of course Paris classification, which is 0-1S or sessile in this case. And NBI wise, so techniques of NBI, I think multiple times it has been repeated in the workshops. So you should use a soft hood. It helps you focus on the polyp, makes adequate distance between the polyp and the scope camera. It helps you reduce the reflection. Then you should have clean surface. Then this is 1500X1, which is the third generation NBI, which is more brighter. So you do first NBI on standard magnification, then you go for near focus and zoom. Can we have near focus? Yes, near focus. And can we have the zoom? So once you do the zoom, don't try to read before stabilizing and before capturing the image. So here I have captured the image. It shows a regular tubulovillous ridge pattern and a regular vessel pattern suggestive of NICE 2 or GNet 2A. So try to have good NBI image of as much areas as possible. So this is another side of the lesion, which is also showing standard tubulovillous ridge pattern, regular with a regular lacy vessel pattern, without any absent vessel, without any amorphous substance. So it fits into NICE 2 or GNet 2A. So reduce the zoom.
Dr. Nikhil, the significant chunk of this lesion is away from the vision on the other side.
Yes, yes. So that is the challenge with the lesions which are on fold. So you can do retroflexion in that, but with the cap, retroflexion becomes difficult. But it's not significant, but still there is part. But based on the majority of the NBI examination, it still fits into GNet 2A. And I would still go ahead with resect this lesion and then see the final pathology report.
How do you assess the size? By open biopsy forceps?
Open biopsy forceps, your snare, the width of the maximum width of the lesion with respect to the cap. So these are some techniques, of course, an approximation. So now we have done the site, size, morphology. Now what should be the approach? So I think approach between, you have to frankly choose between EMR and ESD. So this fits into a category of an EMR. If you want to do ESD, of course, any lesions can be ESD. So it is less than 2 centimeter with GNet 2A, NICE 2, without much high risk feature. And I think EMR is the way to go for this. And post biopsy, if you find any surprise, you may think of coming back. Now, so we will go ahead and try to do EMR in this. Now, for EMR, you have to, the steps, there are various techniques of EMR described, cap and ligate, inject and cut, underwater EMR, band and cut. So here we used to go for standard inject and cut. So I try to bring the lesion at 6 o'clock position. Can you convert to white light? So once we have evaluated, I would like to do my procedure under white light image.
Injected cold snare or hot snare?
Hot snare will be the way, because we don't want any residual tumor on the wall. So cold snare has been shown to be good for lesions between 8 to 12 mm, but this is beyond that. So I think a hot snare polypectomy will be good for this.
This lesion is
Your first injection is going to be tricky here, Dr. Nikhil, because if you hit it where you are, you're going to push it away from you. And then that's going to droop because of gravity. So where are you hoping to hit your first injection so it comes towards you?
Yeah, so oral side is always preferred, but in this case, again, oral side we may not be go. So I'll go to lateral side of the lesion, and hopefully that percolation of fluid will cause it to come up. But even if I'm not able to inject on the oral side, my snare will go beyond that, and we will be able to catch.
Because unfortunately, it's that in between size. So
yes,
it's not so big also that you'll get on all sides.
Yes. So after your first 2 injections, you will be able to assess more. But then again, the position is tricky. And it is hiding in between the folds. So cap helps in this respect also. It helps you to evert the lesion towards you.
Maybe changing position of the patient might
Yes,
also
yes.
give you a little bit of help
Yes.
with regards to the change in location of the polyp. You can maybe try that. Any role of underwater here, Nikhil?
That's a option because it's on the fold that can be attempted. But then I think injection will be better because you're not sure about the oral extent. Can we make the patient supine? I think we'll try to change to get the position at around 6 to 4 o'clock position.
You can just rotate the patient.
Yeah.
Maybe you can try.
Yeah. Just now hold the scope. Hold the scope. Scope. Hold the scope. So it is easy to inject below the lesion, but then it may evert the lesion more. So I'm trying to find a place where I can inject by the side at least. Yeah, out. Out.
Even in this patient's position, the lesion is not stable.
Yeah.
It's tricky.
Inject. Wait. Inject. No. In, needle in.
Then it's going away.
Yes.
Then it's gone away.
Yes.
So maybe we can retrovert the scope and then try injection from the proximal
Yes,
side.
that is the last resort.
Your other option is a gastroscope, Nikhil.
Yes. Or remove the cap.
That will also help your
Yeah.
maneuver.
So this is matter of patience. Oh, and out. Wait. In. NBA हो गया, inject कर रहे हैं. You want to change and come back, it's okay. Hold the scope. Out.
Are you using simple saline or
No, so it's methylene blue with saline.
no gel fission?
No gel fission because we are looking for an end block rejection in.
So change of position has not made any significant difference.
Out. Here is the remove the RDA. आवाज से ज्यादा तो नहीं white light. Hold और dip है, so gastroscopy करना होगा, retroflex में करना होगा ये. Out. Inject. Wait. In. Out.
So, Dr. Nikhil, we are shifting to room number 1.
Yes,
Dr.
yes,
Gaurav
come
has
back.
completed the polypectomy. So we'll come back to you.
Yeah. In.
Dr. Gaurav?
Yeah, hi. So we could manage the tamponade with the help of the using the device assisted ESD. The device was used to close the bleeding by the time they went and got a coagulation forceps. After we achieved hemostasis, we finished the dissection of the lateral part of the stalk. We retrieved the polyp. Can you show the polyp? Can you focus on this? And now just prophylactically, because there's some bleeding and this is a little higher up in the colon, this is not like a sigmoid, this is more in the left colon. I'm just going to close that defect and then we'll call it a day. So what we saw today is that using track motion or a device assisted ESD, we can probably, achieve outcomes, quicker outcomes compared to conventional ESD. Now, open full. Now, the challenge is to place a clip in between these two. Ideally, in scenario, I leave these defects open. I don't do anything. But because there's some bleeding, I am going to just close these defects. Now, close. Fire. Okay. Yeah. So that's about it. Again, just to show you the highlight of the device, you have to introduce the device to your right working channel, that is your 3.7 channel. The device has got two basic structure, basic arms. One is to introduce the device into your lumen of the stomach. This is to open the device. Can you show this? Yeah, just hold it. Open the device, grab the tissue. After you grab the tissue, you can rotate it the way you want it. And then you can just show it here. And then after rotating it, you can move the device so as to get external traction. So device assisted or traction assisted ESD is probably can be made simpler with such external devices. The only thing, you need a double channel scope. You're not using a cap, you're dissecting far away from the tumor. So those are some small changes you have to make in your practice of your conventional ESD. However, you can probably achieve good outcomes with the help of the device.
If you do reuse it, does the angulation get stuck or it's quite supple that way?
No, so far, I mean, whatever we've been using it for the past 6 months.
Yeah.
We've not encountered.
We would thank our moderators for this session, and I would request the moderators for the next session to kindly come on the stage. Dr. Satish Kulkarni, he is the moderator. Dr. Sandeep Kumar Ratra, Dr. Sanjay Rajput, Dr. Shaurya, Dr. Shravan, Dr. Shrikant Mota, and Dr. Sudhakar Pandey. I would request the moderators to kindly come on the stage, please.
Thank you, Dr. Gaurav Patil, for a very nice demonstration of device-assisted polypectomy. So we are going to room number 4 now, where Nikhil is ready for that polypectomy.
Yeah, hi sir.
Nikhil, you are on.
So after a bit of struggle, we were able to inject around the polyp, changing the position, giving some abdominal pressure helped to stabilize. So once we injected, we did not want to lose it again. So we have put the snare around. So we have used a 20 mm Olympus snare.
Yeah.
Now, after you have grasped the lesion, the techniques are very pretty simple. You want to make sure that the muscle is free. You want to have enough space between the opposite wall and your cut and your lesion. So in this case, as you can see, the whole lesion is grasped and the muscle is quite free, and we have enough gap between the lesion and the opposite wall. So I think we are ready to go ahead with the cut.
Yeah.
So we are,
What cautery setting we are using?
it's a standard endo cut with effect 3.
Okay.
So
nicely cut.
So it's an en bloc resection, as you can see. We'll now inspect the area.
Dr. Nikhil, in lesions.
So this is the post-resection site. On simple white light also, it doesn't look any residual lesion. I'll still put an NBI. NBI. I don't suspect any residual lesion here. And the base looks quite clean with no obvious bleed and no deep defect. Remove the NBI.
Such a situation when lesion is placed at such a fold, sometimes you might not be able to see the base because after cutting the polyp,
So the trick was to inject around the polyp. So that let the whole polyp revert toward me. And then I suctioned the polyp inside the cap. And then we could grasp the whole polyp. So the base of the polyp was not that wide, as you can see from the residual base. So injecting around the polyp, sucking the polyp to revert it, then the other measures that everybody suggested, changing to gastroscope, using abdominal pressure, doing retroflexion, all this will help. So this is the lesion. I think now sometimes when you have residual polyp post resection, you may want to burn the area using APC. But in this case, I think we are good to go. Any comments?
Comments from the fourth floor?
So sometimes this simple small polyp can be challenging because of the location and because of the presence in between the fold. So the approach is similar with some modification. To identify the lesion, you determine your approach and you prepare to change accordingly.
How do you want to follow this patient up?
So let's see the biopsy. If it comes out to be a high-grade dysplasia or intramucosal carcinoma, then the surveillance becomes short. If it's a low-grade dysplasia, then we can follow it as an routine post-polypectomy surveillance protocol. I think we have lost the polyp here. We'll get the polyp out.
I think it is a success channel.
No, it's bigger for success channel. It's lost here. So if there are no more questions, we are done with the procedure. Thank you. What do you want?
Okay. So, Dr. Nikhil, suppose this patient is elderly patient and the patients are on anticoagulation or aspirin, then what is your approach? Would you like to?
So aspirin is continued as per multiple guidelines. Clopidogrel you want to stop for 5 days. And antiplatelets, if you are using Novak, then for 2 days. And if you are using warfarin, then again 5 days. If patient is high cardiac risk, you overlap with low fractionate LMWH or unfractionated heparin and withhold 12 hours before your procedure. And you can resume in high risk patient within 48 hours.
Okay, any other tips, do's and don'ts?
So injection, I want to talk about the injection techniques. So injection, sometimes it becomes intramucosal, which can cause hematomas, or it can go intramuscular, which can cause inadequate injection. So the trick of an adequate injection is you put your needle at a 45-degree angle, then you slightly pull back the needle 0.5 millimeter, 1 millimeter or so. Then you put some little bit of saline, couple of ml, and then you see the bleb, and then you go ahead with your fluid. You don't want to inject too deep. You don't want to inject too superficial. If you think you have done a wrong injection, leave that site. Don't try to poke in that side, go to another site. Because injecting at wrong place may cause post-procedure bleed, that may cause non-lifting of the tumor. That's an important trick for your injections. Second, what do you do if you don't see enough of lifting? Then I think you should have a reassessment of your NBI findings and imaging finding. If approachable, do an imaging to rule out adjacent lymph nodes and EUS for exact layer. And you should tilt yourself toward doing an ESD. I will refrain from doing an EMR for a non-lifting lesion. And if not, then you refer it to some expert center.
And in change in your technique in left side versus right side lesion?
So right side is generally more easily approachable. You can go ahead with your standard accessories. For left side, you may require retroflexion. In fact, sorry, for right side I'm talking about. You should do retroflexion and try to inject from the oral side because that stabilizes your scope massively. So all colonic polyp on right side, I try to do retroflexion if possible.
And what about thermal injury? Because the right side the wall is thinner than the left side.
Yes, so duration of current matters. So you use your standard settings, but you don't do a long duration current. And of course, you grasp the polyp away from the base so that the wall, there's a separation between the submucosa and the muscle layer.
In general, underwater, cold snare, hot snare, means.
So standard simplified protocol, if I say, any diminutive polyp you can remove with excision biopsy. Polyp between 5 mm to 12 or maximum 15 mm, you can attempt cold snare if you have a good place to put your snare ahead of the lesion. Like in this, the folds were catching the polyp. So I would not have that runway to catch the whole polyp without injecting. So I will never attempt even for a small polyp cold snare in this. So in this case, I would want to do a hot snare polypectomy, but cold snare is a very good option in patients who are on anticoagulations. In patients, you cannot withhold antiplatelets and anticoagulation for a long time. You incidentally find a polyp, it happens, and you have multiple polyps. You cannot keep on putting current multiple times. So you do cold snaring wherever you see, and you can use 10 times in a polyp in the same setting. And anything above 12 millimeter, 14 millimeter, I will go for hot snare polypectomy.
I think we are done here.
Yes. We'll just retrieve the polyp. I think we can change the room. Thank you. Thank you.
Thank you, Dr. Nikhil, for the presentation.
वो रॉकेट दे दो ना, ये स्टूल में कहीं है.
Sir, you're not audible in the hall. So we cannot hear in the hall.
Hello? We need sound. We can't hear you. Dr. Dadij?
So I think we have a 96-year-old male with a mass lesion in the head of the pancreas with liver metastasis. So a EUS is planned just for demonstration. So Dr. Puri, you'll be doing the case. Dr. Rajesh Puri. Room number 1, please, Dr. Rajesh Puri. Dr. Rajesh, you are live.
No, sir, you're not audible in the hall.
Am I audible in the hall?
Yes, sir.
So elderly patient who has a mass in the head of the pancreas. So the reason of, I always feel for the pancreas, endoscopic ultrasound is a one-stop shop. And why I said so, that not only you diagnosed, but you can stage the disease. Not only you stage the disease, you can get the tissue sampling. And if the patient has unresectable disease, and if the ERCP is not possible, you can do the EUS-guided biliary drainage. If the pain is a predominant component, then you can do the celiac ganglion block. So that's why I said.
Rajesh, my question is like, you are saying that it is one shop, but the problem is that before that you should have one imaging followed by EUS. Otherwise, you can't do it.
I absolutely agree, Dr. Nijavan, and that I wanted to teach because the loco-regional staging should only be done once you rule out the distant metastasis.
Yeah,
So a
you need to
dynamic
have
CT, a dynamic CT scan.
Yes.
And if that shows that this patient has a resectable disease, then for the loco-regional staging, you can do the endoscopic
So it is
ultrasound.
complementary to other images.
I absolutely agree. I absolutely agree with that. EUS should not be done as a primary modality. Once you feel that this patient require either a palliative treatment or you do want to do a loco-regional staging, then you should do the endoscopic ultrasound, not as a primary modality to do it. That's important. So this is the Fuji scope which I'm using, but we need a mouth gag. So I'm using this scope first time. Can you come here? Just on the screen. And I want my cursor on the left side. Yeah. Mouth gag लगा दो. नमस्ते बाबूजी. आप आराम से लेट जाएं. नहीं ऐसे ठीक है. But meanwhile, if there is any question, I will be happy to answer.
Sir, as a beginner, I just wanted to ask one thing. When we introduce the scope, there's a big challenge while passing through the tricopharynx. It happens. I'm a beginner actually. Any special tips while
Yeah,
passing
I
the
think
scope
it's a very
through the
valid question. Dr. Khilji has asked, especially in the elderly people when there is osteophytes.
Okay.
And sometimes it is very difficult to pass the scope. So the few important people says that you inflate the balloon and then go. I feel myself, even you are having a false feeling because balloon is a pliable thing and you feel it is going to cross, you may produce the injury. One of the important trick is extend the neck of the patient. That is a one trick. Second, is not written in the book. You just do a bougie dilatation up to 18 millimeter. Dilatation means you just pass the Sevry-Gillard dilator. 10, 12, 16, 18, and then you take your scope. We do many of the times in our clinical practice, if the scope is not passable, even if the after extension it is not possible,
call your senior colleague who is good in ERCP.
Okay.
It is easy for him.
Okay.
And if it is not possible, even after that, because of the osteophytes,
Okay.
it is always better to dilate it and then go ahead.
Okay. It's safe, sir, to dilate?
Yeah, because there is no stricture. You are just making a passage little bit wide open.
Okay.
So once the patient is sedated, patient is in the left lateral position. And I'm going to demonstrate the anatomy as well as the loco-regional staging. And on CT scan, if I'm not wrong, this is unoperable tumor, Dr. Dadich?
So you have to demonstrate the liver also and the pancreas.
Okay. Oh, he's still awake. Can you see the? Yeah. Can you show me the water?
Dr. Rajesh,
Water? Suction. No, I want to check the suction.
Dr.
Yeah.
Rajesh?
Yes.
Yeah, he is 96 years of age.
Yes, sir.
And he has a lesion on CT showing the mass lesion in the pancreas. Do you think that further investigation at this age, looking to the performance status, is really required?
It will be really required metastatic workup.
If he has a functional status is good, then definitely. Up to the age of 82 or 84, we have done the Whipple surgery. But if you feel that this patient has functional status is poor, and if patient require a palliative treatment in the form of ERCP or stenting, you can do that. But many of the time, patient relatives want a tissue diagnosis, you can take the FNA.
Yes, this could be NET also, Dr. Rajesh.
Yes.
Discuss with the family.
So can we show the endoscopic image? So with the help of my hand, I know that I am already in the esophagus. One more thing which I do in my practice, I make the big knob away and use the scope as an upper GI. So I can see any fungal infection, any stricturing or any mass in the esophagus. So this is my day-to-day routine. And I can see there is a little bit of narrowing. Can you feel it? Can you see a peptic stricture here?
Yeah.
And this is one of the cause of complication when you are going in.
Agreed.
So you go in, I will try to see, can I pass my scope? Yes. So yeah, hiatus hernia with a small stricture. Is that right?
Yes, sir.
So what I do is, I will on the EUS image, picture in picture with the endoscopy. Yes. So there are two ways of examining. First, you focus the liver. I can appreciate the ascites also. Can you appreciate the ascites?
Yes, sir. We can see it.
And the liver appears to be heteroechoic. Can you see the gross amount of ascites?
Yes.
I will focus the portal vein. If I'm not wrong, this patient, can you see the, put the Doppler? Yeah. So you see the portal vein thrombus? Dr. Nijavan? Dr. Nijavan?
Are we audible?
Am I audible in the hall?
Yes, we can see that. Definitely.
So can you see
it
the
is intraluminal?
Yes, remove the Doppler.
How you differentiate between tumorous thrombus and non-tumorous?
Yeah, I think it's a very good question, Dr. Nijavan. So put the Doppler, please put the Doppler on this. I think that is going to say. Can you see the vascular channels? Inside the thrombus, that's number one. Number second, on the contrast EUS, you can see otherwise a contrast and on CT scan also shows. So there is a thrombus with some vascular signal, but this could be an artifact. It is always better if you want to rule out a malignant thrombus versus a bland thrombus. It is better. You should always do the contrast EUS. Patient saturation is 88. Can we lift the jaw, please? So lift the jaw. Yeah. Oxygen can be increased. Yeah. So just wait for a minute. So till that, I'm going to examine the liver. I can see the pneumobilia that indicate that in this patient, the biliary intervention has done. I don't know the history, but there is definitely a biliary intervention has been done. I can see the right heart. So lift the chin. Just give a movement for a minute.
Rajesh?
Yes, sir.
Mostly, actually, we keep the cursor on the other side.
Yeah, Dr. Nijavan, I am an old school guy, learned from Peter Willman. So,
I know, but
you know, it's the reverse of the image, so it's difficult to interpret. So, and most of us, almost 80-90% of the people keep it on the other side.
I agreed. I agreed on Nizam. Nasal prong डालोगे नहीं? Should I take out the scope? So I'm just waiting for a minute till anesthesia colleague is, yeah, now the oxygen has started increasing. Yeah. So there was a blood pressure was on the 85 and that's why the cold camis can produce. So I think there might be a small metastasis. Can you see on the caudate lobe? Can somebody perceive? Where's the cursor? Can you appreciate either a cholangial abscess or a metastasis? Can you appreciate, Dr. Nijaman?
Yeah, we couldn't see. It's just where is the cursor?
Yeah, I will.
Upar hai, upar hai.
Can you push the cursor? Can you show the cursor? Yeah, Nisha. I will show you. Yeah, just see here where the cursor is. Just see.
Yeah.
Can you appreciate now?
Yes, yes. The echogenicity is different.
Yes. Can you appreciate?
Yes, yes.
This is the rounded.
Yeah, yeah.
So either it is a cholangial abscess or it is a metastatic disease. Why I said because this patient intervention was done.
We can apply Doppler on that and see. You know.
Yeah, that is a too small. And now there is a different function that is called as DSI, discrimination flow rate. In that, even you can see the microvasculature without putting a contrast agent. That is a DSI. And another advantage of that is you don't require a contrast because contrast is a costly. So just applying that, you can see the microvascular inside. The only difference is you cannot say this is arterial, venous or delayed because you are only seeing the vascular signal inside. So this is a new development which has happened. So I'm pushing my scope. And you can see the pancreas. So this is the pancreas. Can you appreciate where the cursor is? This is the pancreas. Can you put the Doppler, please? Yeah, remove it. So once I see the portal vein, so there's a way how to focus the pancreas. I'm just going to guide. So can you put the Doppler, please, now? You see the dilated duct in the pancreas. Can you appreciate?
Yes, yes.
Yeah, remove it. So once you see the portal vein in the liver and you rotate, can you make the picture small little bit? I rotate clockwise my hand, just focus on my hand. This is the aorta. This is the celiac trunk. This is the SMA. Can you perceive this? Give me this. So, this is cursor. Yeah. So this is the celiac trunk. This is the aorta. This is the celiac trunk. This is the SMA. This is the pancreatic duct. This is the pancreatic body and tail.
Okay.
At this juncture, if I rotate my scope clockwise, no, make it a little small. So people, if I rotate clockwise, this is the kidney, and further clockwise is the spleen. Can you see the spleen? And if I do the anti-clockwise, this is the left kidney, just below. This is the left kidney. If I further do anti-clockwise, this is the left adrenal. This is the left adrenal. Is that right? So what information I have gathered is at the G junction, this patient has an SOL in the liver, pneumobilia in the liver surface is irregular, ascites is there, patient is a portal vein thrombosis, and the pancreatic duct is dilated in the body and tail of the pancreas. This information we can get it. And once we finish this, we will go to the first part of the duodenum. Either you do no need to enlarge, is okay. Either you enlarge the endoscopic image. Now I'm just not looking at the EUS. I'm looking at the endoscopic image. I will try to go into the first part of the duodenum.
Can we see the mass here?
Yeah, just let me go to the first part. The papilla also, the pylorus also appear tethered.
This is again a challenge, going from D1 to D2 while doing EUS.
Can you make the image bigger, please? Yes. So you see patient has a tethered papilla?
Yeah.
Yes.
One thing, can we press the abdomen sometime?
We can see from D1 also what the problem.
Yeah, we will see from here also. If not, then I will show it from the stomach side. No.
Elderly patient we can see from the antrum.
Yeah, you see the antrum is infiltrated.
It looks infiltrated.
Yeah, because yeah, I will just keep. So this is very important. If you are not able to go it, you should be very gentle. You should not produce perforation. That is most important.
And at 96 years of age, everything is little.
Yeah. So let me just focus it from here, if possible. Okay. Can you show the, please, can you show the EUS? So this is the pancreatic parenchyma.
There is a mass lesion. See.
Yeah, this is. Can you appreciate here?
Yes, yes.
So now see here. This is the pancreatic duct. Because I am in the stomach, I will just show you again. This is the pancreatic duct. Can you appreciate?
At the level of
this is the duct. This is the portal vein with the thrombus. Can you see the pylorus which is thickened? Can you appreciate here?
Yeah, infiltration is there.
Can you appreciate?
Yes.
That is the liver. If I try to go clockwise, this is the bile duct. Can you see the bile duct? The pneumobilia?
Yes, yes.
And this should be the mass here. This is the mass, Dr. Nijaman.
Yeah, it's seen.
Just below it. But I think I absolutely agree what you said. 90-year-old and an ultrasound would have shown the ascites. You would not have required to do the EUS and doing the everything, because look at here, the anesthesia colleague was there, patient has a fall in the saturation. But I absolutely agree, if this kind of finding is there, no point in doing EUS. And one more thing which I want to highlight, if patient has a liver metastasis, no need to go through the EUS-guided because it adds to the cost. You just go with the percutaneous ultrasound, take the FNAC from there, and that shows malignancy. So I think that avoids. And now with the pancreatic tumor, many of the time they require more markers to look for the immunotherapy or so. So we talk about taking the biopsy with the help of FNB needle. But in my practice, what we do, if patient has a metastatic disease, we never do endoscopic ultrasound. We do the transabdominal ultrasound, take the biopsy from the liver, aspirate the ascites. And for pancreas, if required, we don't do percutaneously, we do. But in this case, certainly, I absolutely agree. You don't require. Look at the gross ascites.
So just for the sake of discussion, is it because of cirrhosis what he's having or because of the malignant ascites?
So that will only be seen because cirrhosis is going to develop secondary. So you have to see the clinical profile of the patient and then try to assess. But definitely this is the advanced disease, irrespective of what, because patient has a portal vein thrombosis, patient and SOL, and ascites can be tapped and you will come to know. So I think EUS is not justified, number one. But what is required in EUS? I talk about what you look from the G junction. I talk about what you would have looked from the first part of the duodenum or from the pyloric antrum, because as I said, this is very important when you see portal vein. You can very well see here portal vein. This is a portal vein with the thrombus. This is the GDA. And if I rotate my hand, I can see the thickened duodenal wall and I can see the pneumobilia and the liver also. So that indicates that biliary intervention has been done in this case. Anything else required, I will be happy to answer. But I think this patient, you don't require more than this.
Sir, in cases of pancreatic FNAC or biopsy by EUS, if the patient has gross ascites and still we are taking him up for EUS-guided sampling, would you like...
Can you speak loudly?
Sir, if you are planning an EUS-guided biopsy, not for this case, some other case from the pancreatic head, and the patient has ascites, do you prefer to drain the ascites before the biopsy, or can you go ahead with the biopsy even with ascites?
Yeah, so I think it's a very good question. Number one, when you are taking the biopsy, if you are taking from the pancreatic head, being a retroperitoneum, first part of the duodenum, second part of the duodenum, ascites never come across. But if there is a significant ascites, it is always better because you are needling transduodenal or transgastric. To prevent the infection, it is better to aspirate. And even how you have to prove it, this ascites is because of hypoalbuminemia, because of secondary biliary cirrhosis, or because of metastatic disease, you invariably requires. Okay?
Yes, sir.
Anything else from this case? I will be happy. This is the left atrium, left ventricle, and the ascending aorta on the left side on this side. This is the aorta. This is the left atrium. This is the left ventricle, mitral valve, coronary arteries. If I rotate my scope a little bit clockwise, this artery become rounded. So this is the aorta, and left atrium is a subcarinal space, and this is the aortic valve. Now to focus the AP window, which is a common, so best technique is focus the aorta, pull your scope, and once you see where the aorta become the arch of aorta, do a clockwise rotation and the big knob, and this is the aortopulmonary window. Is that right? Yes, sir. Can you freeze this? Freeze. So this is the aortopulmonary. Cursor. Move the cursor.
There are 2-3 announcements. The lunch is ready. So the plan is to do lunch and then
as a beginner,
be followed by.
there are radial US also
we
available.
can continue with the workshop.
Now everybody is going on
or the
linear,
alumni
linear, and
meet.
linear. As a beginner, shall we start with the radial US or straightforward the linear?
Post workshop, there are 2
Give
events
some
which
few
will
days
occur
to give the
at
trouble.
SRK.
Okay.
But you will be
One
accustomed.
is
with radial, sir?
class on EUS, the practical aspects by Malay Sharma, and the other one is the cautery. It will be actually taken by the country head of RB. So basically, if you need to understand about cautery, which is very important, and about diagnostic EUS. So these 2 things will happen after the workshop at SR Kalla Hospital. And lunch is on, so you can have lunch. You can have you can see the workshop also, and shortly we'll begin with the alumni meet also. So from here we'll go across this wall from the door.
So, sir, I was just asking about the radial versus linear US. As you have clearly pointed, radial US should be done by the beginners. So,
no, I said because the cost of equipment is so high.
Okay.
It may cost around 20 to 30 lakhs rupees.
Yes, sir.
So it is not going to add on value, only a psychological feeling that I'm getting the 360 view.
Okay, sir. Okay.
So if you buy a linear, which is going to help not only for diagnostic, but also for therapeutic.
Okay.
Once you have bought a diagnostic scope, you can't do any therapeutic procedures.
Yeah, of course, sir.
Yes, sir.
Nowadays, we should not buy radial.
Yes, sir. I said the reason very clearly. There is a mental block that with the radial, you can see the 360 view. With the linear, you can see 110.
110, you can rotate the scope and you can see that also.
Same thing I'm telling. It is always better to buy the linear scope.
Yeah,
because
and radial
once you
adds to the cost also.
Yeah, once you buy radial, you have no option of therapeutic. But if you buy a linear, you can do diagnostic and therapeutic.
No,
and
we
if
have
you
radial in our department and linear. So the percentage of using radial is almost 5%. 95% it is linear.
So that's why, and each scope costs 20 to 30 lakhs rupees. So it is always better to buy the linear scope. rather than buying the radial scope. I don't prefer to buy the radial scope now.
What about the newer machine of ultrasound by Olympus?
So just to inform you, sir, I
model,
don't know the Olympus people are around or not, but they are giving EMU3, but the latest Hitachi machine is going to come. Already launched in Australia, if I'm not wrong. And I have not bought EMU3 because of that. The latest machine is coming, and I think within a year they are coming up with a very good vision, that is Hitachi machine. And so these are the two.
With Hitachi machine, I mean, you can't have your Olympus scopes.
Yeah, we will have.
We'll have the Olympus scopes for that, right?
Yes.
There will be attachment of Olympus scope with the Hitachi machine.
Yes. So they are coming up. So when I started my endoscopic ultrasound in Medicity, we have a two machine. One is a Hitachi, which is a processor, and the scope of EUS.
But the Pentax, they have the Hitachi machine.
So Pentax has, and actually if you look at if you look at all the scopes, sir, they came from the same company with the different labels, small differences. So the new scopes which is coming, EMU3 which is coming, is fantastic and is very good. But those who are recently going to buy the Hitachi machine is also coming up with that. And that is also have a very good processor system. So these are the new armamentarium which is going to come in the recent year.
The problem with EUS is, like, if you want to do a therapeutic EUS, you don't have dedicated instruments for that. I mean to say, the wires, the needles, and so it is. I mean, you are using many of the things which are being used for ERCP.
For ERCP, I agree, because this is one of the things which people are facing the problem, that we don't have a EUS dedicated device, and we most of the time keep on using, except needle, we keep on using the ERCP devices.
There is shearing of the wires when you use over the needle, actually, because the needles are sharp, and if there's a bend and you're using the wire, you may actually shear the sheath over the wires.
I agree, sir. I agree. This is one of the weak area where the people are facing, that there is no dedicated EUS device which can help in doing the better understanding of procedure, better safe procedure without complications. The people are working on it. But the lamps is one of the thing which is a dedicated device. You don't require fluoroscopy to do it. You can do the procedure even in the ICU under endoscopic ultrasound. So that is a dedicated cautery enhanced lamps, which is very good.
Actually, that is the future of therapeutic EUS, because it is again everything in one. So we have cautery, you have lamps, and straight away you don't require wire. You go
So rather than Seldinger technique, meaning that puncture, exchange, dilatation, stenting, 5 steps can be avoided with the one device, which is a hot cautery enhanced lamps. So this is one of the advancement.
The problem is little of the cost. I think in future the cost may come down, and we can use more of them.
So sir, now the Spexes has come. The Nagi hot is also coming. So the devices are coming and cost is going to come down. And the Indian variant has also come. I have never used, but the Indian variant by J Mitra has also come.
Yeah, actually, J Mitra accessories we use, the lamps we use, but if it is an easy stenting, there Mitra has no problem. But whenever there is a complicated issue where the stricture is very tight, the stricture is very proximal, then you have problems with Mitra stents.
Yes.
If it is a lower end block, CBD is dilated, there is no obstruction at the luminal level, then the Mitra stent is good enough. But if you are dealing at porta, where it's a longer stricture, it is a tortuous stricture, then Mitra is a problem.
No, I agree.
Flexibility of these Indian instruments for hepatobiliary is a problem.
And actually, as I said, the EUS give the one direction. It is not possible that you have gone through one and I was using one of the cautery enhanced lamp, which is locally made, and I punctured the gallbladder. And the inner flange is open and the outer flange is not open.
That becomes a problem.
And the inside sheath was not coming out. And I was in the great difficulty because
you get a
if
lot
I
of
would have
sweats,
taken out, the patient would have a gallbladder leak. I kept the wire, the two loop. You just imagine 7 to 8 centimeter of the wire is in, and I exchange, and then I put another stent. So it required lot of technique and lot of perseverance. Otherwise, patient will end up into a complication.
Yeah, deployment is a problem with Indian stents.
I agree.
With the imported stents, it looks very flexible. It looks
So
very
quality check is there, sir. For them, there is a very good quality check. Here, the quality check is not there. That is one of the major drawback.
So thank you, thank you.
Thank you, sir. Thank you.
Thank you very much.
Thank you, sir.
Are ready with another room where
Dr. Sunil, yes. The next case, please.
Yeah, next case is EUS-GJ to be done by Dr. Jayanta Samanta. So this person has got periampullary carcinoma with gastric outlet obstruction. So room number 3. Can you present the case, sir?
हाँ ये फर्स्ट नहीं है नहीं सर इट्स नॉट अ पेशेंट इनसे कौन सा पेशेंट नाम क्या होता है उनका पेशेंट का we are moving toward case 3 जो है सुनीता नाम से सुनीता okay so this is a 56-year-old female. She presented to us with a progressive jaundice and pruritus from past 1 month. The CT and MRCP was done, which was suggestive of mid-CBD stricture with a dilated proximal CBD and IHBRD. The patient had undergone a ERCP followed by CBD stentings, and breast cytology was taken, which was positive for malignant cell. The patient is planned for ERCP plus biliary RFA. So we are moving towards the case, which is going in the OT number 3.
मैं कचौड़ी खा लिया है अभी तो 2 घंटे तक मुझे चलेगा अभी
Dr. Sanjay, you are on.
Okay.
Dr.
Hello?
Sanjay, you are on. Yeah.
Hello. Good afternoon. Good afternoon, everybody.
Hello, Sanjay. You are on.
Good afternoon, everybody. This is a very interesting case of cholangiocarcinoma, inoperable, lady of around 50 years. And we have done a very interesting thing that the patient is very obese. If you can see, patient is very obese. So during ERCP, if you are not intubating this patient, they may develop dyspnea or apnea during propofol sedation. So we have done that. We have passed our scope through LMA. Gastro LMA, it is a special device through which your ERCP scope can go through, and our anesthetist can pass, do the ventilation, supportive ventilation in this type of obese patient. So this is very important in obese patient, that if you use this device, you can prevent intubation. Respiratory complication as well as endotracheal intubation is not required in this patient. It is as good as endotracheal intubation without putting tube inside the trachea. So now we have just removed the ERCP, the stent, which was 7 French stent was put 2 days back. This patient is for palliation of the biliary stricture with RFM machine. This is the RFM machine. You can focus here. This is star-made RFM machine. And they have a 7 French catheter called endoluminal radio frequency ablation device, ELRA, and they have a special prefix setting. Watt is 8 to 10, and the temperature is around 70 degree, and the duration of this is around 2 minutes. So with this, we will just do a cholangiogram to delineate how much the stricture is. We will just put contrast. थोड़ा सा यही आ रहा है थोड़ा
Okay, दिखाओ आगे लाओ.
So I have assistant with me, Ashish, who is there with me for last 25 years, and he knows from each and every aspect of myself also, rather than all procedures. So we will try to. We are just passing a guide wire. Contrast, सीधा. And we will put a contrast. मेरे को अंदर जाने दो. And you can see a very tight stricture inside. Can you see the cholangiogram there? A very, very tight stricture in the mid upper CBD. So now we will pass a guide wire deep. And if you can see, it is around 3.5 centimeter long stricture. So it will require at least three passes of the RFA, because this RFA catheter, can you show the RFA catheter? This RFA catheter has 4 markers, 1 centimeter apart. So this is almost 4 centimeter. So they will pass the heat through this steel. Yeah. Can you see?
Yes, yes.
So it is a 7-phase catheter, so you may not need to dilate. If it's not going, then we will dilate. If guide wire and your sphincterotomy is passing through it, wire gap. Yeah, you can see the guide wire deep inside, and I will pass my sphincterotome. If it is going easily, I will not dilate it. If I have problem in passing this sphincterotome inside, yeah. Huh? नहीं. So there is some muck coming out. एक 7 French का dilator. Yeah, because see, you have to access that whether your sphincterotome is going easily or now it has gone inside. So it is more likely to, this catheter may go inside easily, and we will try that. We will exchange this slowly. There is some amount of blood is always there. And this RFA treatment has shown to increase the patency of the stent, as well as it has definitely shown to increase the life of the patient also. So this is a very good armamentarium to have in your setup, because in India we have seen that gallbladder cancer, even the CBD cancer are increasing now. So most important thing is they present late, and most of the time they are inoperable. So whatever best we can do, we should do for this patient. And RFA is a very good modality to treat this. And nowadays there are papers that with RFA you can put plastic stent and repeatedly remove this plastic stent and do another RFA. So metal stent may not be done during first session. You do second session of RFA, and if patient is doing well, you just put plastic stents for that also. So it will reduce the cost for the patient also. With this RFA, it is very important that once you do this RFA, you always flush or you always remove the debris before putting plastic stents, because otherwise plastic stents get clogged. So now we are passing our RFA catheter. Pedal है? Pedal किधर है? Pedal. Direct? Okay. चलेगा. So the most important thing about this is you can see the catheter inside. They have 4 markers which you can see on the fluoro also. Fluoro. You can see how easily it is going. So always check before with your catheters that your catheter will go easily. Now you can see the upper side of the stricture. where this catheter is there. बड़े में नहीं दिख रहा है. हाँ, इसको बढ़ा दो. So now, can you see? See the marker? हाँ, सीधा कर लो. Wire सीधा कर. I will try to change my guide wire position inside. I will try to be as straight as possible. Come back. Aja. Yeah. Yeah. Yes. It has gone now deep in. And now my catheter is easily going in. Because the guide wire was coiled, it was not going in easily. यहाँ से डाई डाल सकते हैं? ये है ना? This catheter we can put double lumen channel from the same cholangioscope. We can put cholangioscope के ऊपर है ना double lumen. ये रहा. हाँ, निकल रहे. If you have a cholangioscope with you, you have this double lumen catheter which can be attached to this, and you can use this as another contrast. You can push the contrast through this. So you can make any double lumen catheter into tri-lumen with the help of this. So this is very useful device to have. If you have a single channel device, you can make them double channel with this. And if you have double channel device, you can make triple channel with this. So he just putting the contrast inside. So I would like to see the upper end also, from where I would like to start. Dal. Wire सीधा कर लो. Wire सीधा करके I am coming down. हाँ, wire सीधा ऊपर डाल दे. पीछे जाना है अपने को. I think the wire is coiling because it is in the cystic duct. So we would like to change the position of the guide wire. थोड़ा नीचे आता. I will change my position. You can see the position change inside. I would like to come down, and then I will pass my, yes, now they are going deep in. Yeah. So,
very nice.
Yeah. Now we will put contrast. Now you can see the upper end of the stricture. Previously we were in the GB.
Yes.
Yeah, you can see the GB stones inside. So
Yeah,
it is
we can
very
see that.
important to have a good assistant with you who can guide you when you are not going in good direction. Our catheter is at the upper end of the dilatation. Now we are taking it on fluoro. Yes. So if you can turn a little bit patient prone or supine, we will have a good picture. सीधा कर दो. हाँ, सीधा कर दो. Yeah. Make perpendicular to the back. वो ज़्यादा time हो जाएगा. Now we will start our first session of the RFA. And this special catheter has a depth of injury up to only 5 millimeters. So there are very less chances of perforation, and they have prefixed watt and the duration as well as the temperature. So till now there are very less
You always put in a stent after RFA?
Yes, always, sir. Because we have put contrast, and usually we do the cholangioscopy also. इधर ही ले लो, वापस ले लो. So now we have seen, ले लो.
Dr. Sanjay can be sipped for a brief moment to room number 1, where there is interesting case. Dr. Shreyans is presenting.
See, now we are at the upper end. They are changing. बताओ. Yeah.
Hello.
Yeah. Now, so we will start. We will just start, and you can go with the next case, because it will take 2 minutes here. We have just started the RFA. And now you can change. Case? Now you can change. Yeah. Okay.
Sunil, what is the next case?
Because the 2 minute we take, 2 minute looks very long while waiting in these cases.
This is a case of a 34-year female. She presented to us with complaints of pain abdomen, progressive jaundice, pruritus since past 2 months. She was suspected to be a case of carcinoma gallbladder with a type 2 block. MRI MRCP image showed a GB fossa mass 71 into 64 infiltrating the adjacent liver parenchyma and reaching the porta hepatis. It involves the confluence causing the IHBRD and proximal CBD dilatation. Multiple periportal and peripancreatic lymph nodes are seen. Patient is having a bilirubin of 25, LFOS of 994, a normal value of 120, and CA99 of 1000. The patient is planned for US staging. This is the type 2 hilar block. We can see in the MMIP image. Now we'll proceed towards the case. This is showing the GB mass infiltrating into adjacent liver parenchyma. So we'll be proceeding towards the case OT1.
Yes, Malay, you're on.
Okay. So here we are in the stomach, and the first thing we see is that this is a vessel, arrow, and this vessel that we see is the superior mesenteric vein, this is the splenic vein, and this is the portal vein. Once we see this complaint in the stomach, we are seeing that these veins have divided the pancreas into two parts. This is the body of pancreas, and this is the head of pancreas. In fact, the left border of superior mesenteric vein identifies the junction between body and head of pancreas. The diameter more than 10 indicates portal hypertension, 8 splenic vein, portal hypertension, and portal vein more than 12 indicate portal hypertension. So the formula is 6, 7, 8, and 12. As I rotated here, I could see that this superior mesenteric vein is dividing in this complex, this portal venous confluence complex, is dividing into three parts, 1, 2, and 3. So this is the inferior mesenteric vein, this is the splenic vein, and this is the superior mesenteric vein. If we apply color Doppler, we can find out that these three are fusing together. And as I rotate, they fuse together. Remove color Doppler. So this is the idea of how to see the pancreas. The pancreas should be divided into body and head by effectively passage of the superior mesenteric vein, inferior mesenteric vein union, splenic vein union. And you see, when I'm watching this complex, you must understand why there is a convexity towards this point. Because this convexity will evolve into splenic vein. You rotate it here, splenic vein. Rotate it here, splenic vein crossing in front of superior mesenteric artery. So this is the complex. So these are the diameters, and once we see this portal vein here, we have to concentrate in head of pancreas, which is in this area. And the head of pancreas is divided into two parts, anterior head and posterior head. Posterior head is the hypoechoic area which you see here, and anterior head is the hyperechoic area. So the pancreas from this stomach, even without moving, you can identify body and head, anterior head and posterior head, and within the posterior head, you are looking for passage of the CBD.
Malay, which scope you are using?
It is a Fuji scope, Fuji film, and model is 5830 UT, 380 UT. Now, in this stage, you are also finding that this is a pancreatic duct. And when I rotate here, this pancreatic duct is passing into the hypoechoic area. That means this patient does not have a pancreas divisum. And this pancreatic duct is fusing the pancreatic duct of body across this area. So I will freeze so that I can remove the characters. And then I am able to follow arrow. I am able to follow the pancreatic duct from the body across the neck into the head, and then from anterior head of pancreas into the body of pancreas, posterior head of pancreas, and then this is the duodenum somewhere where they are going. So in this case, I am unable to see any CBD obstruction at lower end of CBD. This is the hepatic artery, So I have got this much information from stomach that this patient has got the pancreas, there is no problem. These are the normal structures that I have shown. Superior mesenteric vein, inferior mesenteric vein, splenic vein, portal vein, pancreatic duct, passing like this from body to across the neck to the head, from anterior head to posterior head, and then, so now I will go into the bulb. For that, I insist that your movement should not have Parkinsonism, and you should have one steady movement while you are advancing towards the pylorus. I personally do not like this movement. I insist that you should know that in one steady movement, like a panther you are falling and you go into the pylorus. Once you reach into the pylorus, what do? You fix the scope. How do you fix the scope? The simple trick is you just keep it down and move it to the left and right. This is the way of fixing the scope. And now you will see the same thing here, that this is the superior mesenteric vein, this is the splenic vein, this is the inferior mesenteric vein, and this is the portal vein from here onward. So the same thing you are seeing here is from the bulb now. And now once you see this, you will see that this is the pancreatic duct that you are seeing from the duodenal bulb. If you rotate right now from this position, you will find that at this somewhere just now, a gastroduodenal artery color will cross anteriorly, and this is the arrow.
This is gastroduodenal artery.
This is the gastroduodenal artery, crosses anterior to the neck of arrow. I want arrow as well as color. So the gastroduodenal artery will cross anterior. Now apply color. So again arrow also can be no. So we cannot see arrow, but right now remove color. So right now arrow, we can see that this is the gastroduodenal artery. Yeah, this. And this is the portal vein. And once you see this gastroduodenal artery, it lies in the anterior groove of the pancreas. Can we zoom it depth? It lies in anterior groove of the neck of pancreas. So this is the neck of pancreas that you are seeing, gastroduodenal artery anteriorly, portal vein posteriorly, and this is the classical neck of pancreas that you see here. If from this position you rotate clockwise, you are likely to go towards this is hyperechoic pancreas. You rotate clockwise, and as in endoscopy you advance towards the ampulla, same way the pancreatic duct is advancing towards the hypoechoic area and towards the ampulla into this hypoechoic area. So this point, it showed me as the pancreatic duct by rotation moved from hyper to hypoechoic pancreas, that this is not a pancreas division. So as I am rotating, I can see a clear boundary between the posterior head of pancreas and anterior head of pancreas, and the pancreatic duct has entered now the posterior head of pancreas. But I have to rotate further in the hope that I will find the bile duct. Until now, I have not found the bile duct, though I am seeing the IVC and the right renal artery. So I have not found the bile duct so far. So I will now just push the scope a little bit in, rotate like this, and then again rotate clockwise. As I am pushed the scope in, I went to the upper part of this artery, and will we apply color there, color Doppler here. This part of the artery, remove color, which is seen as an arrow, is coming like this, is the common hepatic artery, which is dividing into two branches, hepatic gastroduodenal artery and the hepatic artery proper. This is called a seagull sign, because this was the venous seagull that I have shown. You can see the venous seagull where the body is up, the wings are down. And this is the arterial seagull where the body is down and the wings are up. So from the bulb, you see two vascular seagull. One is a venous seagull, wings down, and second is an arterial seagull with wings up. So this is the wings up seagull. This is the wings down seagull. Wings down seagull. Wings down seagull is bigger. Wings up seagull is smaller. So as I rotate here, I am trying to see if at this point the pancreatic bile duct comes closer or not. As I rotated, I found that there is some sort of a mass here in this part of the pancreas. I will change the depth now and then assess that what is this mass, and this mass is again coming in the, it is a very variable mass, and this has gone as I am toward the gallbladder. The gallbladder. I am going seeing the gallbladder, and as I see the gallbladder, this is the gallbladder neck mass which is infiltrating into the iron. So these are the ducts. We'll apply color here again, and we'll find out that this patient has got a gallbladder neck mass which is infiltrating into the So again apply color, and you will find out that these are the vessels which are encased running close to the mass, and this is the gallbladder neck mass which is infiltrating into the. So I think we have done with the diagnosis of the case so far. Now the question is, she is a very malnourished lady. If we want, we can do an FNAC of this mass so that the color remove. So this is the diagnosis so far. Now the question now is that as I rotate here, I find several nodes. In this case, this is the node which is passing close to this artery bifurcation of celiac artery, and this is one node. This particular node is rounded. This particular node is not so rounded. And this node is running very close to the hepatic artery. But this node is separate. This node is not part of any liver parenchymal tissue. So originally I thought that this is a node, but this is not a node. This is part of liver tissue, whereas this particular node is not a part of liver tissue, this node. So the question is to do FNAC of this node or to do FNAC of the mass of this area. So this is the area. Now, in this area, I would just want to show that this is the particular area where we are seeing the neck of the gallbladder and the fusion of the anterior and posterior duct of the gallbladder, the left and right duct of the intrahepatic bile duct. So this patient has got a gallbladder neck mass which is extending from neck to just at the confluence of the gallbladder. I have a habit, I don't ask about the CT finding until and unless I have done AUS. Right now, I am seeing, now I can ask the CT finding. Did the CT finding show a gallbladder neck mass obstructing the common hepatic duct where the union of right and left duct is patent? Is this the same finding? And I will ask Dr. Mukesh whether he wants any FNAC or not. So this FNAC. So Dr. Nijawan, what would you want an FNAC? There is no need.
Hello. Yes, sir. Dr. Malay, sir. Dr. Ashok here.
Yes,
Any extra
yes, sure.
advantage, sir, we have with
I will not do an FNAC for one reason. Because financially, this is going to cost 15,000 rupees, 10, 15,000 or whatever. FNAC. So they want an FNAC. You got free needle for the conference?
Dr. Malay, can we shift to room number 2 for another procedure, interesting procedure, EUS-GJ. Thank you very much for a very nice demonstration.
Okay, thank you.
Thank you very much, Dr. Malay.
FNAC दे देना.
FNAC can be done, Dr. Malay, if you wish.
Yeah.
Yeah.
You can shift.
So the next patient is a
76-year-old male presented with us recurrent vomiting, jaundice, and intermittent fever since 15 to 20 days. He is a diagnosed case of periampullary carcinoma with liver metastasis. Status post-ERCP and CVD stenting. Now planning for EUS-GJ plus EUS CVD or HCS. Now proceed to room number 2.
So over to you, Dr. Jayanta.
So
Yeah,
just
Dr. Rajesh and Dr. Jayanta, you are on.
Okay.
नहीं
Am I audible
उधर
now?
तो 10-15 मिनट और लगेगा ना रे.
Am I audible?
Yeah, अभी audible से.
Are we audible in the hall?
Yes, yes. Dr. Jayanta and Dr. Puri
10-15
both
मिनट
are
अपने
audible.
जितना
Okay,
fast
thank
कोई
you.
नहीं है.
So good afternoon, everyone. We have already heard the history. So we're going to do. We are planning is for the US-guided gastrojejunostomy. I have with me Dr. Rajesh.
निकाल लो ना, अरे पे तो खत्म हो गया ना अभी. इसको निकाल लो plug.
So this patient, what we did behind the camera was that we tried to place an NCD deep inside beyond the tumor in order to insufflate the jejunum with fluid. So once we have done that, this is a freehand technique. So like yesterday, you must have seen Dr. Sandeep sir.
करंट नहीं
performing the
लगता
birth.
रे तेरे को मालूम
This
नहीं
is a
क्या?
more of a freehand technique.
आदमी को लगता
where we try to So where we try to inflate the loop with a.
बता दो गुरु. पहुंच गए.
Is the US image
Yeah.
visible to the audience?
Yeah. Yes. Yes,
So you
US
can
image.
see, this is the if you see the
Is
point.
the EUS image coming in the hall?
Yes, yes, sir. It is coming.
Sir. So you can see that sir is showing. So this is the tube that you can see over here, which is showing a railroad kind of a track, and yes, tram track appearance kind of a thing. And here you can see there's a nicely dilated. Can you see this loop is here?
Yes, we are.
And we are going to target this loop. So it looks like it's a longitudinal loop. We have a good run over here. We're going to just switch on the flow once. It's absolutely fine. There's no vessel intervening. And sir, can you show the landing space? We have a good amount of landing space. What do you think, sir?
Dr. Jayanta, which tube you are using for it?
Please give somebody, sir, a mic.
Yeah, I think we have a good landing space of 7 centimeter.
Okay.
And a few important thing is you always give buscopan to the patient before the procedure.
Right, sir.
Don't try to put the water in the beginning because if the procedure delay, then a lot of water go to the distal part.
Right.
So just as Jayanta has put the water just before the procedure, so that make your procedure easy and successful. So this is the descending limb, the longitudinal limb which has come, which is very important. Yeah, and we keep on putting the water.
As sir has aptly pointed out that we try to stop the peristalsis as much as feasible.
Dr. Puri.
Yes.
Which tube you are using for insufflation?
Which?
Tube you are using for installation of the water in this? In jejunum, which tube you are using?
So we are in the D4, proximal jejunum and D4. If you see, this is a descending limb. Yeah. We are using the nasobiliary drain
Okay.
as a tube to inject the water.
So do we go in?
Yes.
Okay.
A
So now
little
we are
more
going
inflict.
slightly
Can
more.
we give one buscopan, please? Or glucagon?
Hey. Either देखो ना.
So one very important thing,
hold here.
you always look for any intervening bowel loop.
Yes.
This is the common mistake. So we were facing the problem, but Janta has very nicely removed and choose a loop which has no intervening bowel loop. And you can see this is the stomach wall and this is a jejunal wall. There is a no intervening loop. That is very important in this case.
So now we're going to plan to go in. Yes, sir. So do you think it's okay? We are
Yes, I think we should go ahead.
ready? Okay, thank you. So Pratham, I'll require slight more inflation maybe. Yes, very good. And I'm going to go in. So we're going to burn through this. So we are in. You could see the bubbling over there. So I'm going to nicely move inside.
Yes.
Yes, please. So we deattach the coil. So you think we are in, right?
Yeah.
Right. So what we're going to do is we're going to push in the system as deep as possible. Then we unclog this one.
and start deploying the proximal flange. So once we have deployed the proximal flange, can you hold this so that the people can see? Right. You're going to deploy the proximal flange first.
You put the water.
Put the water, please. Please hold this like this. Right. Thank you.
Yes.
So we have deployed.
And sometimes you have to wait for some time. You know,
Yes,
this is completely
yes.
expanded
Now you can see
now.
this is completely expanded and nicely. So the moment we pull it over here, you can see this is the loop. Can you see the loop here?
Yes.
So you can see it is in continuation with this water level. And so you think this much amount of deformity is fine, right?
Yes.
So these are the two. Can we have some silence in the room, please? So these are the two limbs which we can see. Sir can actually help me showing. And after we are sure that we have pulled in, so you think now we deploy the proximal flange, sir?
Yes.
So we're going to again lock the system and then deploy the
Inside the channel.
Right? So we have already deployed. So the game is done. Now we're going to switch to the endoscopy mode.
Endoscopic view.
Yeah, thank you. So what all we're going to do is we're going to gradually move away from the lumen towards the right and try to push the Yes, you can start now seeing the mesh. Can you see? Now we start pushing the wire out and this.
Yes.
So we've already deployed now. You can see nicely the fluid is coming out. What we are going to do now is we're going to detach it everything. So you're okay with this, right, sir?
Yeah, I think it's perfectly fine.
So you can see nicely that the
You can see the diluted methylene blue colored fluid has come.
Yes.
And that indicate that you was in the right position.
Yes, you can see over here nicely that the fluid is coming out. And we're going to have a fluoro image as well. We're going to actually kind of see the stent nicely deployed. Yeah, you can see.
Excellent, Jayanta. It was a cakewalk for you.
No, sir, it was possible because we had Rajesh Puri sir continuously guiding me through the whole procedure, sir. Invaluable inputs from him, sir, no doubt on that.
Team approach.
Yes, sir, absolutely. It's always a team approach. And obviously, I had Mr. Pratham from Boston Scientific also helped me a lot. So definitely, I'd like to, sir, you want to do a contrast study or you just leave it like that?
Rajesh is always there to help everybody.
Rajesh, sir, no doubt on that.
We must congratulate him for...
come out or you want to confirm or something? Whatever you say.
To show the audience, we can put the contrast. Otherwise, you generally don't require.
Okay, sir.
But
can we have a cannula or something?
Cannula with the wire also. Use the thermo wire, huh? दूसरी वायर आने से प्रेशर लगाएंगे जो डालने वाला है कितना प्रेशर मार रहा है आपको पता नहीं है
समझ गए
और कैन्युला अलोन क्या होता है इसकी फ्लैंज
So you can actually see there's a lot of fluid that we had actually kind of placed is coming out. So you just got to keep patience, suck out everything because obviously the patient is intubated and we do not want all this water to kind of cause a risk of aspiration. Dina?
Dr. Jayanta. So we'll switch to room number
Thank you, Jayanta. Thank you very much. Big round of applause for him.
Yeah, big round of applause for him. Dr. Sanjay Rajput is ready for the RFA being done.
Yeah, RFA has been done. Now you'll show us what has happened.
Dr. Sanjay?
Yeah, Sanjay, you are on.
Sanjay, you are
Now
on.
you can see the beautiful image of post-RFA.
Yeah. So you always do colonoscopy after?
Yes, sir. We always do pre and post because we will decide how much it is one and whether we want to put a metal stent, whether we want to put a plastic stent. If this is a very good RFA, we can get away with the metal stent and we can save the lot of money from the patients. So you can see how beautiful images are.
So you will like to repeat RFA?
Yeah, I will repeat RFA after 6 to 8 weeks.
So it will be a fully covered stent or what?
No, I will put only plastic stent, sir, because there is a dilatation above this.
Yes.
And CHD is not involved. So this patient will do well with only plastic stent. We do not require metal stent for this.
Yeah. But post metal stent, can you do RFA again?
No, it is very difficult to do post metal. So if you want to do RFA again, please put plastic stent and repeat the RFA. And when your RFA sessions are over, and you are satisfied, then you can put the metal stent after second or third session.
Very nice.
Thank you, sir.
Thank you very much. Thank you.
Bye.
Big round of applause for Sanjay. बहुत बढ़िया किया भाई.
Thank you, sir. Thank you. चलो. Off करो इसको अभी तो. बंद करो. निकालो. Extend कर लो. Extend करो.
Mukesh, Kalla and Dr. Pankaj for concluding remarks. So, yes, Mukesh, we are here.
Boss, आओ ना इधर. नहीं, please come.
Yes.
On behalf of G6 and the organizing committee of
other three of the G6 are here.
Yes,
Amit,
yes.
me and Rai sab.
Yes. So all G6.
हम दिख नहीं रहे, हमारी आवाज आ रही है.
Virtually and physically, all G6 are there, and they have been the strength behind this meeting. And this meeting has been a great meeting and the great support from each and every one of us. I hope everybody has enjoyed. And I must give special thanks to my team, in particular Dr. Pankaj Shrimal. Pankaj has been a backbone of this workshop, accumulating cases, getting it done smoothly and thoroughly. And God has been kind to us because none of the patients has had any problem at all. Patients did well, they got good results. And I'm extremely thankful to my faculty. And for those people who have left and those who are here, in particular Dr. Rajesh Puri, who is such a versatile player that he is available to us as and when needed and as and when for whatever procedure needed. A special thanks to Dr. Malay Sharma because he took pains of traveling at odd hours, and for on a short notice also he came over for us. So I'll give it to Pankaj to say a thanks and then followed by Dr. Govil.
Yes, it was really a wonderful conference, and we did a variety of cases, and they were beautifully done by all the experts across the country who came from far off here. And post-procedure also, yesterday we saw the patients in the evening. All the patients were absolutely fine, no complications, fortunately. And today also, till now, all the patients are absolutely fine. There were no complications. It was really a wonderful conference.
Yeah.
Thank you so much. Thanks all of you. Special thanks to the audience who stayed back all this.
Yeah. Big round of applause for all the audience.
Big round of applause, yeah.
खुद के लिए खुद ही तालियां बजाओ.
Thank you so much.
पीछे गोविंद देव जी की जो तस्वीर लगी है.
And yes sir.
वही सबको आशीर्वाद दे रहे हैं कि ये सब काम अच्छा हो रहा है.
Yes sir.
इसलिए आप हमेशा इसको यही लगाए रखिए.
Yeah. And there is one person who's sitting left of Dr. Nijavan, Ankur.
Yes,
Ankur
yes. खड़ा हुआ है, big round of applause for him.
Yeah. I would say he's like a foster son to me, and he really takes care of each and everything, whatever is happening in the system.
Led by Yogendra also did a
Yes,
job.
and my event team is immensely useful and I mean on the toes for all last 7 days. Thank you very much. And Sunil will say a remark and then we conclude.
Final remark would come from Dr. Rai Sahab and Dr. Nijavan Sahab. And thank you everyone. And both the residents also. Dr. Shreyans, please.
Yeah. All residents did a good job. I had not seen them sleeping for last 3 days.
Yes. Thank you, sir.
Very nice. Thank you. And at the last, I'd like to thank all my people who have come from other places than Jaipur, Rajasthan, all across from India. And there are few people who have come from even US. So special thanks to them. And, this was a new idea of doing a conference where a new brigade of the endoscopists are ready. We had a very nice CME, including them. The ratio was 20-80. 20 were the old and 80 are the new ones. So very many thanks to the new brigade of endoscopists all around who have come here and graced the occasion. Thank you.
Yeah, sir. One last remark. I mean, Vinayak, who's been taking care of all the guests and upstairs on the 4th floor. And I would not fail in mentioning Dr. Komal's name. She gave diagnosis straight away there and then. Even Dr. Malay Sharma's patient, the last FNEC patient, has also turned positive. I was just told. And thank you, everyone, and in particular G6.
And we thank everybody who have joined us.
Sir, Dr. Malay's class will happen at 2:15 p.m. and then there will be a class on electrosurgical cautery at the hospital only. So anybody who is interested is most welcome, because these are things like you cannot get Dr. Malay Sharma
The alumni
in the hall.
should stay here only. The alumni to stay here only. Please. Thank you, Mukesh. Thank you. Thank you very much.
Thank you, sir. Thank you.
Now I don't know what to do in next, because for last 6 months we two were sitting together daily.
Yes, sir. Yes, sir.
So let's see. We'll have something else now.
Yes, sir. Yes, sir.
So we'll have the alumni meet here only, because now there is no other activity going on.
Right, sir.
So we log off from here now.
Thank you.
Thank you.
Thank you. I'll request all SMSG
Sir, Dr.
alumni
Nijaman.
to come inside.
Dr. Nijaman.
Anji.
Dr. Sanjay, I want to say something.
Yes, yes, yes.
It was a nice experience for spending 3 days with you all, and very excellently done conference, and the hospitality of Jaipur and special kachoris.
Thank you, Sanjay.
So, those who have not tasted this, I would like them to taste them.
नहीं नहीं आप आए तो बाहर आ गई
सर बाहर तो बाद में आई, हम लोग अंदर जल्दी आ गए.
नहीं नहीं आप आए तो बाहर आई, बाहर नहीं आई कचोरी.
Thank you, sir. Thank you.
And this gentleman happens to be my batchmate. I'm proud of him.
Yeah, thank you. Thank you. Thank you. So, I'd like to call upon, first of all, the teachers on the stage. Rai Sahab, Dr. Amit. There are few alumni who have turned teachers, so they have to sit there only. अभी हो नहीं पाएगा. आप लोग वहीं बैठे. These are actually, teachers who have taught the alumni. Though the alumni are now teaching other alumni, but now they have become teacher because of these teachers. So, हाँ वहीं आ जाते हैं. वो है ना माइक.
दिनेश आगे बैठो, सीनियरिटी से सब लोग बैठ जाइए, अच्छा लगेगा.
इसमें ये जो आइडिया है फॉर गेटिंग द एलुमनाई मीट इज Rai Sahab, myself, we have an alumni meet at AIMS. Amit की PGI में होती है. So no, they are big institutes, and SMS is not less than any other institute. So that was the idea that was actually percolating in my mind. And वो लोग every 2 years they meet, and then the special part of any alumni meet is the social gathering, the bond which we get among ourselves as a family of SMS. So that was the sole idea of doing it. We did that last year at midterm ISG conference here in Jaipur only, but somehow the attendance was less. So I am going to retire this month. So that was the emotional angle I gave to all my students, and that is the reason that good number of students have come, and I really understand the few who have not come, they had a very genuine reason not to come. So it is well taken, so that's not a problem. But
डॉक्टर हेमेंद्र आगे आ जाओ.
हाँ
डॉक्टर प्राचीश.
हाँ वो ऐसा कुछ नहीं है, ये सब एक जैसे हैं.
नहीं, सीट्स आगे खाली पड़ी हैं.
हाँ आगे आ जाओ तो अच्छा है. सो मैं कहाँ
Sorry.
So at the retirement, you actually tend to forget many things. So पहले तो मैं सिर्फ नाम ही भूलता था रेजिडेंट्स के, अब थोड़ा ज्यादा हो गया है. So this is that was the emotional angle I gave, and I'm very thankful to all the alumni who have come from outside Jaipur. And जो मेरा मानना है वो ये है कि we should keep it a yearly phenomenon. and every year we should meet, and we should meet at our alma mater. That is, we should meet at Jaipur, because we started that much before. Dinesh did one, and then Dr. Singla did the other one. But you can do yourself, and we can come over there. But having our alumni meet at Jaipur should be there. AIMS happens at AIMS, PGI happens at Chandigarh. Similarly, all our alumni meet should be at Jaipur. We have got very many sites where we can actually collect for an overnight stay. Saturday, you come in the morning, afternoon we start, and we actually disperse off on Sunday afternoon. So it's well connected also, so majority of people can come. So that is the idea of the present alumni as a future. So we should continue it. And बाकी तो we started somewhere in 1999. वो अभी you have to come year wise here, and हमने सोचा तो यही है कि हम लोग नहीं बोलेंगे, आज आप लोग बोलेंगे. So everyone is given 2 to 3 minutes of time. You can speak whatever you want to speak, and it is not only we will be sticking to only the alumni who have passed out. Those people who are becoming the alumni are not entitled to speak because they have some inhibitions to speak. So you are all open to say anything you want, anything in your mind. So few words from Raisa, followed by Amit, and then we'll have one by one as far as we'll call you year by year. So 1999, 2000, 2001. तो आपको तो अपना year पता होता ही है, तो आप लोग अपने आप आएंगे.
सबसे पहले मैं आप सबका हृदय से आभार प्रकट करता हूं कि आपने हमें गौरवान्वित होने के लिए बहुत मौके दिए हैं, और आज हम एक उस अवस्था में हैं जहां पर आप सबको उन ऊंचाइयों पर देखकर और इस संस्थान का नाम गौरवान्वित करते हुए कि आप सब हमारे एम्बेसडर्स हैं. जहां जहां भी आप हैं वहां आपने अपने आप को गौरव से कह सकेंगे कि हम SMS के एल्यूमनाई हैं. मैं चाहता हूं कि आप सब में एक भ्रातृत्व की भावना, आपस में एक दूसरे के प्रति जो सम्मान होना चाहिए वो और गहरा हो और प्रगाढ़ हो, और हम आपस में एक दूसरे की सहायता कर सकें, एक दूसरे के लिए अपने आप को आगे बढ़ा सके. मैं ये चाहता हूं कि इस एल्यूमनाई मीटिंग के द्वारा हम लोग और आगे बढ़े. मैं ये कह सकता हूं कि ये जो 3 तिलंगे यहाँ बैठे हैं, इन्होंने बहुत दिनों तक साथ निभाया है, आपके साथ हमेशा खड़े रहेंगे, और ये मैं आश्वासन आपको दे सकता हूं. जब तक मैं हूं, जब तक ये हैं, सब लोग आप सबके साथ रहेंगे, और मैं चाहता हूं कि हमारी बॉन्डिंग और स्ट्रांग हो. थैंक यू वेरी मच टू ऑल माय 3 तिलंगास.
एक तो सबसे पहले तो मैं एक स्टैंडिंग ओवेशन तो सर के लिए देना चाहिए कि इतना सर एफर्ट लेते हैं, राय साहब, डॉक्टर निजावन सर, और मुझे तो ये समझ में ही नहीं आ रहा कि अपना डिपार्टमेंट बिना निजावन साहब के कैसा लगेगा. He is an era of gastroenterology which we can't think of, but yes, he has created some wonderful juniors who will take over the gastroenterology department. But sir के जैसा मेरे हिसाब से तो कोई नहीं हो सकता. I think most of the students can agree. As a teacher, as a mentor, as a friend, as a brother, he's always there for all of us. And honestly, we would miss him. You all would all miss him, but he's always there. तो सबसे तो ये है कि ये महीना बड़ा इमोशनल महीना है कि सर SMS से रिटायर हो रहे हैं, बट ये सिर्फ रिटायर हो रहे हैं, ही विल ऑलवेज बी देयर फॉर ऑल ऑफ अस. एंड ऑनेस्टली इट इज़ जस्ट लाइक अ फैमिली. और मुझे तो जब भी हमारे रेजिडेंट्स यहाँ आते हैं तो मुझे तो बड़ी खुशी होती है, सर को भी होती है, कि we all meet and जैसे सर ने कहा है, it can be a good interaction if we have it every year, क्योंकि हम लोग मिलते रहेंगे. And in fact, it would be very useful to help each other professionally also. So we are always there. And thank you, sir, and thank you all of you that you really made an effort to be here for this. Even जैसे अमित है वो तो रात में आया है, just to be here for the alumni meet. So we would now request each and every one of you to come forward. कुछ अपने दिल से बात करें और कुछ आगे क्या करना चाहते हैं और क्या कर रहे हैं हम लोगों को बताएं.
We called Dr. Nepali and Dr. Sharma ji also, but they are stuck up for some of the other reason. No problem. So we'll carry on, right?
अभी यहाँ senior most
first batch ये आ जाओ भैया.
Mahavir Prasad Sharma, he is the senior most. And now professor and head of the department, we are really proud of him.
Running DM course. So सर आप टीचर के टीचर हो गए हो. मेरा एक ही कहना है कि टीचर नेवर रिटायर्स, है ना. सर कह रहे हैं कि मैं रिटायर हो रहा हूँ, पर सर नेवर रिटायर्स. मेरी फैमिली प्रॉब्लम हो या मेरी पर्सनल प्रॉब्लम हो, सब में सर हेल्पफुल रहे हैं. इवन राय साहब तो मेरे, क्या बोलूँ मैं, अभी भी मेरे को सर के सामने बोलते हुए घबराहट होती है. बट सर के सामने आते ही मेरे को पता नहीं क्या होता है कि थोड़ी सी पल्स बढ़ जाती है. मेरा एक ही मैसेज है सबके लिए, स्वस्थ रहो, मस्त रहो और एंजॉय योर लाइफ. मेरी वाइफ फार्मा में है. शी इज एसोसिएट प्रोफेसर एट जेएलएन मेडिकल कॉलेज एंड बच्चा जो है एमबीबीएस कर रहा है, इंटर्नशिप में है.
वेरी नाइस. और आप क्या कर रहे हो यार? आप तो सीनियर प्रोफेसर हो रखे हो यार. Yeah, he is heading the department at
I am
JLN
senior professor and head at JLN Medical
and
College.
he has a DM training program. उसकी भी अलग अलुमनाई होगी.
ये सबसे बड़ी खुशी की बात है कि अपने ही के सारे पांचों मेडिकल कॉलेजेस में अपने ही लोग हैं जो कि हेड कर रहे हैं. ये बहुत ही अच्छी बात है, बहुत गर्व की बात है.
आइए विपिन जी, आपका नंबर आ गया. आई थिंक नीरज जैन था हमारे साथ, बट हाँ नॉट हियर.
डॉक्टर नीरज था, वो अभी इंदौर में है. और मैं
साथियों का बताते जाओ, साथ में तुम्हारे नीरज था.
और भी बहुत गर्व की बात है कि विपिन अब एक उस ऊंचाई पे पहुंच गया है जिस पे आप सबको पहुंचना है. ही इज नाउ द प्रिंसिपल एंड कंट्रोलर ऑफ उदयपुर मेडिकल कॉलेज. मैं चाहता हूं कि आप सब भी उन सब ऊंचाइयों पे पहुंचिए जहां आपको एक स्थान खाली पड़ा है आपके लिए.
Yes, we all feel very proud of Vipin.
आदरणीय राय साहब, निजावन साहब, अमित सर, यहाँ उपस्थित सभी मेरे भाई, जयपुर आना, आप सब से मिलना और खासकर अपने गुरुजनों से मिलना हमेशा एक वापस घर लौटने जैसा अनुभव होता है. मैं 20 साल से अभी उदयपुर में हूँ. मेरा आरपीएससी में सिलेक्शन के बाद मैंने डिपार्टमेंट उदयपुर मेडिकल कॉलेज में शुरू किया था. दैट वाज इन 2004. ऑलमोस्ट 20 ईयर्स है पास्ट. अभी हम एक डीएम कोर्स भी रन कर रहे हैं गैस्ट्रोएंटरोलॉजी में. इनफैक्ट उदयपुर मेडिकल कॉलेज इज नाउ ब्लेस्ड विद डीएम एंड एमसीएच कोर्सेज इन ऑलमोस्ट ऑल सुपर स्पेशलिटीज. 5 बच्चे हमारे पास पढ़ रहे हैं अभी, और मैं अभी सुपर स्पेशलिटी का डायरेक्टर भी हूँ और प्रिंसिपल एंड कंट्रोलर भी हूँ. मेरे 2 डॉटर्स हैं और दोनों ही मेडिकोज हैं. द एल्डर डॉटर इज ड्यू टू अपीयर इन हर फाइनल एमडी एग्जाम इन रेडियो डायग्नोसिस एंड द यंगर डॉटर इज टेकिंग हर फाइनल एमबीबीएस एग्जामिनेशन. तो वो एमबीबीएस में फाइनल में और वो एमडी अभी खत्म कर रही है अपनी. इन एडिशनल आई शुड टेल, मेरी यंगर जो डॉटर है वो नेशनल शूटर है 10 मीटर्स एयर राइफल में. और
पत्नी के बारे में बताइए.
मैं भी जो है वो ट्रैप शूटर हूं एंड आई एम रेनाउंड शॉट. सो ये मेरी थोड़ी एक्स्ट्रा करिकुलर एक्टिविटीज है.
और हॉर्स राइडिंग भी तो है यार.
सर है. मेरी वाइफ डॉक्टर अंजलि माथुर अभी प्रोफेसर एंड हेड है डिपार्टमेंट ऑफ कम्युनिटी मेडिसिन की आरएनटी मेडिकल कॉलेज में. मेरा बैच 2000 वाला है, डॉक्टर महावीर और डॉक्टर नीरज के बाद का. एंड मेरे जो साथी बहुत ही प्रिय साथी डॉक्टर ललित शिम्पी, वो कल तो यहाँ थे, आज नहीं दिख रहे मुझे।
He has left actually. He had a flight.
He
some
had a
work.
flight and he is not here, but we had an excellent time here. मैं आपको, आप तो, क्योंकि मैं बोली ऐसी जगह पे रहा हूं जहां आप सब लोगों ने इसको खुद ही स्वयं अनुभव किया है, जो मैं आपको कहने जा रहा हूं। एसएमएस मेडिकल कॉलेज में खासकर गैस्ट्रोएंटरोलॉजी विभाग में जब हम आए 2000 में, तो कई तरह के दिमाग में चीजें, नए जो स्टूडेंट्स आते हैं उनको चलती है कि कैसा होगा, क्या होगा। लेकिन हमारे जो गुरुजन जैसे किसी एक पौधे को, एक बीज को पानी दे करके और पौधे को पानी दे करके उसको एक वृक्ष के रूप में खड़ा करते हैं, इस तरह से हमको स्नेह मिला। न सिर्फ हमने गैस्ट्रोएंटरोलॉजी सीखी, बल्कि जीवन में कैसे चलना चाहिए। अगर आज आप, अगर मुझे प्रिंसिपल एंड कंट्रोलर बनने का श्रेय देते हैं, तो ये मेरे इन गुरुजनों की ही देन है, जिन्होंने मुझे हाथ पकड़ करके जीवन के रास्ते पे चलना सिखाया।
हम लोग एक्चुअली लैब में साथ खाना खाते थे। मैं इसको इसका खाना नहीं खाना चाहता।
विपिन का खाना इतना अच्छा
बहुत ही स्वीट मेमोरीज हैं। डॉक्टर निधावन साहब, आप जानते हैं, ही लव्स गुड फूड एंड ही इज आल्सो अ कॉन्नोसेयर ऑफ गुड वाइन। तो सर के ये शौक जो है वो है, हम भी खाना साथ खाते थे। तो आप ये देखिए कि अपने गुरुजनों के साथ में खाना खाना, वो भी एक कितना बड़ा, एक बहुत ही बड़ा एक हमको जो है वो सपोर्ट था। हाथ पकड़ करके काम कराना, सिखाना, समझाना, डांटना, सभी। मुझे अभी भी निजावन साहब की बहुत भारी आवाज है, अपन सब जानते हैं। इन माई ड्रीम्स आई हैव सेवरल टाइम्स अवेकन अप राइट इन द मॉर्निंग लिसनिंग हिम विपिन, इधर एकदम खड़ा हो, सर, यस सर। तो ये खूबसूरत रिश्ते हैं। और जैसे डॉक्टर राय साहब, मुझे एक इंसिडेंस याद आता है। अब मैं सर 2 मिनट और ले लूं?
आप प्रिंसिपल हो, आप ले लो यार।
तो प्रोफेसर, मेरे जो रियल अंकल हैं, वो यहाँ पर बैंक के अंदर, ही वाज चीफ जनरल मैनेजर एंड ही हैड सम वर्क, डॉक्टर, वी हैड सम वर्क विद हिम। कुछ हमको, हमारे उनसे कुछ चाहिए था, कुछ एड वगैरह चाहिए था। तो मेरे अंकल मिलने आए प्रोफेसर राय से, तो मैं उनको लेके गया डॉक्टर राय साहब के चैम्बर में। वो मिले, बात हो गई सारी। देन व्हेन ही वाज वॉकिंग अवे, प्रोफेसर राय, ही accompanied हिम टू हिज कार। वो नीचे तक आए अंकल को छोड़े, जबकि वो अंकल उनसे उम्र में छोटे हैं और जानते भी हैं उस चीज को। मैंने कहा सर आप बिराजें। तो उन्होंने मुझे एक चीज कही कि हमेशा इस चीज का याद रखो कि जिसकी जो हैसियत है उसको उतना पूरा सम्मान दो। तो ये छोटी छोटी बातें जीवन में बहुत काम करती हैं। और मैं आप सबसे भी एक अनुरोध करता हूं, आप सब लोग, ज्यादातर लोग मेरे से उम्र में छोटे हैं, कि अपने इस गुरुकुल का जो एक डिग्निटी है, एक जो आपस में बॉन्डिंग है, उसे हमेशा बनाए रखें और आपस में कनेक्टेड रहें। जैसा कि अभी डिसाइड भी हुआ है कि वी ऑल विल मीट एनुअली हेयर ओनली इन आवर एल्मा मैटर। वी आर लेस टू नन। बड़े इंस्टीट्यूट्स हैं, वो अपनी जगह पे हैं, वो अपना काम कर रहे हैं। आज हमारे भी यहां से निकले सभी स्टूडेंट्स ने ये प्रूव कर दिया है कि दे आर सेकंड टू नन। आप सब लोगों को मैं पुनः बहुत बहुत बधाई प्रेषित करता हूं। सबका धन्यवाद।
Thank you very much. Next batch. आओ दिनेश जी, आओ आओ।
ईश्वर को मानिए। मैं बहुत ज्यादा पूजा पाठ नहीं करता हूं, लेकिन एक शक्ति है जो शायद को चला रही है, हमें मानना चाहिए। और चैरिटी करते रहिए, चैरिटी बहुत जरूरी है, आपके मन में शांति बनी रहेगी। कुछ समय के बाद, एक लंबी प्रैक्टिस होने के बाद बहुत से प्रेशर्स आएंगे। चैरिटी करिए, थोड़ा आध्यात्म की तरफ भी जाना चाहिए। मुझे नहीं पता, सर के विचार में जानना चाहूंगा क्या है। हम सब लोग हैं, आप में से बहुत से हमसे जूनियर हैं, मेरे सीनियर्स भी यहाँ बैठे हुए हैं। हमसे जो बन पड़ेगा, आपकी कभी भी जरूरत होगी, जो भी सहायता बन पड़ेगी अवश्य करेंगे। हर फील्ड में, जरूरी नहीं है कि सिर्फ गैस्ट्रोएंटरोलॉजी में, किसी भी प्रकार की और सहायता की जरूरत हो, सर ने ऑलरेडी ये बात कह दी है, हम लोगों की तरफ से भी और कहीं भी। मुझे लगता है कि ये एक बहुत बड़ा हम लोगों का कुनबा हो गया है, और इतने बड़े कुनबे की स्ट्रेंथ कितनी होगी ये आप सोच सकते हैं। सो अगर सब लोग इसको एक कुनबे की तरह ट्रीट करेंगे तो फिर मुझे लगता है कि हमसे कोई नहीं जीत सकता है। तो हम सरकारें बदल सकते हैं।
नहीं,
तो
निर्विरोध आते हैं, ये दोनों यहीं बैठे हैं।
तो इस तरह की चीजें हैं, बहुत सारे हैं, और छोटे भाइयों को भी मौका देना है। मेरे बाद जो भी हैं आ जाएं, जोशी
गणेश,
जी।
बच्चों के बारे में, पत्नी के बारे में बताओ।
हाँ, तो मेरी वाइफ पैथोलॉजिस्ट, मैं आगरा में सेटल हो गया हूँ, पिछले 20 साल से वहाँ प्राइवेट प्रैक्टिस कर रहा हूँ।
एक और अच्छी बात आप सब भी सीखेगा कि जब तक आप अपनी ईगो को शांत नहीं करेंगे, ईगो को थोड़ा कम नहीं करेंगे, आप अपने दूसरे लोगों को साथ लेके नहीं चल सकते। दिनेश has set an example of having 4-5 people working with him in the same institution, और सब लोग मिलके बना रहे हैं।
पिछले 10 साल से हम लोग एक ग्रुप प्रैक्टिस कर रहे हैं। पहले 3 लोग थे, अब 4 लोग हैं, और मुझे लगता है कि नए लोगों के लिए बहुत ज़रूरी है। किसी को भी इसके बारे में कुछ कभी विचार करना हो, कुछ डिस्कशन करना हो, आई एम ऑलवेज ओपन टू दैट। उसका कोई मुकाबला नहीं है इन एवरी सेंस, बी इट फाइनेंशियली, बी इट कंफर्ट लेवल, वट एवर। सो उसके बारे में सोचिए, उसमें कुछ चीज़ें हैं जो आपको सेक्रीफाइस करनी पड़ेंगी, बट मुझे लगता है कि जो गेन्स हैं ये मच मोर देन व्हाट यू सेक्रीफाइस। आ जाएं जोशी जी, आ जाएं। अच्छा, मेरी वाइफ एक पैथोलॉजिस्ट हैं, शी इज़ रनिंग ए पैथोलॉजी लैब, एंड आई हैव 2 daughters. One of them is doing MBBS at Agra only, and second one is preparing for NEET.
देहरादून में मिलवाया था ना, देहरादून में। Right. आशीष जोशी फ्रॉम बीकानेर। हाँ, पहले यही था। नहीं, वो शर्मा जी ने ब्रेक कर दिया उसको एक।
सक्सेसफुल गेस्ट
नहीं, ट्रू गैस्ट्रोएंटरोलॉजिस्ट, ट्रू गैस्ट्रोएंटरोलॉजिस्ट वही है जिसके 2 daughters हो।
शायद मैं इसीलिए अनसक्सेसफुल हूँ।
सर आप सर के वो डीएम के पहले हो गए।
Joshi ji is head of department at Bikaner Medical College, and he will.
I am professor in gastroenterology, Bikaner Medical College. My wife is also professor in ophthalmology, and son is doing MD from AIMS Jodhpur. Yeah, department mein we have started the DM courses. Now we are running 3rd batch. This is exam going batch, and 2 residents are there. So total 6 residents are there.
आशीष इज ऑल्सो ए टेनिस प्लेयर। और इसका बेटा भी अच्छी टेनिस खेलता है। तो मैं जब भी बीकानेर जाता हूँ तो टेनिस का रैकेट,
वो मैं वही बता रहा था। जैसे ये प्रैक्टिस करते हैं, कई बार बहुत ज्यादा थक जाते हैं, तो शाम को जब थक के कई बार बहुत हेडेक वगैरह सब होता है, तो दिमाग में एक बात याद आती है सर का, निजाम सर का एक शेड है। एक बार बीकानेर आए थे सर, कोई कॉन्फ्रेंस, वन डे की कॉन्फ्रेंस के लिए, मेरे को फोन किया कि मैं बीकानेर आ रहा हूँ। मैं कहा सर ऑलवेज वेलकम। शाम को सर, रात को आए, करीब 8 साढ़े 8 बजे उतरे
कोर्ट पे,
तो सीधे वहाँ मेरे को घर के बाहर ही रोका कि यहाँ से सीधा टेनिस कोर्ट चलेंगे। वहाँ टेनिस कोर्ट गए, रात को 2 घंटे टेनिस के लिए। मैंने सुना यहाँ गोल्फ
What
तो
will
मैंने
I
कहा सर
find? I will
बीएसएफ का
find
है,
the liver.
सुबह 4 बजे मैं वहाँ जाऊँगा।
And what
तो
was
मैंने
this
डॉक्टर
liver? Left lobe or right
ऑर्थोपेडिशियन उनको
lobe?
फोन किया, मैं कहा हमारे सर आए हुए हैं,
Left lobe.
तो ही इज
So
इंटरेस्टेड इन
simple thing is,
गोल्फ।
you are here.
नो प्रॉब्लम। सुबह 4 बजे सर
And in
गोल्फ कोर्स
between,
पे थे,
once you find, you are
4
finding
से
this is
लगा
the
के
inferior vena
7 बजे तक
cava,
गोल्फ पे,
which is
9
going
बजे सर वाज देयर फॉर
spirally.
लेक्चर ऑन
What is
पैनक्रेटाइटिस।
spiral?
4 घंटे लेक्चर चला, डिस्कशन चला।
In
दोपहर में
esophagus,
सर
in
बिजी थे
stomach
फॉर
is posterior.
साइट सीइंग एंड ऑल दिस।
IVC
इवनिंग में
in
सर
stomach
वाज
is
ए सिंगर
posterior structure.
एंड डांसर आल्सो।
IVC in mediastinum is anterior structure.
So
And it is this IVC,
प्राउड ऑफ यू
as
सर।
it is passing through the
जब कभी भी
liver,
प्रॉब्लम होती है,
that
कभी
it
सोचते हैं तो
becomes an
सोचते हैं सर
oblique
इतना काम अभी
structure,
कर रहे हैं
curving
और
structure,
अपन थोड़े से काम में भी थक
and
रहे हैं,
the
तो सारी
upper
थकान
part
गायब
of
हो
this
जाती है।
IVC
कभी भी ऐसा सोचते हैं कि यार
here
ये ज्यादा हो गए
is
पेशेंट।
anterior
सर का वो भी डायलॉग याद आता था, सर कहते थे कि सर को कई
and
बार
the
आर्टिकल
lower
देते, सर
part
कहते
of
हैं
this
यार मैं इसको करेक्शन
IVC
करके दूंगा,
is
लेकिन कब करूंगा
posterior,
जब
and
व्हेन
this
ही
is
वाज
the
गोइंग टू हिज होम,
spiraling
तो रास्ते में
part
गाड़ी में
of
बैठ के उसका
IVC,
करेक्शन करते। और
which
कई
is
बार कहते हैं
going
यार मेरे को
through the
नींद का टाइम
liver.
डिस्टर्ब हो
And
जाएगा,
this is
क्योंकि
the,
नींद भी सर
so
उसमें ही लेते
once
थे
you are
गाड़ी
in
में।
the, I follow,
एसएमएस
suppose
से
you
घर
want to
जाते थे,
follow
वो नींद ले लेते थे,
IVC,
वहां
once
जाते
you
फिर पेशेंट
follow
देखने
the
स्टार्ट करते
IVC
थे।
by this, you are seeing posterior. So you started from stomach, from esophagus at 33 centimeter. You saw the heart. This is the anteriorly placed structure. And then you push into the stomach directly, you will find the liver. And as you rotate, you will find the spiraling structure going through the eye. So this is the preliminary. You are in esophagus, you are in stomach, and once you are in stomach, what do? You have gone 2 ways. I am now seeing the right lateral part of from the stomach. This is the left anterior part of the stomach, because through the liver I can see the heart. This is the right lateral part of the stomach. Why do we say that? Why this is right lateral? Because I am seeing the hilum of the stomach. So this is anterior part. In esophagus scope is now lying seeing. This is the right lateral part. And if I rotate it further, this is the spiraling IVC. And if I rotate it further, I will find the aorta. And the aorta is posterior to the stomach. Your rotation has transferred it from anterior to posterior structure. Once you are here, suppose you decide to rotate it further like this, you will find this liver once more. Okay? So what I mean to say is that you can rotate your whole body. Suppose I want to fix your hand and start from imaging from here and move up like this and move my whole body like this within the scope, you will come to the same position. So these are the principles of imaging from the top. Yeah. So now in this case, we are supposed to find out where is the pancreas. So now I rotate it here, I rotate it here, and what I want is now to find the aorta. This is the aorta. What is special about this aorta? Right now, there is a gap between the aorta and the stomach. Why there is a gap? If I apply color Doppler here, you will find out that this is aorta, this is having color. But this aorta, when I was in the stomach, was running very close and parallel to me. Parallel to me. Why this aorta is no longer running parallel to me? Can anybody think? Do you think the aorta is running parallel to you? And do you realize that in this case, there, arrow. In this case, these are the intervertebral disc, and this is the spine. This one is spine, two is spine, and this is the aorta running parallel to you. It is slightly slanting away. Let us see what will happen if we were to follow this aorta higher up. Do you notice the atherosclerosis in the wall of the aorta? This? So let us say you pull it back, and you see it is running parallel to you. Will it run parallel all the way till I remove the scope, or will it stop being running parallel? What will happen? It will become an arch. And right now, when I am pulling it here, you see this line is sliding up and down. Do you see this line sliding up and down? Why is this line sliding up and down? Because this line indicates that the sound waves are going through aorta, reflected by the pleura, and at the time of reflection, some of the sound waves are entering into the alveoli, and within the alveoli, they are reverberating, and they are producing these artifacts, which artifacts you can see this, they are known as lung rockets. And you can count that these are the lung rockets in this present. These are the lung rockets. These are the lung. This is the lung rockets. You can find out there are many lung rockets. The lung rockets, because this is reverberation within the pleura. So the pleura is moving up and down. Not only the pleura is moving up and down, it is seen as a white line. At some places, the sound is able to penetrate into the lung. And when it enters into the lung, it creates the reverberation artifact in the form of lung rockets. But that is not the only thing. There is one more thing. You find two aorta. Why there are two aorta? Why there is an aorta parallel to aorta? This is the mirror image artifact of aorta. Because the sound that is reflected at the first surface is creating a mirror image of aorta. So we understood three things. Now what will happen if I pull this aorta all the way further? This aorta will start becoming rounded. And let us see, the mirror image of aorta is more prominent. And once it comes, it arches. This is the area where it is arching. So once I am following it from below, and I am finding it is arching, on the top border of the arch, can somebody put the finger on the top border of arch there? Put your finger on the top border of arch. Yes. So if I rotate it right now, what do you expect to come out from the top border? This aorta has become rounded, and from this top border, you will expect a vessel to come out. And the name of that vessel which is coming, joining it here right now is Cyst. See, I am rotating left subclavian artery. And you rotate further, there will be left common carotid artery. And then, so this is the way. So basic principle is follow one structure.
Right angle.
No. We are following from the left now. So first will be left subclavian artery. Then will be left common carotid artery. And then there will be brachiocephalic trunk.
So anteriorly we turn clockwise and we'll find right.
When we are following from the border of arch, descending aorta, the first vessel will be left common carotid. When we are following it from the ascending aorta, the first vessel will be brachiocephalic. Okay. Now we are going into the stomach muscle. So we started following the aorta. Once we start following the aorta, we want to find out why is this aorta going away now. It was running parallel to you because that is what aorta does. In esophagus, it runs very close to the esophagus, but as soon as it enters the stomach, in the below the diaphragm, esophagus, the aorta goes away from the gut, and in between the stomach wall and aorta, what is the structure that comes? What is the organ that comes to lie between them? What organ will come here? Pancreas. And that is why it is slanting, because we are now seeing the stomach bed. When we see the stomach bed, several important things are that this particular structure, aorta, you will be finding a vessel. You will be finding a vessel taking origin from the anterior border of the aorta. And it is at this particular place where the vessel takes origin that the black fiber will end, and that black fiber will be the remove color. That black fiber will be known as crux of diaphragm. So where is the crux of diaphragm? If I were to enlarge the depth and show you. Now, can you freeze? Can you show me the crux of diaphragm? Put your finger. No. This black line. This black line, and this black line, the place where this black line enters is the place where the celiac artery origin takes origin, And what is the vertebral level of that celiac artery origin? T12. Okay. So once we have identified that this is where we are going to identify, this is where we are going to inject in this place the celiac ganglion for the celiac ganglion neurolysis. But first let us identify what lies below in the pancreas. I go, no, Arif. We are not, we will get it. So what happened? I went into the stomach bed now. I am doing posteriorly. I was seeing esophagus so far. I am in stomach. I followed the aorta. And once I followed the aorta, I am finding three black structure. In the three black structure, one of the structure is a very naughty structure moving too much. The second structure is rounded, though this is rounded but moving too much when I move my body. The second structure is not moving too much, it is more or less fixed, but it is still moving. And the third structure is had got an irregular line. So if I were to ask you what are these three structures before I apply color Doppler in them, that what are the three possible structures?
Splenic artery.
Which one is the splenic artery?
Too much is splenic artery.
Too much is splenic artery, because the splenic artery is the most tortuous artery of the whole body. And the splenic vein lies behind the pancreas. So imagine the splenic artery lies here and the splenic vein lies here. The splenic artery keeps on flirting with the top portion of the pancreas, and the splenic vein lies behind the body of pancreas. In this case, something is happening. They both are coming as if there is. If I were to now imagine that this particular place, trace कर सकते हैं इसमें नहीं कर सकते trace. Measure करने measure कर. So I will now try three boundaries. This is one boundary, one set. Enter. Then this is second boundary, set. Enter. And then this is third boundary, set. Enter. So this is a pyramid. Imagine this pyramid where the pancreas is acting as a pyramid. The splenic artery is at top border. The splenic vein is behind the pyramid, and within the pyramid at 60-40 lies the pancreatic duct. What is 60-40? Because this is a pyramid. What is the central part of pyramid is not midway. The central part of pyramid is a little below midway of pancreas. That is why the pancreatic duct lies within the substance of pancreas, not in the middle of pancreas, and the substance of pancreas lies in the pyramid a little below midline. Okay. So in this case, what is happening is that the pyramid tip is sort of absent, and I start wondering what happened to the tip of the pyramid. Or so I rotate this pancreas, right? And then I keep on rotating, and I find that this pancreatic duct, which by now I feel is the colorless pancreatic duct, is going into many branches. These are going into many branches, and then these are the branches, and this pancreatic duct and splenic artery and splenic vein are going all the way to the tail of pancreas. So why do you say this is the tail of pancreas? Because at this particular point, this is the pancreas, this is the splenic hilum. And at this point, this is the splenic hilum, splenic artery and splenic vein. And at this point, the splenic hilum is there. And then this is the tail of pancreas. So you see this pyramid evolving. You see this pyramid. Do you see this pyramid? I would like to increase the frequency by higher frequency. Maybe you can appreciate the pyramid more clearly and the duct within it and the branches of the duct within it. Okay. Now this is the pyramid of the pancreas. Now what this pancreas, which part is the body and which part is the tail? So before telling you which part is the body and which part is the tail, let me tell you which part is the head and which part is the neck. So as I rotate here, this pancreatic duct, which is dilated here, at this particular point, it converts into a mass. This mass is probably intraductal because at this particular point, this mass is spreading, seems to be spreading in an irregular manner within the ducts of the pancreas. And this is again a dilated part of the pancreatic duct into which this mass, this all pancreatic duct. So I find a relatively dilated pancreatic duct, which in the middle part of body is replaced by a mass, and which in the distal part of the body is having dilated pancreatic duct because the mass is obliterating the lumen of the middle part of the. However, there is one part which is very strange so far. I expect when there is obstruction, the upstream duct to be more dilated than the downstream duct. And here is where the first clue of the possible disease is that the upstream duct is an obstructed duct. And after the mass, this duct is possibly a dilated duct because of the filling of the mucin secrete, mucin within the pancreatic duct. Okay. So now, as I was rotating it, I was keeping my eyes on two other black structures, that is the splenic artery and the splenic vein, so that I can follow. And this particular splenic artery that we will follow here, arrow. This will splenic artery will go into celiac artery. Splenic vein will merge with supramesenteric vein, and the pancreatic duct will fall from body of pancreas towards the head of pancreas. So these three things happen. So once we see here, this is the body, and we are seeing aorta, this is the body. When do we say that this body is becoming tail? As I rotate clockwise, as I was telling you, I was here, 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 and then further here. As I am rotating clockwise, the splenic artery, splenic vein are going away from me. So it is when I stop seeing this kidney, when I stop seeing the kidney, this is the kidney outline. And as I rotate, kidney will become upper pole. This point should be known as the body and tail junction. Do not think that the tail is like the tail of a lizard. No, the pancreas, body and tail are equally divisible organs. If body's head is 30%, body is 35%, and tail is also 35%. So the tail is divided into two parts. One is the intraperitoneal part, and second is the extraperitoneal part. Where exactly is the intraperitoneal part of this tail? So this is the tail of pancreas, which I rotate here. And it is the tail of pancreas. When it comes to the hilum of the spleen, this particular part is the intraperitoneal part of the pancreas, because this lies in the ligament known as lienorenal ligament, and the three structures lying within the lienorenal ligament are splenic artery, splenic vein, and tail of pancreas. So this here, when we see here, is lienorenal ligament containing the tail of pancreas. So this here, where I see the duct, some sort of duct here, this some sort of duct, and the large part of the duct disappearing, that will be the point where I will say that the pancreatic tail has gone. If I concentrate my eyes, this is the tail, and now this is gone. And this is the part where I see the splenic hilum. This is the lienorenal ligament. It is not gastrosplenic ligament. Gastrosplenic ligament is a different ligament. Lienorenal ligament is the intraperitoneal part of the tail of the pancreas. Okay, so we have assessed the pancreas, tail, body, or divided pancreas into body and tail. The body is further subdivided into two parts. One part is from the neck of pancreas to tuberomen tail, and the second part is from tuberomen tail to the junction of body and tail. Similarly, the head is divided into two parts, anterior head of pancreas and posterior head of pancreas, and the posterior head of pancreas is also arbitrarily divided into a suprapapillary portion and an intrapapillary portion within which lies the uncinus process. So why I am trying to classify so many parts of pancreas? Because start thinking of pancreas and different. So now we'll go now into the duodenal bulb, and as I said, I hate Parkinsonian movement, and I want you to again close your eyes, move down onto the left, down and to the left, inflate, don't move, and even with an endoscope, even with a EUS scope, even with a ERCP scope, learn to practice this movement where you hold it at 70 centimeters, close your eyes right now, push it in, turn, rotate, and turn to right. Gradually you will know that you are reaching the pylorus, 50%. If you practice in every endoscopy this movement, you will be avoiding Parkinsonism. I see. It's going, they will turn this, they will twist this, they will move right and left, now this, and bloody hell, they will spend 1 minute in reaching pylorus, because every part of body is moving to reach the damn pylorus. Okay. There is the only part of the body that you need to move in endoscopy and colonoscopy is that you are here at the junction, just beyond 40 centimeter, down and left. Inflate, don't move, close your eyes. And learn, please. Push, hold 30 centimeter, push, rotate, and move it up. So, Parkinsonism prevalent, the younger they are, the more Parkinsonian they are. Now, we'll go one movement. Now, I will insist on a panther movement. What I call a panther movement is you are supposed to enter the pylorus. You are not supposed to touch the right and left now. And you are not supposed to twist this. You are supposed to move your body. So, one movement, 15 seconds. Here. This is one movement that has pushed you in 10 or 15 seconds into just beyond the pylorus, into the duodenum. So your esophagus to stomach, 15 seconds. Right. Stomach, wait 30 seconds. Fundus to pylorus, 15 to 30 seconds. No Parkinsonian movement. And once you are in pylorus, you must learn to fix the scope. Because otherwise, if you don't know how to fix the scope, you will keep on doing all stupid movement. And the more movements you do, the more compromised you are in executing your therapeutic, in diagnostic way. Now what do I see? I am now in the duodenal bulb. One thing that I don't want to do right now is slip back. So when I turn to left, my turning to left means not turning like this. My turning to left means turning like this, so that I remain in duodenum. I don't want to slip out of duodenum. So right now, once I am in the duodenum, I see certain structures. And these structures are 1, 2, 3, 4. And again, I must find out before applying color Doppler to you, how many of you think which type of structure is what? One is a rounded structure. This one definitely should be an artery. This is an oval structure, can be portal vein, and this can be pancreatic duct. And as I rotate it clockwise, this pancreatic duct comes out like this. And as I rotate it anti-clockwise, this pancreatic duct goes into a mass. This is the mass that I have shown you from the stomach. And this is the mass. And this is the pancreatic duct going from body towards the tail. So I rotated this pancreatic duct like this. This pancreatic duct is full. I rotate it, and when I am rotating it here. So here, this is what I was seeing as a dot here. You decide this dot, when I rotate like here, this dot decides to move down in the form of gastroduodenal artery, and that is how you identify the neck of pancreas. Okay. So how much time we have left? So you cut celiac block is going to take only 5 minutes. So you keep on telling me, you feel is it over for you people? ज़्यादा तो नहीं हो रहा?
कुछ ज्यादा नहीं हो रहा.
Okay. So right now, so what has happened? We have come. So again, I must come back. Here, go into the rotate it here and rotate it here. Now I have identified. What do you see here? What do you see here? There you see a dot, and you see this dot seems to be pressing the vessel. This is a principle that, like you, I don't know how many of you as a husband are tamed husband, but a tamed husband is always compressed by his wife, and this is an artery or the wife compressing the husband, the vein, in such a manner that the vein is indented. So whatever is, however small, however tiny they are, they can manage to compress you. Do not go by their stature. Do not go by their size. Okay. The only thing matters is their arteries. And so long as it is the artery, they will compress the biggest of the vein, the mightiest, even though you may be 120 kg. Don't gloat, because no matter who. So this is an artery compressing the vein. And that is why I call it the indentation sign. Okay. So this is an artery and this is the vein. So once you rotate, this is the gastroduodenal artery and the vein. And right now the fine time has come to explain to you what is the vascular seagull. Because this vein, this particular seagull that you see here is a seagull formed by the vein. What is a seagull? Seagull has a body and two wings. Wherever two wings unite, you see two wings and a body, that is a seagull. And they are venous seagull, they are arterial seagull. This is the venous seagull. And the arterial seagull will be formed because this artery, hepatic artery that you have seen here, is coming from somewhere higher up. And if you can manage to rotate it, you can manage to see this is a hepatic arterial seagull also. But that we have not seen. I will concentrate now back on the, this is the arterial seagull. Yes, you can see. This is the freeze. So this is the arterial seagull. This is the arterial. And arterial seagull is smaller. It has two wings are up. One wing is the common hepatic artery proper. This wing is the gastroduodenal artery. And the central body is the common hepatic artery. And in this wing, the venous seagull, the wing going up is the vein, portal vein. Going down is the mesenteric vein, and this is the venous seagull. Okay, the upper is arterial. This will be any. Cannot show it so well, but I believe I have shown it in the last case that I demonstrated. Okay. Remove. Now we have come to we have demonstrated the pancreatic duct level. But where is the bile duct? I am trying to trace it. So how long?
D1 से D2 में कैसे जाए, मतलब how to avoid perforation?
Yes. So now we are seeing D2. How to avoid perforation. This is the trick. If you do a perforation, then can we have a bigger endoscopy picture? So now you are standing there. So you must learn how to go from D1 to D2. So I will come back again here. And as I said, right now, what I will do is move my body to the right. Torque the scope to the right. Move this right and left knob to the right. I am not moved forward. The first thing that I have done is, after reaching the D1 bulb, I have rotated, moved my body to the right, moved the right and left knob to the right, and torque the scope. This scope is screaming at me. I don't want to insult the scope. But right now you see, scope is screaming at me. But I don't mind it scream. Because I have seen people doing it like this, but I don't want to. I will keep L. I will not easily make a U of the scope. This is still an L of the scope. Okay. Now I can do three things. There are three ways by which I can go into the duodenum. Number one, remember, if at this stage I do a sudden movement, the tip of a scope, which is visible in this scope, will spring forward into this wall and cause perforation. That is perforation number one. So what to do? Keep on doing like this and learn. Just do this. Say faster. How many times? 10 to 100. But this will not achieve good result until and unless you shorten the scope from about 90 centimeter to 80 centimeter or 70 centimeter or 60 centimeter or 55 centimeter. So now you start reducing. How do you reduce? You must understand that this is, give me your hand, this is your hand. So if I reduce it by my ulnar aspect, this is my ulnar aspect. If your scope is like this, and I apply pressure on this ulnar aspect, you'll see like this. Now I am making a U of the scope. Way number one. But ulnar aspect should not be like this. Ulnar aspect should be, I am standing almost this way. So I did four things. Number one, I rotated the scope. I rotated my body. I rotated right and left knob to the right. No locking, no locking. And I started making a U of the scope. U of the scope. And the U of the scope with this direction. Not in this, with this direction. Second thing is right now, I must say that I find some people don't know what is a crisscross. A crisscross to me is a very vital movement in ERC. And what is so vital about crisscross? A crisscross is that this hand is fixed. And whatever you do, this hand will do the rest of the execution. Now see, this hand is fixed. I am moving my body like this, but this hand is fixed.
कुछ movement transfer नहीं होगा.
Whatever I do, so this hand is fixed, and I bring my hand between the scope and this hand. What happens? Many people, when they are here, they make the mistake of shortening and bringing the hand from outside. And as they move the hand from outside, they turn slightly to the left. And then they slip out. And then they cause the perforation, second type of perforation. So I said, this hand is fixed. And I am bringing my hand here. I am holding it here. If you try to do this, you cannot do this. How did I do this? I put my feet inside the table, I bent it, and I started bending so that I can bring my hand here. See how much I can bring my hand here now? But as I bend, I could bring my hand here. And then after holding it, I torqued it. But while torquing this, I kept on moving this up knob up. And then I torqued. Constantly moving up. So this is the second way to reduce. Okay? There is a third way, which I will tell some other time. So now once we have reached there, this is the second way. You must see if we can show you the fish eye papilla, which he wanted to show because it is a rarity to be able to see fish eye papilla. And this is a beautiful case. That is why he must be insisting that you must show the fish eye papilla. But if I cannot show, we'll try with a side view endoscopy. Now, wait a minute. Now, how to, even when you are in ERC, suppose you are doing ERC, how to come back You are in D3, how to come back? Rotate, stability, instability. Stability, instability. Stability, instability. Rotate back. When you are passing your cannula, keep on rotating this unstable, stable, keep on. And gradually, this movement will bring you higher up, will bring your scope higher up. Because right now we are seeing the third part of duodenum. This is the medial wall of the second part of duodenum. And we will see if the papilla is in the medial wall, if the papilla is in the higher here. This is again the third part, stable, slipping out. If you rotate too much to the left, you will slip out. And you will slip out again. I try to see it, I cannot see it. So I don't want to slip out, but maybe, yeah. Again here. Yeah, I was probably too deep, moving up. Am I in the duodenum? I slipped out. So the papilla is hidden. It is not be possible to see with this scope. So what I am going to now do is go here and enter the duodenum again with the third part. Here, entering. Here, turn, rotate, turn, not two, maybe. And critical point. There is a critical point. You have to push to the critical point. This is the critical point. And again, turn, rotate. And the third aspect, as I said, one is to make a U, move it in just by pulling it back. But at the time of pulling it back, make sure that you are moving the higher. And this I have gone now. This is the D2, D3 junction. Once I am in D2, D3 junction, I will keep my body to the right, pull it up, and now and US. Now we are here in the third part of duodenum, second part of duodenum, and now we are going to see this is the mesenteric artery and vein which we are seeing. And within this, now we are going to see the pancreas. This is the pancreas. The pancreas is seen between the scope as well as the body. So right now you see two ducts. One of the duct color which is going down is the pancreatic duct, and the one of the duct which is smaller going above is the bile duct. So they are sometimes called as snake eye sign, remove color, snake eye sign. But this is the pancreas. You rotate, you will see pancreatic duct. Now you start following the pancreatic duct like this and following like this, because bile duct has got nothing. And you find this is the pancreatic duct, you follow color, you see this is the tortuous pancreatic duct, color. Here. This is the pancreatic duct. I am following the code. And mind you, this pancreatic duct is not as dilated as I was seeing. So let us see whether the IPMN, which or tumor is filling the Santorini papilla, and whether this patient has got a fish eye papilla, mainly of the Santorini, and whether or not. Okay. Now that we will do later on. Right now, let us come back to how to do celiac ganglion block, and we fill the
D2 से एक बार एम्पुला दिखाएंगे.
हाँ, okay, D2 sample. Okay, so how to see D2 ampulla from D2 here? Color, remove color. Number one is to move it up totally. Number two, rotate it. Rotate it like this. Once you are rotating right now, in this particular place, you are seeing the psoas major muscle. You are seeing the superior mesenteric artery and superior mesenteric vein, which are crossing in the third part of duodenum, here anterior to the duodenum. This part is anterior and this part is posterior. Right now, I am touching this part. So this part of duodenum from 12 to 3 o'clock is anterior. This is medial. And in posterior middle wall, when I see the aorta and IVC, I expect the pancreatic duct and bile duct. So as I am rotating here, SMV, SMA, then here will be the aorta and pancreatic duct. But I must keep it totally up and rotate it like this, so that these mesenteric vessels become parallel. Now they are parallel. They were going, so they are sort of parallel. And when they are parallel, then between these parallel mesenteric vessels, I will find the anterior head of pancreas. This is the anterior head of pancreas. Whatever lies between the probe and the vessel, between the probe and to the right side is the anterior head of pancreas. And when I rotate it anticlockwise, you will find that this is the duct which is going in the intact of pancreas, and this is rotating anticlockwise. This duct is going toward the hypoechoic aorta. This is aorta. So when I see aorta and IVC, that is the point. Rotate it again, clockwise. This is the papilla. Now I am scared, but what is the time? This is the papilla, which is right now. Arrow is here. This is the papilla. This is the papilla. Right now, what I can do is, I can enlarge it, increase the depth, push in some water here, and in this water, now you will see that this papilla has got bile duct coming here and pancreatic duct coming here, merging into this papilla, whereas this is the muscular layer of the duodenum. This is the part where this muscle is present, and this is the papilla. No. And within this papilla here, this papilla, you can see that this, so this is the fluid within the pancreatic duct, the fluid within the bile duct, and this is the duodenal lumen. This is the muscular layer going like this. These are the ducts which are perforating the duodenal wall. And this structure is the papilla. The papilla does not have any tumor or malignancy. This is a normal 6 to 9 millimeter size papilla, which is the normal measure. The normal is 6 to 9 millimeter papilla. Set. Okay.
Coming to volunteers, like adenoma में देखते हैं ना तो अपन
This machine is, means I need to get better resolution of the machine. This I.
How to determine whether we
No,
can
so this.
do ampulectomy?
No. Ampulectomy is simply, see, in this case, suppose you ask me, can I do ampulectomy? Whenever there is a pancreatic dilatation, you cannot do ampulectomy. Because pancreatic duct dilatation is T4. Okay. Now, the question I had in this case was that this pancreatic duct is coming like this, then going like this, and that is what we want to follow. Going like this, turning like this, and now I'm moving it up, totally up. I don't want to slip out. And from this pancreatic duct, I want to see whether there is toward the duodenal wall, there is a dilated duct coming or not. And this pancreatic duct is becoming tortuous here. This is called cork-wise. I'm pushing. And then this pancreatic duct is becoming wider without any obstruction. But yeah, is this pancreatic duct proceeding towards, could not, again I slipped out. So I don't want to go into that. But as I said, if pancreatic duct on MRCP dilate towards minor papilla, it can be a minor papilla. It's a pancreas division, and more fluid is going toward the minor papilla. So this is a minor papilla leaking rather than a major papilla leaking. It is type 3 pancreas division. With type 3 pancreas division with IPM. Okay. Why is the communicating duct smaller than the main duct? So I am not able to trace. I can trace it from the bulb. This main duct I can trace from the bulb again. But
look like in the pancreatic head look like a side branch.
It's a side branch. That doesn't matter. Less likely, but I have opened up a possibility. Now that you should think. If you stop thinking, then you are. Now we'll come to the aorta. We have come back to the aorta, and right now in the aorta we'll apply color, and we'll find out that in this aorta there is a place where the celiac artery is taking origin. So I'm looking for establishing a triangle, and again I will measure. I will measure this area. So this is the wall of the stomach. This area from here to here, then from here to here, and then from here to here. And this the triangle made up around 2 centimeters on each side, into which I can inject, and in which maybe this black thing that I am seeing is a celiac ganglion. But this area is the triangle of gastrophrenic ligament lying between the stomach, the anterior surface of our aorta, above the celiac artery. Alcohol now, between 20, bupivacaine or bupivacaine.
Ready? Ropivacaine or alcohol? Yep.
In-
So we'll inject ropivacaine first and then
Then
alcohol.
then
ropivacaine. 5 ml, 10 ml, 5 ml. 5 ml ropivacaine, then 10 ml alcohol, 95%. And then
Alcohol
5
you
ml
want 10 ml, 20 ml,
to give the size.
20 ml.
20 ml.
20 ml.
So 5 ml ropivacaine, then 20 ml alcohol, then 5 ml ropivacaine last. 19. We want to give bolus of NS before injecting. Bolus of fluid.
Bolus of?
Fluid before injecting.
Yes, 2 liter fluid.
Hmm.
2 liter fluid, because there will be hypotension. No. So this is the triangle I am seeing. Now in this triangle, suppose this regular structure that I am seeing is a celiac ganglion block. But remember, yeah, one of the things that you must remember is, even in this triangle, there is a caveat. I will again measure. I don't want to inject into this crux of diaphragm. Because from here, I have shown you that this particular structure is the crux of diaphragm. So I want to remain anterior to crux of diaphragm, this line. From this line, I want to remain from here above the pancreas. And I don't want to touch the wall of the stomach. So I want to this triangle then becomes smaller. This becomes smaller. Now, in this case, I want to again identify what is the upper border of the pancreas. Fortunately for me, this upper border of pancreas is identified by one of the structures here, that this vessel which is going cranially, and is going merging into the celiac artery, and then you can follow this vessel is the left gastric artery. So I have to take care that I do not inject the left gastric artery. I don't inject the crus of diaphragm. I remain very particularly infected. So I have identified that the structures which are lying in this area, number one, this left gastric artery.
दो स्ट्रक्चर क्या है जो 12 up from
ये ligament, ये ligament. Oh, sorry, ganglion. They can be ganglion. There can be ganglion. See, they are nothing else but ganglion, because they cannot be lymph node. They cannot. So they are ganglion only. So I have to avoid this is celiac artery, and then as I rotate here from the celiac artery, I can say this is the left gastric artery. So, and this is the place where I saw. So now the question is, again, whether to inject here or here. Aorta, a large anterior surface. When I rotate a little bit to this side, I find not much of a structure. As I rotate, as I rotate here, I find the left gastric artery coming here. So this is the place where I have to avoid this crux of diaphragm. Okay, and this up I can reach up to this particular place. I will enlarge this depth more, and then see, because somewhere this ganglion is definitely lying above the pancreas. So it is into this area that we get. मुझे यहाँ से 3:30 निकलना है. नहीं हो गया. I think 5 minutes. 3:10, 3:15. I think I will. उधर पुरी साहब लगे पड़े हैं।
गाड़ी है, गाड़ी से जाएंगे।
अब तो गाड़ी से जाएंगे, नहीं हमें तो
आपकी तो फ्लाइट है ना,
हमारी तो फ्लाइट है जी।
नहीं
नहीं नहीं, हमारा काम हो गया, हम भी थक गए, हमारा भी पूरा जूस निकल गया, क्योंकि इसको पकड़े हुए 45 मिनट। नहीं नहीं नहीं, मुझे मेरी आंख, मेरी निगाह कि ना, मेरी निगाह घड़ी पे हैगी।
टीचर के आपको मन लगे टीचिंग में इसलिए।
एक काम करना आप, 5-7 मिनट मेरा लैपटॉप चार्ज करा देना, आपके कमरे में सामने वाले में रखा है, उससे कहना किसी से कि खोल के लैपटॉप चार्जिंग पे लगा दे। सामने काले बैग में मल्लेश्वर में लिखा हुआ है, सामने वाले रूम में। हाँ ठीक है। सो ये यहाँ पे इस एरिया में हमें इंजेक्ट करना है। ठीक है जी, चल रही है माधुरी दीक्षित का डांस चले जा रहा है। ठीक है, अभी तक कहानी समझ में आ रही है, ज्यादा भारी तो नहीं है, चल रहा भैया। The only thing is, because as I said, we are coming to the last. This is going to be the last for one reason. Because once you inject alcohol, you will not see anything in this view. So I have identified a point where I am going to take my needle here. But before taking the needle here, what to do? Number one, take it out. This is the needle. I am going to fix it. Take the needle out. Needle out. Feel it. Feel the needle passing out of the scope. Yeah. Then see it by moving the scope up and down. I move the up and down, no elevator up and down. Feel it. And then fix it. And then I am ready to bring my needle to this point. Maybe, because in this case I am finding artery here, maybe a little bit to the left in front of the leg. This is the point I can bring. Okay. But at this point, I will maximum tap. Maximum tap. No Doppler now. And I can try Doppler once. Okay, this is the point. And now, and at this time, sometimes it may be a good idea to reduce the gain and do some more image optimization and make the highest frequency possible so that you have the highest and make the overall gain less, because you want to see the black as black. You don't want to see anything else. You want to see just the needle. Now this is the needle. I will remove this. Isko nikal lo. Flush it with saline. I will move it a little bit down, flush it with saline, thoda sa, because I don't want air within the needle. Dal de. Dal de, dal de. Oh, I made a mistake. Why? What mistake did I make? My ears was touching the wall and I got distended. What doesn't matter in there. So, doesn't matter because you shouldn't have touched the and now I am going to push the needle inside. Here, single puncture. Did you see I went into the artery? How many noticed?
Yes.
Okay. Okay. So now
You can do it with a smiling face.
no, bro. No. See, I will tell you one thing. I will tell you one thing. Many people won't tell you that they were not and they were entered the artery. वो हमें पता लग गया, वो साला परफोरेशन कर दिया है ना. अच्छा, now aspirate fast. Whether now is the problem, because I will decrease the gain a little bit more to see if I can end. If I end, rotate the bit, whether I'm in the, but cannot. I think my needle tip is approximately here.
Yeah.
But if I have been having better machine, highest frequency, tissue harmonic imaging है इसमें मैंने, then I would have been able to find out here कि my needle tip is here. But doesn't matter. Aspirate. वापस खींचना. Yeah, I think I can see my tip here. What I will do is just to remove. I will remove. I will make it more darker. I'll decrease the gain even more. And then see if I can identify the tip there. Okay, cannot identify, but I'm in the right place. Now, I'm definitely beyond the dynamic range. Oh, dynamic range I want to decrease. This is the dynamic range I want it to, because my needle is at least up to this point. It is not in at least right place. This is what I wanted. There why I wanted it. Okay. Now, inject bupivacaine. What is it? Hmm? No. Inject.
Ropivacaine, not alcohol.
Inject. This is the last good
5
view.
ml. 5 ml देना है.
And he will have a lot of pain because तेरे हाथ टूट जाएंगे. तुझे कभी कभी ये होगा, घर वाली मर्दानगी पर शक होगा, ऐसे दुनिया वाले लोग बाग तेरा मजाक उड़ाएंगे, अबे क्या हो रहा. ये दुनिया वाले पूछेंगे मुलाकात हुई, क्या बात हुई. ये बात किसी से ना कहना कि मैं इंजेक्ट नहीं कर पाया था. अरे ओ सुन, तूने कुछ नहीं सुना. मुझे नहीं पता था ये भी बैठी है यहाँ पर. नहीं जा रहा? Because then you should have been here, because your force of transmission was not here. तो तू अंदर आ जा, उधर खड़ा हो जा. इधर आ जा, उधर से खड़ा होकर डाल. आई एम सॉरी, मुझे पता नहीं था. आप इस बज़्म में आप भी होंगे, हमें मालूम था न था. ऐसे हालात भी होंगे, हमें मालूम न था, है ना. आप नाराज भी होंगे, हमें मालूम न था. हमने इंजेक्ट लगाना किया था कि अब अपना दिस विल टेस्ट, बिकॉज निडल इज 22 और 19 should not cross it, because नहीं. ठीक है इंजेक्ट. नहीं जा रहा. जा रहा है. नहीं जा रहा. ओके. यू इज द निडल ओल्ड और न्यू? न्यू है. समझ में नहीं आई बात. क्यों नहीं?
दिनेश को बुलाना एक बार. दिनेश
निकाल. बड़ा है. ओलंपस ले ले. हाँ तो निडल ब्लॉक. This must be an old needle that was reused.
Maybe.
मुलाकात किसी से. हो गया जी काम. ठीक हो गया.
जो हम सीबीडी ट्रेस करते हैं ना, जस्ट बिलो द जी जंक्शन, तो हर बार हेड तक को नहीं जाता. विच इज ओके सर. मतलब हाँ,
मशीन
नहीं
के
दिखता. हाँ, मतलब D1 से ही दिखता है वो.
नहीं. एक्चुअली हेड से ट्रेस करना आज भी मैं मानता हूँ, अभी भी जो या तो एरिएटा 850 हो.
हाँ.
ठीक है. इससे नहीं होएगा.
अभी तो ओलंपस में कोशिश करते हैं, मगर नजर नहीं आती.
ओलंपस को
नहीं आती.
इससे
वो पोर्टल वेन के नीचे तक दिखती है, उसके बाद फिर उसके आगे फिर नहीं दिखती है. कभी कभी दिखती है वो करने पर. ठीक है.
हेलो. हाँ जी बोलिए.
सही है.
हाँ बोल.
चालू